Good morning. I welcome you all on behalf of Bengal Society of Pediatric Nephrology, the West Bengal State Chapter of Indian Society of Pediatric Nephrology for this annual conference. I declare the conference open and ask the organizing secretary to start the proceedings for the day. Thank you.
So a very good morning and a very warm welcome to the much awaited annual conference of the Bengal Society of Pediatric Nephrology. So we have a series of intriguing lectures and interactive sessions all throughout the day, which we are sure that will keep you engaged all throughout the day. And what better way to kickstart the day than to have a series of oral paper presentations by fellows and postgraduate trainees. Uh, I would request the judges to come over the stage. Dr. N.G. Karhui ma'am, she is Associate Professor Senior Consultant in National University of Children's Medical Institute, National University Hospital, Singapore, and Associate Professor Department of Pediatrics in Yang Lo Lin School of Medicine, National University of Singapore. Dr. Mukta Manthan ma'am, she is the current president of the Indian Society of Pediatric Nephrology. She is the director professor and in charge of Pediatric Nephrology, Department of Pediatrics of Maulana Azad Medical College, Delhi. And Dr. Sushmita Banerjee ma'am, she is member Senior Advisory Council of the Indian Society of Pediatric Nephrology, associate editor of Pediatric Nephrology Journal. Currently, ma'am is consultant in Department of Pediatrics in CMRI Hospital and honorary consultant Department of Pediatric Nephrology, ICH Kolkata. So I would request the first presenter of the day, Dr. Orijit Nando, to come over and present his paper.
Good morning, everyone. I am presenting here our observational study titled Prevalence of Joint Hypermobility Syndrome and Constipation in Children Admitted with Urinary Tract Infection. Urinary tract infections are pretty common in pediatric population, accounting 3 to 10% in girls and 1 to 3% in boys. What is less recognized that certain modifiable risk factors like joint hypermobility syndrome and constipation may predispose a patient to urinary tract infection. JHS occur up to 39% and constipation can affect 30% of pediatric patient. The underlying mechanism is that the less muscle tone in joint hypermobility syndrome causes some autonomic dysfunction, which in turn affects bladder and bowel function that may predispose one to urinary tract infection. Joint hypermobility syndrome is a connective tissue disorder diagnosed by Brighton score more than equal to 6 or more than equal to 7 according to the age, sex and ethnicity. It is a 9-point clinical scoring system with a simple tool based on flexibility of thumbs and little fingers, elbows, knees and spine. Constipation often coexists with lower urinary tract dysfunction, and Bristol stool chart is a helpful clinical tool to assess it. Type 1 and type 2 denotes constipation. What is especially striking is that there is paucity of Indian data regarding this clinical triad of JHS, constipation and UTI. Our study aims to fill this gap. Our primary objective was to estimate the prevalence of JHS and constipation in admitted patient aged 3 to 12 years with UTI. And secondary objectives included to finding correlation between JHS constipation and UTI and to provide data for early intervention. We conducted this descriptive observational study at Apollo Multispeciality Hospitals in Kolkata for a duration of 1 year with a sample size of 46 children admitted with UTI diagnosed as per ISPN definition. Tools we used were Baton score for JHS screening, Bristol stool chart for constipation, urine analysis and cultures, blood tests including CRP and USG QB finding. Now on to the results. As you can see in the age distribution graph, among the total participants aged 3 to 12 years, mean age was 6.5 years around. Of them, 67% was female. By the history obtained from parents, constipation was found in almost 80% of children, but by assessing them with the Bristol stool chart, we get 43.5% of prevalence of constipation among those admitted children. Byton score more than equal to 6 was 80 in 84.8% cases at it, and if we take a cutoff of more than equal to 7, it was 60.9%. We got abnormal USG findings in almost 39% of cases in the form of urinary bladder wall thickening, urinary bladder debris, post-void residue and hydronephrosis. More than threefold elevation of CRP was found in 91.3% of cases. And the commonest UTI pathogen isolated was E. coli in 56.5%. Our study underscores a high prevalence of JHS and constipation in pediatric UTIs. The functional bowel issues combined with connective tissue laxity may make a patient more prone to recurrent UTIs. Girls exhibited higher prevalence in this triad, which aligns with the existing literature. We found substantial relationship of joint hypermobility syndrome, constipation and UTIs, suggesting that joint hypermobility syndrome and constipation may be an important risk factor for pediatric UTIs. So early recognition and management of JHS may help in not only preventing the UTIs but also long-term renal damages. Our study has got some limitations. It is a small, single-center, cross-sectional study, including only admitted UTI patients, which limits the generalizability. We could not assess the causality and for long-term follow-up. There was some observer bias in a Brighton scoring system, and bladder function was not tested rigorously. The constipation criteria was also not fully met, and lifestyle data were not evaluated. So from all the findings, we recommend that screening of all patients for constipation and joint hypermobility syndrome. Routine screening of all pediatric patients with Byton score, which is a simple clinical tool, is effective and valuable to detect JHS early, which may predict future urinary tract infection and bowel bladder dysfunction. Early multidisciplinary approach to manage JHS with like exercise, lifestyle modification, physical and biofeedback therapy may help to prevent all these conditions. We hope this study may help as a pilot project to conduct larger studies in India to establish more robust and stronger evidences. Thank you. I welcome any question if you have.
Just want to know what were the ultrasound findings in these patients. All of them must have been subjected to kidney, urinary, bladder ultrasounds. So
Most of the patients ultrasound KV was done, but not 100% of cases. And those we have done that, we found the most frequent finding was urinary bladder thickening. Then we got some urinary bladder debris finding, post-bed residue, and few of them having hydronephrosis also.
You could have included that in your analysis. And another question, that how did you calculate the sample size? Was there any sample size calculation done for the study?
By reviewing the literature, some 2-3 article I found, and there the prevalence of joint hypermobility was around 30 up to 30 to 40%, and based on that we calculated our sample size and came to 46 number by statistical method.
Thank you.
Just one quick question. How did you try to reduce observer bias? Did you try to?
In this case, some observer bias was there, as I was the principal investigator and also analyzing the data. If it would have been done by multiple blinded person, then the bias may have been reduced.
So the joint hypermobility assessment was done by one person, two persons, or?
Yes, I have assessed it clinically.
So just a single person. How many assessors were there?
Yeah, by the Byton scoring system, by doing the clinical methods I have
No, the
shown.
question is just one person did the Baton score or more than one person?
One person. In this study, madam, only I did the Byton scoring analyzed.
Did you look at whether the patients had a single UTI or recurrent UTI? And did that make a difference in your incidence of prevalence of hypermobility?
From history, I obtained that, but there was no documentary evidence in many of the patients. That is why I could not put in the analysis part. But I've collected data which one having recurrent UTIs, but documental evidence was not there with them.
And why do you think that your prevalence is so much higher than what you said the previously documented prevalence?
In particularly in India or in our part, this type of study with admitted UTI patient was not done, and we think this is a representation of the community. If we screen all the patient of this age group, in we will might get this much high number of prevalence in joint hypermobility syndrome. Thank you.
Thank you, Dr. Arijit. I would now request the next presenter, Dr. Anindita Nondi, to come forward and present her paper.
Thank you very much. Good morning, all. Today I'll present an initial report from Indian Pediatric SLE Nephritis Registry, highlighting how children from low and middle income country are presenting like India. I am Dr. Anindita Nandi on behalf of Pediatric Nephrology and Pediatric Rheumatology Division ICH presenting today. As we all know, childhood SLE is a chronic multisystem autoimmune disorder. Children often have more serious presentation is compared to adult, but unfortunately there is no data from low middle income countries, especially prospective studies. So with this in mind, Pediatric Lupus Nephritis Registry evolved with ICH as the nodal center, and they are actively recruiting patients since 2020. Presently, 10 centers across India are involved, and children less than equal to 18 years with diagnosis of SLE as per SLIC criteria with features of nephritis and biopsy-proven lupus nephritis are included. We did exclude patients with drug-induced lupus, mixed connective tissue disease, and those who did not give consent. As I mentioned, from 2020 till 31st July 2024, total 154 patients were enrolled. As expected, most were female. And in adolescent age group, none were there in less than 5 years age, and only 9 patients were in 5 to 7 years age group. Median age at the time of recruitment was 12 years, and nearly 2/3 of our cohort had lupus nephritis at the time of diagnosis of SLE. When we look at the renal manifestation, proteinuria was the predominant one, with most of the children had nephrotic range proteinuria. In hematuria, microscopic hematuria, most of them has microscopic hematuria. We also had edema, hypertension, and pyuria in more than 50% of the cases. Interestingly, 43% of our cohort had AKI at presentation, though most of them had stage 1, only few had stage 3 AKI, and 3 patients needed renal replacement therapy for AKI. So as we know, the lupus is a multi-system disease which is reflected in our cohort as well. Mucocutaneous manifestation was the most common extrarenal manifestation, followed by musculoskeletal, hematological, and neurological. We also had few cases of presenting with diffuse pulmonary hemorrhage. When we analyzed our immunological parameters, we found 96% were positive for ANA, but there are few patients who were ANA negative on multiple testing by immunofluorescence. But all had lupus nephritis on biopsy. But what we find, they did not have any, there was no difference in the clinical presentation in the ANA positive and the ANA negative group. As we know, dsDNA is usually present in lupus nephritis, which is reflected in our cohort with more than 80% patient having dsDNA positive. Low complements were found in 94% of children. And again, we did not find any difference in the mode of presentation in the low complement and the normal complement group. And 17% were APLA positive. None had any extrarenal manifestation, but 2 of them presented with thrombotic microangiopathy on renal biopsy. So what was the indication of the renal biopsy in these patients? Mostly it was proteinuria with active urinary sediment. 23% patient biopsied only for proteinuria, and there are few cases of AKI also. Renal histopathological classification showed mostly it was a proliferative lupus nephritis with followed by a combination of proliferative and membranous. And NIH activity chronicity indices were noted in 134 patients with median value of 6 and 0 respectively. So when we attempt to correlate the clinical presentation with various histopathological classification, we found that there was no significant difference in the clinical presentation in class 5 and class 3-4 lupus nephritis. But those who had membranous nephritis more likely to have proteinuria, and those with proliferative nephritis more likely to have acute active urinary sediment. So comparing our data with other cohorts were hard because others were mostly retrospective and all the parameters were not covered. We compared our data with the prospective registry from the Western world. It was almost same with some differences, like German registry showed they have more incidence of the hypertension, microscopic hematuria, and mucocutaneous manifestation. They also reported a high incidence of AKI, 61% in their cohort. So to limitation, definitely discrepancy in data collection, which is inherent property of any registry, was a limitation, and outcome of the data is still awaited. So in conclusion, lupus nephritis present in a significant number of SLE at or near diagnosis. Edema, proteinuria, and hypertension are frequently observed with a substantial proportion experiencing AKI. It is important to evaluate renal parameters beyond clinical symptoms because 10% of our cohort presented with subclinical nephritis. Compared to global registry, our cohort revealed both similarities and regional variation, suggesting possible genetic, ethnic, and environmental influences. So follow-up will help us definitely in optimizing the treatment strategy for children of lupus nephritis in our low middle income setup. Thank you so much. Thanks to team ICH, and especially I want to mention Dr. Sangjukta Poddar. Without her, this presentation would not have been possible. Thank you. Thank you, ma'am.
What were the average UP urinary protein to creatinine ratios and KFTs of these patients?
Yes, ma'am. We took proteinuria as 0.5 cutoff UPCR and significant in 0.2 as cutoff and 0.5. And average it was almost in 0.35 to 0.42.
And what about the EGFR?
EGFR, as I mentioned, it was.
I think I missed it. Sorry. No need.
Okay. EGFR values average was 90.2, but it was, I mean, low in proliferative group. significantly low in the proliferative groups when compared to the membranous group.
And you've analyzed the initial treatment part of these patients also?
Pardon, ma'am?
Have you, as of yet, analyzed the treatment part of these patients also? Like therapies
Yeah,
that you've
treatment
offered?
part, it is the part of the study. I have not presented that part, but definitely we are taking consideration the treatment part as well, comparing MMF and cyclophosphamide and rituximab, indication of rituximab. We are exploring that part. It is ongoing study, ma'am.
So I noticed that the male to female ratio is 1:3.
Three is
That
to one,
means
ma'am.
1/4 of your cohort are males. And that doesn't seem to be my experience. Can you kind of explain why 1/4 of your cohort are males?
No, it was 1:3, ma'am. Most of the patients were female.
But 1/4 are males.
What?
1:3 means 1/4.
1/4 was male. Yeah. Yes. That was our observation. Of course, there are multi-centric centers from other parts also involved, but this is our observation. We did get a 1/4 male in this cohort.
And you said that there were some patients who were ANA negative.
Yes, ma'am. 5 patients we got ANA negative.
Did you have patients who were totally serologically negative and only diagnosed based on their histopathology?
Yes, ma'am. These 5 patients, 3 were from outside centers.
So they had the other markers also?
Yes, they have other markers. In 2 patients, dsDNA was not mentioned, but mucokinases features was there. And definitely all patients had a renal presentation of nephritis. And other 3 patients, we did ANA, repeat ANA again with immunofluorescence, which came to be negative only.
Okay, and you have not mentioned extrarenal features here. This is, you have just
Yes, ma'am.
presented the renal findings, right?
Yes, I have mentioned the extrarenal features, ma'am. Maybe I was hurrying. So in 59%, it was mucocutaneous, which was the most common extrarenal in our cohort, followed by musculoskeletal, hematological, and neurological. And few patients, 4 patients were there who had pulmonary hemorrhage, diffuse pulmonary hemorrhage at presentation also.
Okay, thank you. Anything else?
Thank you, ma'am.
Thank you.
Thank you, Dr. Anindita. Now I would request the third speaker of the day, Dr. Rifa Khan, to come over and present her paper.
Good morning, everyone. So I am presenting a multi-center observational study that explored the genetic etiology of childhood cystic kidney disease. So background of the study, cystic kidney disease are a heterogeneous group of kidney disorders comprising about 7% of the children with ESKD as per the North American Pediatric panel data, and as per the Indian Pediatric CKD registry, it comprises about 6%. Early detection and diagnosis of the cystic kidney enables one to initiate nephroprotective measures, good blood pressure control, prevention of the UTI, fluid intake, and dietary intervention like salt restrictions. So the main aim of the study was to identify the genetic spectrum among Indian children with congenital cystic kidney disease, and second aim was to study the association of individual genetic variants with the clinical characteristics of the children with cystic kidney disease. It is a multicentric cross-sectional observational study with nodal center in the ICH Kolkata. The duration of study was 2 years, and we did the convenient sampling of 100. So the inclusion criteria included any children less than 18 years with observation of 2 or more kidney cyst in USG scans with unknown origin, any child with 1 kidney cyst measuring more than 1 centimeter with a history of cystic kidney disorder, any child with a proven genetic diagnosis of cystic kidney disorder, and typical presentation of the polycystic kidney disease. Exclusion criteria included children with single cyst without extrarenal manifestation, without familial renal or liver cyst, cystic tumoral process like nephroblastoma, and multicystic dysplastic kidneys. So the subjects was enrolled, demographic and clinical data was analyzed, lab parameters and imaging parameters were done and noted. We did sampling, DNA was extracted, and analysis was done by whole gene exome sequences. Reports were followed for pathological, likely pathological, and variant of unknown significance, and data was analyzed. So total of 113 children were enrolled with a male-female ratio of about equal 60:53. Age range was from 1 day to 216 months, and median age was 77 months. On analysis, pathogenic or likely pathogenic variants were 66. Variant of unknown significance was 30, out of which 15 was later reclassified as likely pathogenic or pathogenic, and not related variants were about 17%. So if we see this distribution of the whole data, majority of cases were autosomal dominant polycystic kidney disease, followed by nephronophthisis, and followed by ARPKD. Among the autosomal dominant polycystic kidney disease, PKD1 compromised for about 88% and PKD2 compromised for about 12%. The second most common diagnosis was nephronophthisis. If we see the data, non-syndromic, among the non-syndromic presentation, NPHP1 was the most common, and among the syndromic, NPHP4 SLS was the most common. And among the non-syndromic, INVS and NPHP4 also presented as non-syndromic nephronophthisis, and in syndromic, NPHP3 and Joubert. This shows the yield of the various genes. So in NPHP1, we got total 9 variants, and all of them were the pathogenic or likely pathogenic. And if we see TSC2, about majority was pathognomic, and only 20%, like one case we got that was later reclassified as pathogenic. In PKDH1 and PKD1, variant of unknown significance also formed quite a major part, like 30 and 35%, and pathogenic part forms for about 45 and 52%. This shows the kind of mutation spectrum that we found among our genes. So as we can see, majority of mutation was missense mutations among PKD1, PKD2, PKHD1, NPHP1 and TSC2. Only in Bardet-Biedl syndrome, the majority of mutation was nonsense mutation. This shows the phenotype and genotype correlation. The patient presenting in autosomal dominant presentation. So genotype was most common ADPKD followed by HNF1 beta, while in ARPKD1, majority was about 50% was ARPKD, and some or more genes was there like ADPKD, 17q deletion, Bardet-Biedl syndrome 1, and undetermined significance. In nephronophthisis, out of 22, 18 were nephronophthisis, and in tuberous sclerosis gene, out of 9, 5 had TSC gene mutation, which did not have hypertension, while CONT gene mutations all had hypertension. So our conclusion is phenotype, genotype are variable, fairly good in nephronophthisis and TSC, not that good in autosomal dominant and recessive polycystic kidney disease. The yield was variable depending on the gene. ADPKD and or ARPKD had a high rate of variant of unknown significance, and PKD1 has significant high rate of variant of unknown significance without any suggested hotspot. Hence, family study and clinical correlation to reclassify the variants are important. Thank you.
Hi. Can I ask what are the exact steps you did to reclassify the VUSs?
Ma'am, these genes were later reclassified. When we did the gene studies, we studied the genes, they were coming in variant of unknown significance. But then later with the studies, they were reclassified as the genes of either pathogenic or likely pathogenic.
So what are the steps that was taken to upgrade it? Why were they upgraded?
You know the process by which the change in the gradation was done? No? It's okay to say no.
It's okay, thank you.
Thank you.
In the, say the ADPKD or the HNF1 beta, which are autosomal dominant diseases,
Yes, ma'am.
what percentage had family history, parental involvement, and how many was sporadic?
Parental involvement was there, but when we did the genetic study, they did not came out as autosomal dominant, like PKD1 gene or PKD2 gene. The genetic makeup came out as HNF1 beta.
No, what I mean is, in these patients, how many had parents who were affected and how many were sort of de novo and
No, all three had, ma'am, parental affection, ma'am.
the HNF1 beta? And what about the ADPKD? They had parental involvement. They had the parents
ma'am.
also had cysts. What about ADPKD?
In ADPKD,
The parents, were they involved in all the patients?
no,
with
no, ma'am, not all
ADPKD?
the
No,
patients.
no.
But we did
you
not
have
study
an
the
idea about-
percentage. Ma'am, we
No, I don't mean genetics. I mean by ultrasound, presence of cysts or hypertension or stroke or, you
Yes,
know,
ma'am.
that kind of a family history. So how many patients with ADPKD had that kind of a family involvement and how many were kind of de novo with no known family involvement?
In ADPKD, ma'am,
Yeah.
actually we did not study the percentage, but as per my this thing, majority had the parental. Only 1 or 2 patients were there which did not have parental like affection.
Thank you.
Okay.
Thank you, judges, for this session. I am Dr. Shreya. I am going to be one of the MCs for today. Now, I would like to move on to our next session, which is case-based discussion on a child with increased frequency of urination. I would like to request Dr. Indu Surana ma'am and Dr. Amita Sinha Mondol ma'am to come upon stage and preside over this session. Dr. Indu Surana, she is a renowned consultant pediatrician at DBI Foundation and Research Center, Howrah. And Dr. Amita Sinha Mondol, ma'am, she is a consultant pediatrician in charge at Divine Childcare Unit, Kolkata. I would like to request our chairpersons to introduce our moderator, Dr. Shakil Akhtar.
Can you please put on the CV? Okay, so we begin this first session today, and the speaker and the moderator for this is Dr. Shakil Akhtar, who's the Associate Professor, Division of Pediatric Nephrology, Institute of Child Health, and he's also the Secretary of APNEI and affiliated to Institute of Child Health. So I would request Dr. Shakil to be on the dais, and our panelists for this session.
Yeah, Dr. Subal Pradhan, Dr. Sanjukta Poddar, Dr. Rana Shaha and Dr. Poonam Guha Vez. And the experts for the session are Dr. Jayati Shengupta, Dr. Subal Pradhan and Dr. Subhashi Shaha.
Good morning, everybody. So on behalf of BSPN, I would like to welcome you all for the first panel discussions. And in the next 45 minutes or so, I'll be taking you through the journeys of children with maturation disorders, mainly focusing on increased frequency of urinations, incontinence, and also touch upon polyuria because of the similar presentations with them. There may be times when these children come with a lot of puzzling questions and a lot of things to approach. So these puzzles will be solved by our distinguished panelists that we have today. May I have the privilege of inviting our panelist, Dr. Subal Pradhan. Nice name. So Dr. Subal Pradhan, Dr. Rana Shaha. Dr. Subal is from Odisha. He's a senior consultant pediatric nephrologist. Dr. Rana Shaha, senior pediatric nephrologist from Manipal Hospital. Dr. Sanjukta Pundar, she is our colleague, pediatric nephrologist, and Dr. Poonam Guha, who is a pediatric surgeon. And our expert today is senior consultant Dr. Jayati Sen Gupta, Dr. Subal again, and Dr. Subhashi Shah, our pediatric surgeon. So we all have can we start? So the plan is that in the first 45 minutes, we'll be doing the panel discussions on cases, and this will be followed by the algorithm, which will be discussed by our expert team today. So before we begin with our cases, let us first understand the language of the bladder. There are definitive symptoms which are descriptive given by the International Children's Continence Society. And when we talk about lower urinary symptoms, then it mainly involves the bladder as well as the sphincter, which together in a coordinated fashions helps us in micturations. So we broadly divide our lower urinary tract symptoms into storage symptoms, which is voiding, frequency, incontinence, nocturia, and urgency, what I call VNU. And there, on the other hand, there's the voiding symptoms, which includes hesitancy, intermittency, straining, weak flow, and dysuria. The way I remember is his weakness is dysuria. So coming to the frequency, the normal frequency beyond 5 years of age is usually 4 to 7 times per day. But if you have children passing more than that, that means beyond 8 times a day, it's called increased or high frequency, whereas in the lower part of it, if the frequency is less than 3 or less, it's called low frequency. Coming to incontinence, there is we say involuntary leakage of urine. It's called incontinence. It may be continuous, it may be intermittent, it may be daytime, or it may be nighttime, which we will discuss subsequently. Coming to polyuria, objective assessment of urine in 24 hours is very important to classify as polyuria, and urine output more than 4 ml per kg per hour or 2 liter per meter square per day is quantified as polyuria. Now coming to causes of these symptoms, when we consider increased frequency, UTI, overactive bladder, polyuria, constipation, stress, these are some of the things that we keep in mind high up the order, and then more sinister causes like diabetes, renal tubular disorders, and diuretics comes lower down. When we have children with incontinence, then it can be continuous in the form of some congenital urogenital malformations, or it can be intermittent in the form of UTI, overactive bladder, enuresis, constipation, stress again, and lower down the order you can consider diabetes and diuretics. When you have children suspected of polyuria, high up the order you should consider diabetes mellitus and diabetes insipidus. You can also consider primary polydipsia, renal tubular disorders, and lower down the order you can also think of metabolic problems. Now when you go through all these causes, you see there are a lot of overlapping symptoms, and also there are a lot of causes which may be overlapping, and this makes it very confusing, and sometimes a structured approach is very important to diagnose these children. Now with this basic information, let's move on to our first case. We have Sunny, who is an 8-year-old boy who came to us in the OPD, and the presentation was increased frequency of urination for the last 1 month. He was passing urine 12-15 times per day. Now my first question is to Dr. Sanjukta Poddar. Now what is your initial impressions, and what are the other points you would like to take in the history to elaborate the history to approach to a diagnosis, and what physical examination you would be focusing to look for a diagnosis? Dr. Sanjukta, please.
So coming to the case, this is a 8-year-old boy who presented with increased frequency of micturition for the last 1 month. So whatever is happening is for last 1 month. So if we come to the history, one should remember that a poor history is never a substitute for an examination and investigation. So a proper history, even in a busy OPD, is very important. So in this child, we should ask what is the duration of this increased frequency, how many times, what is the amount is like. Along with that, we should go for other history, other urinary history like urgency, hesitancy, any holding maneuvers like standing tiptoes or Vincent's curtsy, or any history of incontinence. The child, it is often very offending for the child to have incontinence. They may not complain it themselves, so the parents may not be knowing it. You should ask this history to the child. If a 8-year-old boy, he can tell his history himself also. Straining during micturition, then enuresis, that is bedwetting, and nocturnal polyuria. So nocturia and enuresis, these are different. One child who is waking up multiple times at night and going to pass urine in the loo is having nocturia. But if not having bedwetting, then he is not having enuresis. So you have to differentiate whether these things are there or not. And also if there is any poor urinary stream and recurrent episodes of UTI in the present. So this will give you history about any lower urinary tract abnormality also. Along with that, some other history, very important, is any history of constipation. That sometimes, most of the times we have seen in the OPD that the parents are not complaining that the child is having any constipation. Even on repeated poking, they may be telling that yes, the child is passing stool, going to pass stool 2 to 3 times. But even going to pass stool 2 to 3 times, maybe because the child is having very hard stool and unable to pass, so he is going multiple times. Also, if there is any fecal incontinence, you should also take history about the sleep cycles, whether he is having very deep sleep cycles, snoring, any features of obstructive sleep apnea. Family history is important because sometimes there are underlying stressor factors also in the family, as well as in the parents also having some problem. If a proper birth history, developmental history, these are also important. Some behavioral problems like the autism spectrum disorders, they have more chances of these kind of urinary symptoms. So these history are very important. Now if we come to the examination part, the child should be examined. The general examination is important. Any hypertension, features of dehydration, or any recent history of anorexia, and also any on examination if there is any wasting, which may be giving you clue that the child may be having some systemic disorder like diabetes mellitus. And then to coming to the urinary examination, examination of the abdomen and genitalia. The abdominal examination, you may be finding on palpation a fecalith, loaded colon, or a palpable bladder, giving you clue that there may be some underlying problem. And also on the genitalia examination, you should be looking for features of infection, inflammation, any abuse of in a girl child, looking for labial adhesion, all these things. And then coming to the examination of the spine and neurological examination, this is very important. Any history of past surgeries or any spinal problem, neural tube defects, these can give rise to specific urinary symptoms. So a thorough neurological examination may be important in this kind of children.
So what we understand is that the proper history is very important, and also the examination. What we miss out is examination of the genitalia and also the spine. So it's very important that has been focused right now. So coming to summarizing all the history and examination, what we found in this child was the child had urgency, the child had frequency, and also there was a significant constipations. But coming to parental history, family history, neurological history, and surgery, that was negative. What we found on physical examination, mainly abdominal examination, there was a lump which was suspected to have some fecaloma or fecal mass. Now with this basic findings, what are the initial investigations would you ask for? Dr. Rana.
So with this child who is having increased frequency of urine for 1 month and having some storage symptom, I would do a minimal invasive investigation in the form of like routine urine and culture, just to rule out any infection and look at the urine routine to any glycosuria and specific gravity of the urine. And also do a ultrasound of the KUV region just to look at the kidney, look at the upper tract, any dilatation, and also look at the bladder. What is the bladder wall thickness, and any post-void residual is there. And also elaborate history of bowel and bladder in the form of bladder diary, and that should be at 48 hours bladder diary. That will give us an idea about the voiding volumes and any associated urgency there. And the 7 days of the bowel history, that will give us any constipation and the degree of constipation.
So exactly for all micturition disorders, basically these are some of the basic informations that we want through the investigations: urinary, USG, and KUB, and also the bowel bladder diary. So we did urine examination that ruled out UTI, that ruled out diabetes and other things. In the USG was essentially normal, the kidney sizes were normal, no hydronephrosis, bladder wall thickness was normal, post-void residue was residual, was insignificant, and you had a transrectal diameter of 38, which is significant. So any transrectal diameter will give you an indication of whether the loadal stool is there or not, constipation is there or not. Beyond 30 millimeters is thought to be significant. So after that, we did a bowel bladder diary, and this was something that the parents had come with. So my next question to Dr. Subal. Are you there? So what are the informations that we get from this bowel and bladder diary, and why is it so important for all these children having increased frequency of urination to have this specific diary that will give you so much of information? What are the things you can derive from there?
So what do you call this? Non-invasive urodynamic studies that can be done, I think, practiced by any pediatricians. And look at the chart, the very simple chart. Look at the number of time he has voided, water intake, urgency, and stool pattern, right? So look at the number of frequency from the chart. So it is more than 7 times. So there is increased frequency of urinations. And look at the voided volume. You look at the expected bladder capacity as per the age in the year plus 1 into 30. So that is 270 ml. But voided volume very small amount, 90, 110, maximum 110 ml. And so there is increased frequency of urination and small voided volume. And water intake almost match the output. I think as per the 8 years, 1.3 liters intake and urine output 1.2 liters. So there is no polyuria. And also there is some lower intact symptoms like urgency. And also child is constipated, that has been reflected by the ultrasonography also. So from this simple voiding that you can say that there is increased frequency of urination, there is small voided volume, and there is symptom of lower tract with urgency and constipation.
So nicely said. So you can just see, just one chart can give you so much of information, and it's so non-invasive, and you can see so many points from here. So this child has a high frequency of urinations. This child had a smaller void volume, and there was urgency, and also there was a constipation, which we can pick it up from the Bristol stool chart, which should be there in your clinics when you're running a clinic like this. So now, what is the diagnosis, and what advice will you do for any further investigation you would want to do, Dr. Poonam?
Yeah, so with the finding of increased frequency and urgency, and as we have documented, the child is already having constipation. We have documented the increased frequency on the voiding diary. So diagnosis is clear in this child. This is an overactive bladder. So ICCS says no further investigations are actually needed. Only the urgency and increased frequency, there may or may not be incontinence. That is sufficient to say that is an overactive bladder. But there is another non-invasive investigation which is actually freely available that can be done in this child. That is a uroflowmetry. So can we just show? Yeah, this is a uroflowmetry on this child. This the child is asked to pass urine in a.
So just interrupting.
Yeah.
So if you have child who has a very clear-cut history and basic investigations and what we have seen in the bladder chart, so do we still need to do UDS, or do we still need to do uroflowmetry in all these children?
No other investigations are ideally needed. Only the basic history, the voiding, the bladder diary, it gives us the most important clue, and the history of constipation. All these given together, this is a case of overactive bladder. We do not need any other investigation, but if we have this sort of a uroflowmetry, it helps us convince the parents. Okay, see, this is the reason. The urine force is very high. There is probable overactivity. Basically, the parents need to be convinced that, okay, there is constipation that is causing all these problems. Right. So this convincing needs the evidences. So that is why we get all the investigations done. And also, if we are, suppose we have treated the child's constipation, still the symptoms are persisting, then also if we have some other investigation, it helps us substantiate, okay, we were thinking right.
Exactly. So history and examination will give you a lot of clues, but then if you want to facilitate the diagnosis in terms of counseling also, then this is something that you should be doing. At least uroflowmetry should be doing. That's what is your point you want to say.
Then
how do you manage this
curve,
child? Yeah. These are the children who comes very often. How would you manage?
Yeah. So management of this child would be, first of all, we'll have to manage constipation. In any such child, whether the history of constipation is there or not, but we need to manage constipation. We have to treat the child as having constipation unless proven otherwise. So we give him laxatives, we institute a proper bowel regime, and most importantly, the explanation, that is urotherapy, the first part of urotherapy is explanation. The explanation to the parents, explanation to the child, that what is the cause of the problem and how are we going to manage the problem. Because the parents come in with urinary problems, we ask them to manage stools. They get irritated that we have not come for these stool problems. The child does not have any stool problems.
In OPD, whenever you talk about stool, they will say we'll come for urinary problems, not for the stool. Then, so it's a very common question by the mother.
Then they switch OPDs, then go to somebody else. So it's better to explain to them properly, especially the child. Because the complaint is the mother asks the child to go to the and to the toilet. The child will say, I am not feeling like going to the toilet, why should I go? So explanation to the parents as well as the child is most important. Then explanation about proper fluid intake, proper stooling regimen. They have to sit 3 times a day to use the gastrocolic reflex, to have proper fluid intake throughout the day, and to use the washroom for to go to the toilet at specified intervals, so that they do not postpone micturition when at school. These are the common principles that have to be explained to all the children.
So counseling is very important, and parental involvement is very cornerstone of the therapy, and this urotherapy remains the gold standard. And sometimes we also use bladder relaxants.
Yes, bladder relaxants may be needed. Once we have treated the constipation properly, still the child is having symptoms. Then we can either go ahead with a UDS and then start bladder relaxants, or we can start bladder relaxants as it is, but before
So if you're starting, how long do you continue with the anticholinergics like oxybutyrin?
depending on how the symptoms are progressing.
Progressing.
Before anticholinergics, what is important is we have to see that there is no PVR. If there is post-forward residual, then these things are contraindicated. And also constipation gets worsened by the use of anticholinergics.
Right, exactly.
So these are two important things.
So we move on to our next case. Sonu is a 6-year-old male child. He's had similar symptoms of increased daytime urinary frequency for the last 2 months. He goes to pass urine every few minutes. There's no incontinence. There's no nighttime symptoms. The urgency is there, and he has joined a new school, and his stools are generally soft. So with this basic history, we moved on to physical examinations and history. There was no parental history, no family history, neurological history, surgery history was normal. There was a stressor in the form of joining a new school. Physical examination was essentially normal. And what we found overall is that the child had frequency of urination and only urgencies. So we did a urine examinations, which was essentially normal. USG KUB was nothing significant. And this was the bowel and bladder and bowel diary. What is the diagnosis? Dr. Poonam, can you again interpret this?
Yeah, this is the voiding diary in this child. Voiding diary shows there's frequent voids in this child to the tune of around 15 to 20 times in a span of 24 hours. And the voiding volumes are very small, to around 40 to 80 ml. There are few volumes of 5 and 15 ml also. So this is classical of polyuria. That is extraordinarily high daytime frequency in this child.
What we understand is the increased frequency and the volume of voids was very low.
Very
so
small
how does it
voids.
differ from the previous case?
Yeah, basically in the previous case, what we see, the children with constipation, this child, again the stool diary shows that there is no constipation, there is type 5 stools. So these children usually, the polyuria is differentiated from the other urgency symptoms. In this child will have only daytime symptoms, will not have any nighttime symptoms. Usually constipation is not associated. The parents will say that the child is passing urine every 5 minutes. Every 1 to 2 minutes the child is going to pass urine. That is usually not there in the other overactive symptoms. And also if the child is asked to postpone, okay, there's somebody there in the toilet, wait for some time, the child will keep on shouting, I want to go, but he won't leak in his pants. So this is one important point which differentiates this from the other urgency or overactive symptoms.
Okay, and the
another point
examinations
you
are
can
essentially...
differentiate, these children, if their concentration is taken away to a different thing, if they are allowed to do something which they'll be concentrating on, probably traveling, you will find that they are not passing.
So if they are distracted, they forget about their urge.
And these children do very well if you give them these rewards, telling them that if they don't pass for a certain time, you give them a reward.
Exactly.
And
So that is how we are coming with the management. I think, how do you manage these children?
Yeah, so in this child, usually the parents have to be told that there's nothing to worry. This is just an episodic thing that happens, usually lasts for 1 to 2 months, and then it disappears on its own. It tends to recur probably, it may recur the next year also. What we have to see properly is that whether the child is having any amount of constipation or not. Because these children, some of them do have constipation, and if we start laxatives and a proper bowel regime, again this polyuria also may, the increased frequency also may improve in a few kids. So only reassurance, and if there is constipation, that has to be managed.
So reassurance is the key factor here, and then the parent has to be explained properly. But avoid any medications. I think they don't need medications. These are benign, and with time they go off. So that comes to my third questions. This is a child who is an 8-year-old girl, comes with bedwetting. She usually wets bed 4 to 5 nights per week and was never dry at night. So with this basic information, what are the salient history, what are the focus clinical examination would you do? Dr. Subal, please.
So this is an 8-year-old girl, and typically she had 9 symptoms, night incontinence, so seems like nocturnal enuresis. So history-wise, we have to differentiate from monosymptomatic versus non-monosymptomatic nocturnal enuresis. So we have to look for the low intact symptoms, as discussed earlier, like storage symptom as well as voiding symptoms. Then look for the risk factors, developmental milestone in family history of enuresis. Also look for the history of comorbidity, like constipation, one of the important risk factors that need to be addressed before treating with other drugs. And look for the ADHD or sleep pattern, also cervical stress that can influence enuresis. Examination, as we discussed earlier, look for the abdominal examination, look for the constipations, look for the external genitalia, and look for any neurological cause. Look for the skull and spine.
So elaborate history and physical examination would give you a lot of clues to the diagnosis, and the summary of what the history and examination findings we had. Again, this child had only enuresis, and the rest of the findings of the voiding and storage were negative. But the child soaks the entire bed. There was no daytime symptoms. There was no history of constipation. Essentially, the development was normal. Abdominal examinations and genitalia was normal. Spine and neurological examination was essentially normal. So with this, what are the basic investigations will you do, Dr. Sanjukta?
So the basic investigations are same. First, urine routine examination. I would do a urine dipstick also. It gives a lot of clues like tell us about any infection, leukocyte externus test and the nitrate test, and also any glycosuria, how is the osmolality of the urine, and also urine routine examination followed by ultrasound KUB will give us an idea about any underlying constipation or any lower urinary tract abnormality, and obviously bladder bowel diary. That is very, very important.
So again, the same kind of investigations to start with, and then we have done these basic investigations of urine, which was essentially normal. There was no UTI, there was no glucosuria as well, and we did the USG of the kidney, and that showed it was normal. The bladders were normal, the post-void residue was insignificant, and transrectal diameter was also within the normal limit. So we have done the basic investigations, and the next we had ordered for a bowel and bladder diary by the family, and that is something what we have been presented with in the OPD. So my next question to Dr. Poonam again, like how do you interpret this diary, and what are the informations you want to extract from here?
Yeah, we have already discussed how to read such a diary. So first of all, we have to calculate the expected bladder capacity. This is again an 8-year-old child, so the capacity should be around 270 ml. Over here, we can see the child is passing urine around 6 times per day. Capacity.
Dr. Poonam, how do you calculate the expected bladder capacity?
Yeah, it is, we calculate as age plus 1 multiplied by 30. There are a few formulas which say age plus 2 into 30, but we usually follow age plus 1 into 30. So that is comes to 270. Over here, the voided volumes are around 150 to 300 ml. So this is normal voided volumes with normal frequency. So this child is actually not having any daytime problems. And again, the constipation over here, it's type 4 and 5 is passing twice. So there is no constipation also. So this fits in the diagnosis of monosymptomatic enuresis.
Exactly. So what we found is that this frequency, in terms of frequency, the frequency is normal. In terms of volume of void, that is essentially normal. And then what you see is a nocturnal kind of urine output. Could you comment on this? Like if you have 10 to 7 a.m., the child was sleeping, and overnight you had a kind of volume like this. And then the early morning, after waking up, the child had a volume of 240. So,
yes. So
if you calculate this, like it comes to, around 600 ml, which is definitely much beyond your expected bladder capacity, almost more than double. So it's been more than 100% of, 200% increment. So how do you classify this, the nocturnal urine output being more than 135%? You want to comment on this? So it's considered to be a nocturnal polyuria. We say nocturnal polyuria when the nocturnal urine output along with the first urine sample in the morning would be more than 135%. So this child, when it comes to frequency, it was normal frequency. When it comes to volume of void, it was normal volume of void. But if you look at the nocturnal urine output, it was a case of nocturnal polyuria. So this was a child having nocturnal polyuria, and your diagnosis, Dr. Subal?
So she was never dry before, so looks like primary enuresis, and there are no low impact symptoms. So this case is a primary monosymptomatic nocturnal enuresis.
So why do you say primary, and why do you say that monosymptomatic?
So as I've told earlier, she was never been dry before, and there is no low impact symptoms, like there are no constipations, no bowel bladder symptom, like no urgency, no hesitancy, or no storage or voiding symptom. So in that condition, we call the monosymptomatic. Any child having low impact symptoms is called
okay, we'll come to this as well. So it's a case of primary monosymptomatic nocturnal enuresis. And how do you classify nocturnal enuresis, Dr. Sanjukta, and what are the basic pathology that you see and why it's happening? What are the causes that you normally find?
So enuresis can be classified according to 3 parameters. One is depending on the frequency. If the weekly frequency, the child is soaking the bread more than equal to 4 times, then it is frequent, and if less than 4, then it is infrequent. Depending on the onset, if it is the child was never dry for more than 6 months, then 6 months or more, then it is primary. And if the child was dry for at least 6 months any time, then it is secondary kind of enuresis. And both this primary and secondary can be further classified as monosymptomatic and non-monosymptomatic. So monosymptomatic when there is no lower urinary tract dysfunction associated, and in the non-monosymptomatic there is associated lower urinary tract dysfunction, and often daytime symptoms are present in this kind of children. And coming to the pathophysiology, the very important is a line that mismatch between nocturnal diuresis and functional bladder capacity overnight in the presence of a deficient arousal from sleep. That sums up the whole monosymptomatic enuresis. So any child who is having any of the two, that is there is mismatch between nocturnal diuresis and functional bladder capacity, or there is a deficient arousal to sleep, can lead to a monosymptomatic enuresis, that is bedwetting at night. And other than that, you have to also look for any genetic predisposition. There may be a family history. Often we have seen one of the parent also having a history of bedwetting, and also there may be psychosomatic manifestations, behavioral problems, developmental disorders, and underlying constipation, abnormal bladder reserve function, bladder detrusor sphincter dyssynergia. So all these things are associated with lower urinary tract symptoms also. So you have to look for those things and differentiate between whether it is monosymptomatic or non-monosymptomatic.
So there may be plenty of causes here, but the key players, if you look at, is basically nocturnal polyuria, which is because of the lack of AVP and the reduced nocturnal functional bladder capacity, and of course the arousal from the sleep disturbances. That is the key players that comes into play. So how will you manage this child, Dr. Rana?
So this child is having primary...
Focus on this child.
Yeah, but primary monosymptomatic nocturnal enuresis. We should start with the treatment, the education of the parent and the child. So the education should include that about the disease process and the pathophysiology of nocturnal enuresis in details. And we should inform that this is not uncommon. This problem is a high prevalence rate in the children. And the good thing is that they have spontaneously high cure rate. And other general advice to change the lifestyle advice has to be given regarding the fluid intake. The child should be taking adequate fluid throughout the day, but they should restrict fluid after the evening. And they should avoid any bladder irritant like the carbonated beverages, sweetener, and also the caffeine containing fluids. Another thing is that we have to maintain our diary that will give us the amount, the bladder function, the voiding volumes, and any urgency or other symptoms is associated there or not. And also you have to ask the child and encourage them to pass urine at a regular time during the daytime and also before going to the bed. Constipation you have to explore, and if it is there, you have to treat adequately. And sometimes the rewards such as starchers and dry bed, rewards for the dry bed has been helpful, but we should say that this reward should not be due to the dry bed. It is due to adherence to the treatment that the child should be encouraged. And the two valid first-line treatment after these general lifestyle changes is enuresis alum and desmopressin. It depends on the family acceptance, motivation level in the family, so we have to decide which way to go. In our index case, this child has got significant nocturnal polyuria. So desmopressin will be the ideal treatment to start with, because this child also has got normal bladder reservoir function. So where we will consider alum, the family is highly motivated and children has low voided volume, and there is the voiding is, bedwetting is mostly in the later part of the night, and they do not have any daytime wetting. So if we start alum, that should be continued for at least 2 to 3 months, and 2/3 of the children achieve remission with this. But when we stop, can recur, and second alum therapy might be required. And desmopressin, ideal case as our index child, that child with a nocturnal polyuria, normal reservoir function, and sometimes we need desmopressin to start when alum has failed or family has denied not to go with them.
So, but I think in our child, we have a child who is only having nocturnal polyuria and the functional bladder capacity being normal. So, our first drug of choice should be desmopressin. I think
and
the other panelists
if
would agree to
desmopressin
this.
fail, we can try alum, and if that combined therapy fails, and if there is associated lower urinary tract symptoms we have to consider anticholinergic agent of severe.
So those are rarely used, but the first line, what we normally take it as a preferred treatment is that somebody having nocturnal polyuria with normal bladder reservoir functions, desmopressin is the drug to
Now,
go.
how long it should be continued?
How long to continue?
So
Anybody wants to
desmopressin,
continue?
if we start, we have to continue for 3 months, and we can start at a lower dose or higher dose, depending on the practitioner's choice. And we have to see the response, and if it is cured, then we have to stop it.
Now,
But
most
it
of
can
the time,
recur
most
again.
of the time, I've seen that when patient is on the desmopressin, symptom is less, but when to stop the medicines, and again, patient
Yes,
is
exactly. You are right,
so,
sir.
So what is the
The
guideline?
relapse rate of desmopressin is very high, up to the case of 60 to 70%. So they might relapse again. So again, that has to be restarted. But what is very important is that proper counseling of the family and sticking to the therapy. To begin with, you
No,
should
when,
start
have
at
to
least.
when I have to stop?
When you have to stop. Anybody wants to
If,
comment on
if the
this?
child has achieved, at least 3 months, if the child has achieved like 14 consecutive
Dry nights.
days of
Right.
bed waiting, the child hasn't bed wait for 14 consecutive days, we can consider. But usually it takes at least 3 months to work. If it
And-
is at all helping. If it is not, then we have to consider other
So the
supportive
guidelines is that you start for 3 months.
You can
and once
increase
you
the
have,
dose firstly. You can go to higher doses, and you can make double treatment. You can use a desmopressin as well as an alarm. So
Yes.
combining treatments can
So
often
combination therapy is also there. But you start with at least a trial of 3 months of therapy with
My
desmopressin.
question is, when patient is on the normal low dose, patient is asymptomatic. But when you stop the medicine,
Sir, we
again
do
patient
not-
relapse the
sir, I'll
conditions.
take this question.
So how will know that patient will under control? We can stop the medicine.
No, we first start for 3 months of therapy. And we see with the bladder diaries how the child is responding. If the child responds in terms of having dryness for more than 2 weeks, what we normally do is that we do not stop suddenly. We taper the doses to thrice weekly, then twice weekly, then once weekly, every 2 to 3 weeks, and then we see how the child is behaving with that. And then we stop after tapering the dose in sequence. And we'll see the bladder diary. We'll take few questions maybe towards the end. So what I really want to emphasize here is that if somebody having only a small bladder capacity, we can start with alarms. And somebody having nocturnal polyuria, along with that, if there's smaller bladder capacity, we can do a combinations of both alarm as well as desmopressin. Both can be used as a first-line therapy, and then they can also be combined as per many of the guidelines. So this child with nocturnal polyuria should be started with desmopressin. And now that brings to my fourth case. This is a 9-year-old boy who is admitted with high fever. There was a history of continuous dribbling of urine since birth. And the child was operated for meningomyelocele at the age of 12 days, and the pants was always wet, as explained by the family, and there was a significant constipations. There was a history of recurrent UTI for which the child was admitted. And on examinations, what you can appreciate here is a very bad scar. You can see there was a scar over the back, the palpable bladder was there, and there was a lump in the abdomen suggestive of fecaloma. There was rashes in the perineum, probably because of the continuous urinary dribbling. And in neurological examinations, the lower limb weakness was significant. So what is the likely diagnosis in this child, Sanjukta, with this kind of information that we have?
So this kind of information is quite straightforward. The child was having neural tube defect which was operated, but the child is having an underlying neurogenic bladder, and along with that underlying constipation.
So, summarizing the history and examinations, what we find here is that they have plenty of symptoms in voidings and as well as storage. There was urgency, frequency, incontinence, enuresis, hesitancy, poor stream, and also constipations. And in examination part, neurological examinations had focal neurological deficits, and there was a surgery history of repair of meningocele at time of birth. So, with this basic history and examinations, what are the initial investigations that you will ask in this child? Dr. Subal.
So he's having fever now, and having risks of recurrent UTI. So first thing I think we rule out UTI and start treatment. So to send a routine maximum cultures, do a CRP, CBC, do a baseline urea creatinine because having not being addressed that could be risks of CKD. And ultrasonography give information about the hydronephrosis, bladder post-void residues, bladder wall thickness, MRI LH as per the protocols, and to assess the functionality. MCUG, of course, it is helpful to rule out reflux and low duct anatomy. And urodynamic studies, maybe all surgeons agreed that. So any child having neurogenic low duct dysfunction, this standard of evaluations.
So these are rightly said, these are the investigations that we do in these children. So we have done the investigation that showed the counts were high, the CRP was high, suggestive of infections, the urine culture showing Klebsiella, and there was plenty of pustules, again, suggestive of UTI. The USG KUB showed thick-walled urinary bladder. There was bilateral hydroureonephrosis. There was a significant post-void residue, and transrectal diameter was also very high, suggestive of constipations. We did MRI LS spine that showed tethered cord, and MCUG that we have done showed this particular picture. Dr. Poonam, you being a pediatric surgeon, can you just comment on this kind of MCUG that you normally
This is
see?
the classical Christmas tree appearance of a bladder that we see in case of neurogenic bladders. This shows that probably the bladder is very high pressure. There are trabeculations, circulations all throughout, and there is some VUR seen on one of the sides, on the left side. So in this child, urodynamics study is a must because it will give us an idea of what are the pressures in the bladder like. Our aim would be to reduce the pressures in the bladder and to make the child dry. Reducing the pressures in the bladder is important to safeguard the upper tracts, because already this child is having some upper tract dysfunction. Creatinine is already 1.6. So his upper tracts have been damaged to some extent. We have to reduce the further damage by reducing the pressures in the bladder. For that we will need medications. And to keep the child dry, we need to do CIC. The child has to do catheterization every 3 hours.
We'll come to the management part also.
Yeah.
So essentially, these are the tests that we normally do, and very important is that we also check the renal RFTs. Creatinine here is 1.6, which is often missed by the doctors during the follow-up, which should be done sequentially to see whether the child is having any renal dysfunctions or landing with CKD in future. So what next would you do, Dr. Poonam?
Yeah,
So would you go straight away with the urodynamic study, or you just want to do uroflowmetry and just see what
No,
you want to
in
see?
this child,
So you did this child is basically went to you and you did this urodynamics. It's your report only.
So neurogenic bladder is a special indication where I would go ahead for UDS for all the patients.
Right.
Because we need to document what are the bladder pressures like. If the pressures are high, the kidneys are going to get damaged silently. We do not want them to happen. So that is why urodynamics is a must in all cases of neurogenic bladder.
So that's a point that should be taken, that for all the neurogenic bladder patients, urodynamic is a must.
Absolutely. So over here what we can find is the green line shows the bladder pressure that is going up, and there is the leak drops, the drop sign are showing the leaks. So the child is having leakage at bladder pressures of around 30 to 40 centimeters of water. So that means it is a very high risk bladder. Any pressures more than 40 is detrimental for the upper tracts. So this was a high risk bladder, that is why it has caused the creatinine to go up to 1.6, which was absolutely preventable. This is an important point in all neurogenic bladder patients. The patients are born with normal kidneys. If there is any deterioration in renal function, it is our fault because we have not monitored the bladders adequately.
So that's a point that should be well considered. And how will you manage these children? Dr. Rana.
Yeah, as already discussed, these child should have been followed up with a nephrology team regularly just after the surgery. So this child has developed all the complications of neurogenic bladder. This child has upper tract dilatation. This child has got recurrent urinary tract infection, also has got constipation. And this child has got significant high blood pressure during the storage in the bladder and also during high pressure during the urination. So the main goal of the treatment at this stage will be control of infection, management of the CKD if it is any, the creatinine is already high, so that line, and also institution of the therapy so that no further renal damage happen and no secondary bladder wall changes happen. So the goal should be to keep the renal function. In doing that, we have to keep the bladder pressure low, and we have to keep the voiding very easily, either by the voiding by the child himself or by catheterization. Also prevent the complication like UTI. Other long-term goal will be to achieve urinary continence and independence in bladder management. The standard therapy for this is clean intermittent catheterization and with addition of some medication to control the functional bladder disorder. So clean intermittent catheterization can be done by the child if he or she is more than 7 years of age. Below that age, it has to be done by the parents. So it is clean, but it is not sterile. And it should be done 4 to 6 times a day at least, and an interval of more than 8 hours is not encouraged. If that doesn't help, and also if there is already there is high pressure, so we have to add some medication. Some common medication we use is anticholinergic drug. Oxybutynin is the commonest agent, and that is oral oxybutynin. Sometimes intravesical oxybutynin can help also.
So do we
And
always add anticholinergics, or there are
yeah, I
specific
think in this stage
indications?
we have to add, because already there is high blood pressure and there is a we are suspecting there is retrosal hyperacceptability is
Yes.
there, so you have to suppress that to increase the bladder function, to
So
increase the
the
stored
points
quality.
to be taken to is that you need to preserve the bladder, you need to preserve the kidney as far as possible, and for that CIC is a very good thing that should be done, and then proper counseling to the family again is very important and key to this management, and
So
of course
along with this
anticholinergic should
standard
help in
therapy,
this child.
we have to do other supportive therapy also.
Yes.
Like treatment of constipation, treatment of infection, if any, supportive treatment for the renal function decrement, and also there is a voiding diary also helpful.
Right,
And child should be encouraged to pass if the child is passing urine regular basis. And there are other treatment options available like physiotherapy, which will strengthen the pelvic floor muscles, neuromodulation, sacral neuromodulation, and botulinum toxin, Botox injection in the bladder wall. That will also improve the, actually reduce the detrusor hyperacceptability and improve the bladder storage function and voiding function. So if these all fail, if the child is having progressively deteriorating renal function and complicated by multiple infection, then the surgical intervention will be required. Like Mitrofena procedure and augmentation cystoplasty and other complicated bladder surgery. So the lifelong follow-up will be required for these children, particularly monitoring at the upper tract changes, renal functions, and bladder changes.
So rightly said. So the crux is that you need to have a nephrurology team in most of the centers who are dealing with this, and you need to follow these children very closely, and lifelong follow-up is very, very important. So you should have a pediatric surgeon and you should have pediatric nephrologist on board to have a management of this kind of child. Now this brings to my fifth case, that is a 3-year-old child, is a male boy, and is passing frequent urine in excessive amount for the last 1 year, noticed by the family. The child passes urine 16 to 18 times per day. There's excessive crying for feeds, especially the liquids. The history of recurrent fever and excessive thirst. The child has a poor weight gain and height. On examination, the child looked dehydrated, vitals were normal, systemic examination did not reveal anything. This was the first born child of non-consanguineous marriage, term male AGA, uneventful perinatal history, no history of any hydramnios. There was no history of family history of renal disease. Developmentally, the child was normal. There was no history of any drug intake, any trauma to the head, any history of pulmonary cox. There was no history of visual or hearing defect. So with this basic information that we have, the history, what are the possibilities you should think of upfront, and how will you investigate this child to get to a diagnosis? Dr. Subal, you have a lot of information on this child.
So this is a 3-year, 2 months child, and there is increased frequency of urinations. Here is what is the red flag sign, here is the failure to thrive. So again, that point towards something alarming, right? So you have to look for the causes of, organic causes of polyuria, sorts of things like that. We need to document that. Thing in the line of some subtubulopathy, could be renal tubular acidosis, Bartter syndrome, could be diabetes insipidus. Look for the diabetes mellitus, and of course never forget chronic kidney disease.
So initially, what should be your focus? Like upfront, what do you think may be the possibility?
So just failure to thrive. So to me, I have to look for other symptoms, signs, symptoms like our renal tubular acid is quite common. First thing come to my mind if there is polyuria, polydipsia, and failure to thrive.
So you want to have some basic information about the investigations, so that you go ahead with
so
this.
at least urine microscopy was like quite useful.
Right.
Urine analysis, like look for the.
So that brings into my next question, that you need to do some investigations to approach to a diagnosis. So we'll do some basic investigations.
Yes.
So what investigations?
So you have to look for the hemoglobin, look for the like CKD, like could be anemia, look for the creatinine, kidney function test, look for the urine analysis, and look for the electrolytes, sodium, potassium, magnesium, calcium, that can give a clue to the like any tubulopathies. And do a blood gas, look for the metabolic acidosis. Of course, ultrasound quite helpful, it's quite non-invasive, can give a lot of information about the kidney size, echogenicity, nephrolithiasis, nephrocalcinosis. So they are the basic investigations that will give a lot of information and give a direction where we are moving towards.
And also from the history, the child was passing frequent urination and in large amounts. So you need to document whether the child is having polyuria as well. And then you need to consider the causes of polyuria, as sir has said. And then we did basic investigations, and these are the investigation findings that we have had in our test. So Dr. Subal, would you want to comment on these investigations, what we have done?
There is mild anemia, 10.8 grams, and electrolytes normal, sodium potassiums, again that almost rule out.
So,
and but look at the
would you think of CKD here? The renal
creatinine
profiles were
creatinine
normal.
normal.
So, would you
electrolyte
consider
normal,
tubular
yes.
disorders here?
Sodium is normal, right? Bit of higher side. Blood gas normal. Bicarb normal. So almost seems normal, right?
So it looks normal. So would you think it's a diabetes mellitus? You've done random blood
Not
sugar
so
also.
normal, right?
So it doesn't
That
look
is-
like. So it
yeah.
doesn't look like
So it doesn't
diabetes
look like that.
mellitus, doesn't look like tubular disorders,
Yes.
doesn't appear
That-
to be
Doesn't look
heart
like
disease or something like that.
Yes, doesn't look like
And
lactic acidosis.
look at the gas. We have done the gas also, and that
That's all
essentially
normal, right?
speaks of
Within
normalcy.
normal.
So doesn't look like a tubular disorder, doesn't look like a diabetes,
Tubulopathy, yes.
tubulopathies as well. So what will you do next, Dr. Sanjita?
So with this investigation, we have ruled out RTA because the blood gas is normal. The renal parameters are normal. So CKD has been ruled out and blood sugar is also normal. So next we have to look for whether it is diabetes insipidus or primary polytipsia kind of thing. So for that, one thing I would like to do is first measure the urine output and the intake output charting. So whether there is any polytipsia or not and polyuria not, confirm that. Also do one ultrasound KUB to see whether there is any anatomical abnormality of the kidney, because there may be some underlying kidney disease, and also urine osmolality measurement. So urine osmolality will give us a clue that whether there is any suspicion of diabetes insipidus. And by the water deprivation test, we can differentiate between this diabetes insipidus and primary polytipsia. And if we are if the water deprivation test is telling us that it may be diabetes insipidus, then you have to do a desmopressin test then to confirm whether it is central or nephrogenic kind of DI.
So can you just elaborate on what we have done, like the urine osmolality and
Yeah.
serum we have done?
So
with this,
we have done a 24 hours urine volume measurement. It
So-
is 10 ml per kg per day. So that is very high. More than 4 ml per kg per day is polyuria. So obviously the child is having polyuria, and the urinary osmolality is 165. So with serum osmolality 296 and urinary osmolality 165, yes, it is a very much suspected of diabetes insipidus or
right. So we are suspecting that may be a case of diabetes insipidus. So next, as we have seen that if you have a child who suspected diabetes insipidus, the urine osmolality is being low, the plasma osmolality being 290 to 300, we would go for. So next we want to do a water deprivation test. Just quickly, can you just see the report of water deprivation test that we have done? Dr. Rana, just quickly, can you tell us what do you see in this report?
Yeah, in this report, you can see that this child is still passing quite a significant amount of the dilute urine with a rising of the serum osmolality. Serum osmolality is crossing 300, but urine osmolality is still on the lower side. I mean, you would expect a normal child or primary polydipsia, this urine osmolality should be above 600 or nearly 750. So this is not happening here. Also, sodium is rising. So this is a partial response.
Yes, so what investigation would you want to do?
We need to go for the DDIP test, the desmopressin.
Okay, so what we saw that the increment of the urine osmolality is not beyond 750, so it's still less, so you consider diabetes insipidus, and next you want to do as a vasopressin test. So we did a vasopressin test, and this was the finding. Can you just comment quickly, Dr. Subal? So what do you see in the post-vasopressin challenge?
So, desmopressin challenge is basically to differentiate whether it is central diabetes insipidus versus nephrogenic, what you call resistant diabetes insipidus, and see the response here. After giving a dose of desmopressin, there is significant improvement in the urine osmolality. So it is responding to desmopressin. So it is a case of desmopressin deficiency or ABP deficiency, diabetes insipidus.
Okay, so it looks like a
Central diabetes, or what do you call that recent term, ABP deficiency diabetes.
So remember, if after the vasopressin test, if the rise in urine osmolality is beyond 50% or more, then it is likely to have a central DI. So how would you treat?
So again, that needs a replacement, hormone replacement. So lifelong desmopressin therapy also has some dietary modifications.
Okay, I think we are running short of time, so we just end here, and then we have algorithm by our experts. So can I have my expert team here, and then we'll be discussing in short of what we have done over the last 45 minutes or so. So we'll just sum it up with our experts doing the needful. May I invite my expert? No, it's okay. One of the other, we have 3 experts here. They can come and just share their opinion and the algorithm. Yes.
So, no, it's okay. It was a really wonderful presentation, Dr. Shakil, and especially for the people who are practicing general pediatrics, this bladder bowel diary, how important this is in our day-to-day practice. I think we should incorporate it in our daily practice, just like we are using growth charts. And the expected bladder that output, I think, that's what you were saying, how to calculate that and go ahead with that, I think that is also to be learned from this discussion. And regarding that neurogenic bladder, again, that proves that it's not only the correct intervention and the early intervention. We neurodevelopmentalists, those who are proponents of this, we have a neurodevelopmental pediatrician also with us. It's so nice to see Dr. Nilanjan. So, but we always say that it's a multidisciplinary approach. Like, we treated this for the meningomyelocele and the child was lost for follow-up. And he landed up with some complications with the neurological part. So this should have been taken care of much earlier had this been a very much organized like follow-up. So we should not lose these patients, and this is something very important so that they don't land up with these complications with the comorbidities which are present along with these problems. So we'll go ahead with the experts now.
So over to my experts.
Yeah, I think so. Basically, when a child comes to us with increased frequency of micturition, the first thing is what is increased frequency. So anything, a child passing more than urine more than 8 times in a day, usually they pass around 4 to 7 times. If they pass more than 8 times in a day, we call it urinary frequency. So the next thing is to differentiate whether it is just increased urinary frequency or whether it is polyuria. Okay, so we shall proceed a bit fast. So for that, first is a very thorough history taking is very important. Whether it's a very recent onset problem or whether it has been there for a long time, whether there is any associated dysuria or any pain which will go towards an infection, whether there is associated incontinence. So as we have already discussed in the previous, from the case histories, that just frequency of micturition and incontinence will be dealt with differently. And then we have to see whether there's been a history of any weight loss, any fatigue, any signs of dehydration, any failure to thrive, which will again lead us towards metabolic and other disorders like diabetes or RTA. And the last but not the least is the bowel habits. Never forget to check for constipation. Then once you've got a thorough history, you'll be more or less know which side you're going, whether it's just increased frequency or it's incontinence or it's polyuria. So these three categories should be very clear in your mind. Now we go for a very detailed physical examination. General examination, obviously you'll have to do to see if there's any signs of dehydration, if there's any telltale signs of any surgery, any congenital malformations, all those things have to be there. Very specific targeted abdominal examination. Never forget to look for constipation and whether there's any palpable bladder, and obviously fecal mass. Genitalia examination, look for urogenital abnormalities, especially if there's any congenital abnormality which is causing, suppose an ectopic ureter, which is causing constant leaking of urine. Or there's any neurogenic, any spinal problems which are leading to any neurogenic bladder. The very important is to look at both the feet and to see whether any spinal problems, the gait problems must always never be mistaken. In investigations, we really don't do much. Basic investigations, which is a urine analysis to rule out any infection, or to see the dipsticks to see if there's any sugar in the urine, to rule out diabetes mellitus. A basic ultrasound to see whether you have there's any congenital malformation, or there is anything like you have any obstructive neuropathy or anything, or anything suggestive of any neurogenic bladder. Sorry. So once this is done, this is a very simple algorithm. So if this is a very sudden onset, I don't think you need to take pictures because we've all given you a folder which has everything in it. So if it's a very sudden onset or whether it's a gradual onset. If it's a sudden onset history of increased frequency, see whether it's a very frequent daytime urination, more than 3 to 4 times in a day with a normal urine analysis. If that is so, see whether there's an increase in volume or not. But if you find there is no increase in volume, from the bowel bladder diary, you will know whether there's an increase in volume. If there's no increase in volume, no minimal nighttime symptoms, no incontinence, the bladder capacity is normal, usually associated with stress and behavioral issues, it is most likely going to be pollakiuria associated or not associated with constipation and other behavioral or functional causes of voiding dysfunction. If there's associated urgency and incontinence, then you have to think of overactive bladder, some organic causes like voiding dysfunctions or neurogenic bladder. If the sudden onset is associated with dysuria, hematuria, fever with an abnormal urine analysis, likely to be UTI. If this whole thing has been gradually started gradually with failure to thrive, rickets, nephrocalcinosis, it points towards RTA. If there's glucose in urine with polyuria, points towards diabetes mellitus and diabetes insipidus. So this is in very short an algorithm which you can just apply in your OPD. So we shall go into the next one, which is incontinence. Shubhashish.
So I'll take 10 to 15 seconds as we are short of time. So basically, there are two broad things. One is the child is incontinent from, day in and day out, continuous leak. So continuous leak only happens if there is the ureters directly draining beyond the sphincters. So that's a surgical issue. And if it is intermittent, then you divide whether the incontinence is only during the day or it is only during the night or it's continuous. So basically that comes to enuresis. We have already discussed a lot that monosymptomatic enuresis, what you want to do. So basically ectopic ureter, as I already discussed, and also in the meningomyelocele case, spina bifida, we discussed little back. So what we showed, discussed here was a child with overactive bladder causing incontinence, but myelomeningocele children also may have a wide open outlet. The pelvis is wide apart. So that child will continually leak. There you can neither do MCU, neither do UDS, you can do nothing because there is no bladder capacity, it's wide open outlet. So those are surgical things. So medical things are overactive bladder. So incontinence with overactive bladder, we already showed how the urodynamics looks. So it goes like this, like this, like this. This curves, detrusor curves. So there you need either anticholinergics. If anticholinergics fail, you have to do intravascular detrusor Botox. And there is dysfunctional voiding. In dysfunctional voiding, what you do is, child is incontinent because when he or she is trying to void, the sphincters are tight, sphincters are not relaxing, and vice versa. So the child continues to leak at terms. This is classically seen also on the MCU and on the UDS. UDS tells you, gives you a UDS with EMG study, shows you a clear-cut thing that this is a dysfunctional voiding. Dysfunctional voiding, in addition to proper rectal clearance and medications, sometimes respond very well to biofeedback therapy. So that's another big thing that is coming up and which helps in a big way. Next is voiding postponement. The child doesn't goes on seeing serials or mobile or something plays on the mobile, doesn't go for. So voiding postponement can be habitually trained. Training can. And next is the underactive lazy bladder. The bladder has lost all its power of contracting. So there you need CIC. You need CIC because you can't make the bladder contract. There are prokinetic drugs, but they are not used in children. So mostly it is CIC, and continually you have to keep the nighttime drainage, continuous entire night you have to keep the catheter in situ. And of course, in all these cases, you have to rule out fecal impaction, that is a bladder bowel disorders. So this is a basic thing which we discussed all the way. I'll hand over to Dr.
So how will approach case of polyuria that will be discussed in the case scenario. So look for the causes of polyuria, could be acquired causes like psychogenic, obstructive uropathy like posterior valve, Could be hereditary, diabetes insipidus, dyslipidemia like chronic hypercalcemia or hyperkalemia can cause. Clinical features look for the antenatal history of polyhydramnios, that could be neonatal Bartter syndrome, neonatal and infancy failure to thrive. Look for the feature of rickets, that could be CKD or renal acidosis. History of aneurysms, look for the psychological cause. Drug is quite rare in children. So quickly going through the algorithm how to approach the case of polyuria, distinguish between polyuria and urine frequency as we have discussed. So for that need to do a 24 urine charting. So if there is polyuria more than 4 ml per kg per hour, do a baseline investigation to look for the red flag sign or secondary cause, organic causes, do electrolytes, creatinine, blood glucose, blood gas, urine analysis, look for the osmolality and simple non-invasive ultrasonography. That will give a lot of information. Rule out secondary causes like diabetes mellitus, renal acidosis, chronic kidney disease. If everything normal, do a first morning urine paired sample, urine and serum osmolality and sodium. That urine osmolality is serum urine osmolality less than 295 and urine is more than 75. So that means kidney is preserving the concentration, it is intact. So that rule out, then no diabetes insipidus. If serum osmolality is less than 295 and it is urine osmolality variable, then you can go for a water deprivation test. And if you are able to conserve the urine osmolality, increase gradually, urine osmolality more than 750, then that could be psychogenic polydipsia. If urine osmolality is variable less than urine serum osmolality more than 300 and urine osmolality less than 300, then that again indicates water diuresis. So in that conditions, you have to go for challenge with TDAVP. If the response, that means increase in urine osmolality more than 50% from the baseline, that indicates deficiency, ABP deficiency, it means central diabetes insipidus. If there is no response, there is no increase in urine osmolality, less than 10% increment in the urine osmolality, that indicates resistant cases, means ABP resistant or nephrogenic diabetes insipidus. Thank you.
So thank you, sir, for that crisp.
Because of time, we will not going to take any questions from the audience. We can discuss it later on. So thank you very much. Thanks to the panelists, thanks to my experts, and thanks to the chairpersons. Thank you very much. Over to Devlina.
Thanks a lot, sir. I would request the chairpersons, the moderator, the panelists, and also the experts to kindly collect the memento from the memento corner. And I would request Dr. Amitabh Pahari, sir, to hand over the mementos in the memento corner to them. Now, I would like to tell you that in this conference, we have started this interesting segment called the audience quiz segment, where the audiences are supposed to answer some questions after every panel discussion. And that will be through a mobile-based app called the Mentimeter app. So I will now hand over the charge of introducing this app and asking the audience quiz questions to Dr. Rohit Bhomik and to Dr. Niladri Bose.
Good morning, everyone, and warm welcome for Bspncon 2025. We are really delighted to have a full house from the very beginning, and thanks to everyone for joining. So we have organized a quiz segment after each talk, and it will be through the Mentimeter app, and the link has already been posted in the group, will soon be posted in the group. There will be 2 MCQs that will be shown over here as well as in your mobile screen. A demo will be shown right now and you will have to answer the questions over your mobile only. At the end of this session, the person with maximum number of points will be awarded. So over to Dr. Rohit for the demo of the Mentimeter app.
So good morning all. Yesterday we have a brief session on this. Many people joined. Those who have not joined, it is very simple, nothing much to do. One app is there, nothing to download, nothing to do. The link will be shared on your mobile. So once you...
the link has been posted on the delegate group, right?
It will be soon, it will be posted by Deblina.
I think it has been posted.
But don't do anything. Once it is there, this kind of things will be seen. Like see the Menti one, right? Like this one number is there. Is it there to everybody? Yes. So once you click on that, now you can click step 2. And some creature will come, wolf, fruits, flower. Came? A group link.
Just posted in the faculty group also.
So just click once. Second step, is this came? Some creature, something? Don't do anything, just once by one. Reload means you have clicked 2 times. Just click 1 time. Again you can go back and click. It won't, just once. Then your name, put your name, otherwise for prize it will be difficult. No, no, did not connect means you don't have internet. It is connecting. See, you do. See,
Link has been posted both in the faculty group and the delegate group.
see, it is coming here. Ha, reload means it is okay, okay. If something is happening, it is okay. Then your name will come. Once we start, your name will come. You have to put your name. Reload means you are in the right track. Now don't do anything now. Then name will come. Once name will come, question will come like that. Now it won't come. It will come like that. Please concentrate here. It will come like quiz is not open. Please wait for presenter to activate. Don't click anything. Don't click reload. One dictum is don't at all click reload. Don't click anytime, please join another quiz. Just you have to simple question will come. Question will come like that. It will show like that, like which Indian song recently won Oscar award. And time. After that, within 5 seconds, answer will come like that. Like this. Eiffel Tower is situated in Paris, London, Toronto, Washington. Remember, if you mark correct, the probability is you may get 1000 point, you may get 500 point. Immediately you answer 1000 point, you wait, thought, after some time you answer, the least point you will get 500 in a correct answer. Wrong answer, no marks. Correct answer can give fastest finger first, just like KBC. The highest person will get 1000, the lowest person will get 500. Only for correct answer. You can see your response, okay, you're correct, you're wrong, or you have not able to put, you did not vote, wrong answer, no negative marking. Or you are in the first place. Last it will show. Let's see how you did. Your answer, your result will be declared to you only. At the end means last. Session 2222 will be there. At the end, leaderboard will be displayed. Not publicly. You will know your result, your rank 1, 2, 3, 4, 5, 6. And we will know here, but it won't be displayed publicly. So the right side, nobody will know the other person's result. Very confidential, but you will know your result, we will see here. Thank you. Any doubts? Any doubts? This is perfect. This screen is perfect. No code, nothing is required. Once I open, it will be perfect. Sign up not here. Wait for the content to start. And again content ready. কোনো app লাগবে না, কিচ্ছু লাগবে না. It won't create in your memory. No app is required. Once it is over, it is over. No residual damage. ঠিক আছে না? This one is হ্যাঁ, ঠিক আছে. No app, no download, no phone memory. Once it is over, it is over. This is perfect.
I've got a sad news. Sad news is that faculty will not get any prizes. So you can obviously answer, but you will not get any prizes.
See, it is visible. So many people joined, right? 75 voters are shown. So I hope it is clear to everyone. Don't click anything. After that, don't click anything. Sumantada. Her name you can put.
Just put your name only.
Because prize it is there required. Sumantada, you join karo.
Just put your name only. Don't click anything.
তুমি দেখতে পাবে সুমন্ত। Okay, done? Everybody is okay?
Is it showing get ready to play? Then your name?
Yes.
Anyone having anything else? The screen should show get ready to play, then your name.
So we are ready to start.
I will just read it out the question for you.
Answer first to get more. Yeah.
So nocturnal polyuria means nocturnal urine output. These are your options. More than 90% of expected bladder capacity, more than 100%, more than 135%, more than 150%. Fastest finger first.
Sorry, time. That means your time is up. Don't do anything. क्या हुआ? तो क्या कर सकते हैं? We told you, you have 20 seconds time and time is going up, na? Sorry? That means, see, many people are laughing means they answered, like you answered.
Now the time starts from the very beginning of the question. When the question comes, and it
How
might
many
vary
people
with the-
answered? Just hold on. See.
Huh.
40% click. See, তোমার নেটওয়ার্ক নেই। हाँ ठीक है, no problem. See, no hesitation. 40 people answer correct. See the device. You don't, most probably you have answer correct. Just hold on. See, 40 people answer correct.
40 plus 26 plus
Plus
4 plus
26.
6.
See how many people responded? Just hold on. 40.
76.
76 people answered. See, this hall, 76 people answered. 40 people are correct. So how, sir, it is possible? Sir, impossible.
Acha, next question. Chalo, next question.
15 seconds. Now, it is a ma'am, it is oil practiced. It is there. Maybe it is down in your screen, it is down somewhere. 40 people answered correctly. Many students answered correctly, I guess. See, people are laughing. Sir,
Next question. Chalo.
maybe your screen is short. Just see. Next. Anyway, 10 questions are there. সংযুক্তা দেখাও তো কি হচ্ছে না। তুমি এসো এদিকে, এসো দেখাও আমাকে দেখাও। তুমি কিছু করোই না, বারবার নাম লিখতে লাগবে না। once you are there, see question is there. কিসের বারবার নাম? এই তো।
All are voiding symptoms of bladder except hesitancy, straining, weak flow, incontinence. Now the answer rate is better. Done.
Explanation. Sir, explanation.
At the end. Okay.
And third note is keep this window minimized. Means this don't go out. Means you can go to WhatsApp, chat, another thing. Keep it because again it will come.
So the explanation for this one is all are voiding symptoms, only the incontinence is called storage symptoms. And for the first one, it's a straight cut answer. It's more than 135% of the expected bladder capacity.
So you also keep your mentimeter minimized. Means you can go to other window. Again it will come.
So the next quiz session will be after the next talk. Okay, so get ready, fastest finger first.
টাইম হয়ে বেরিয়ে চলে গেছে।
Thank you very much. Now I'm Dr. Pallavi. I will be one of your MCs for today. Now we move on to the next session. That would be plenary lecture first. A child with failure to thrive, renal perspective. And the chairman would be Dr. Mukta Manthan ma'am, who is the current president of ISPN, director, professor, and in charge pediatric nephrology, Department of Pediatrics, Maulana Azad Medical College, Delhi, and Dr. Rafiqul Rahman sir, who is the professor and HOD Department of Pediatrics at Eye Care Medical College.
কালকে মানে একটা ট্রায়াল আমি
Good morning. Good morning, everybody. Today our lecture session, which is the failure to thrive, renal perspective, we know the failure to thrive is in pediatrics very useful things, but there are a lot of causes. But today we'll discuss only the renal perspective of the failure to thrive. This lecture will be delivered by Dr. Mehul Shah. He is a renowned pediatric nephrologist. He is a consultant pediatric nephrologist. He is attached in the Apollo Hospital and Little Star Hospital of the Hyderabad. His interest is mainly in the renal tubular disorders. His many publications. Dr. Mehul Shah, please.
Persons. At the outset, I would like to thank the organizing team, Sushmita, Amitava, Rajiv, and Jaiti, and the younger group for the kind invitation. Certainly, it's a nostalgic feeling because I've been coming here since 2003, 2004, when Amitava had first started the Apollo specialty CMEs. So good morning, everyone. I think over the next 20 to 22 minutes, we would go through the topic on failure to thrive in children, a pediatrician's guide to renal causes. I think the work has been made a little easy because of the panel discussion which we had earlier, and some points are going to be repeated, and I'll try to skip them because it has been covered in the previous 1 hour. So the outline is going to be a brief introduction followed by the renal causes of failure to thrive, the presenting features and pathophysiology in brief, approach to polyuria, which Subal and the team has already discussed, but just my perspective, and time permits, the cases which we have gone through in Hyderabad. So as we all know, I don't need to specify the definition of failure to thrive for this group over here. It's an inadequate weight gain or growth for age, which is below the 5th or the 3rd percentile on standard growth charts. Why is it important? Because it's a risk factor. Failure to thrive is a risk factor for malnutrition. It is noted in up to 10% of children and up to 5% of hospitalized children in teaching hospitals. It's a huge number. This has an impact on overall health and development and contributes not only to morbidity but also mortality. So why should we worry about failure to thrive resulting in malnutrition and the fact that the child has got kidney disease? Because as you know, pediatric chronic kidney disease is a rising public health concern. A significant proportion of children with CKD, especially in developing countries like us, are going to experience growth failure. This results in reduced well-being and self-esteem, not to mention about the increased hospitalization and mortality, especially related to malnutrition characterized by low serum albumin. Sorry. So briefly, we can divide renal causes of failure to thrive into 3 broad categories. The first one are the children with renal tubular disorders, which will present with failure to thrive. Some of the causes of renal tubular disorders have been mentioned over here. Renal tubular acidosis and Bartter's are the 2 most common renal tubulopathies which will present with renal failure to thrive. The second group is children with chronic kidney disease. We should not forget that it's not just renal tubular disorders, but children with chronic kidney disease are also going to present with with failure to thrive. The CACUT group, the congenital anomalies for the kidney and urinary tract, contribute about 25 to 30% of causes of chronic kidney disease in children. Chronic glomerulonephritis, steroid-resistant nephrotic syndrome, and some hereditary renal disorders, which are all important causes of chronic kidney disease in children. Not all children with CACUT are going to progress to end-stage kidney disease requiring renal replacement therapy. Some of them may just have chronic kidney disease which can get arrested, which may not progress, but are associated with failure to thrive. Some of them are renal hypodysplastic kidneys. Certainly they are going to progress to CKD stage 5, high-grade vesico-ureteric reflux. Posterior urethral valves, about 30% of boys with PUV are going to require renal replacement therapy, and inherited diseases like HNF1 beta mutations, which are slowly progressive renal causes of CKD. The mechanisms behind growth failure in children with renal disorders involves a complex interplay between nutritional inadequacy because of inadequate intake, metabolic dysregulation because of increased utilization, and systemic inflammation which all contributes to inadequate growth. However, different conditions are associated with different pathophysiological mechanisms. In brief, we would like to go through it. I'm not going to go into the details because it's more of a clinical approach over here. The pathophysiology of failure to thrive in tubulopathies is one, all of them are going to present with polyuria. This polyuria results in polydipsia and increased water intake, vomiting and constipation. Both these factors together are going to contribute to anorexia, decreased intake because the children's stomach is going to be filled with water. They don't have any capacity to take any solids. Decreased intake of solutes is a major contributing factor for decreased intake. Increased urinary losses, which results in lowish blood pressure. This results in decreased organ perfusion and hence slow growth. Finally, acidosis, which could be one of the features of renal tubular disorders like RTA, will result in muscle weakness. Acidosis results in anorexia, nausea, vomiting. This results in decreased activity and associated secondary vitamin D deficiency because children are not exposed to sunlight, and also there is decreased intake of vitamin D. In contrast, children with chronic kidney disease and failure to thrive have a different pathophysiology over here. We all know what chronic kidney disease is. I'm not going to go into the details, but any child who has got a persistence of markers of kidney damage for more than 3 months is defined as having chronic kidney disease. These markers of kidney damage could be just abnormal urine analysis, it could be abnormal renal function tests and or abnormal radiological tests. So this children needs a long-term follow-up. The pathophysiology of growth failure in chronic kidney disease includes protein energy malnutrition, anorexia and reduced caloric intake, loss of calcium, phosphorus, potassium, anemia, mineral bone disease associated with chronic kidney disease, and presence of uremic toxins, which in itself reduces the appetite. So multiple factors will contribute to growth failure in children with chronic kidney disease. So as a pediatrician, when should I suspect renal tubular disorder or chronic kidney disease? Certainly all these children are going to present with failure to thrive, inadequate growth. Growth which is either below the 5th percentile or growth which is faltering and it is dropping 2 curves in a child who was previously doing well. Most of these children are going to have polyuria, polydipsia. They would be having delayed physical milestones. Usually the mental milestones are age appropriate. They would have weakness, either generalized or episodic, unexplained anemia, recurrent headaches and vomiting, or they would just not be responding to your standard therapy of vitamin D in a child with rickets. So these are the common symptoms with which a child with renal disease and failure to thrive would be presenting to us. How do we identify a child with chronic kidney disease? 1, 20%, 25% of children with chronic kidney disease have underlying CACUT, congenital anomalies of the kidney and urinary tract. So certainly looking at the antenatal history, looking at the antenatal ultrasounds and evaluating children who have got anomalies needs an important first step. Failure to thrive, certainly. Children would have polyuria, polydipsia, constipation, vomiting, delayed milestones, unexplained anemia, and vitamin D resistant rickets. So these are some of the features with which a child with chronic kidney disease would present to a pediatrician's office. Who is at risk for chronic kidney disease? Steroid dependent or steroid resistant nephrotic syndrome, chronic glomerulonephritis, children who have recovered from severe AKI, they are all at risk for progressive chronic kidney disease. Children who have been treated with nephrotoxic agents which can give rise to subclinical AKI, AKD, and then can progress to chronic kidney disease. We all know that children who are born preterm or who are born with small for gestational age are at high risk for developing chronic kidney disease in terms of hypertension, proteinuria, and metabolic syndrome in their 3rd, 4th decades of life. These babies would need a long-term follow-up. And not to forget, children who have recovered from severe AKI needs a long-term follow-up, because up to 25% of these children over a period of 10 to 20 years are going to develop albuminuria, hypertension, and chronic kidney disease. So just after recovery from AKI, do not discharge the child from your follow-up. These children would need long-term follow-ups. So Briefly about polyuria in children, again, I have only few slides because it was already discussed by Subal and the panel in the preceding session. It's an excessive urine output which is more than 4 ml per kilo per hour. Friends, it needs to be differentiated from frequent urination. We had an excellent panel discussion on urinary frequency, urgency, incontinence. This frequent urination is seen in children who have got urinary tract infections, dysfunctional voiding, or the newer terminology is the bladder wall dysfunction, and it could be physiological in infants due to the smaller bladder capacity. And the second condition which needs to be differentiated from increased urine output is nocturnal enuresis. Both these groups of children are going to have normal urine volumes. It's not going to be increased. So not everyone who has got increased frequency of urination has polyuria. Please make sure that we are not confusing with these two common conditions in pediatric practice. In young infants who are not toilet trained, it's easy to say that it's more than 4 ml per kilo per hour, defined as polyuria. But how do we quantify urine in an infant who is not toilet trained? We do not end up putting a catheter. It's not usually necessary. But yes, we would think about polyuria if these children have nocturia. Please remember, a child who has got polyuria, either because of a renal tubular disorder or because of chronic kidney disease, their kidneys are going to lose salt, water continuously. It does not stop losing salt and water at night time. So a child who continues to pass large volumes of urine at night time, it should be a red alert for us that this is not just increased frequency of urination. Once children have increased urination with large volumes, they get dehydrated. And when they get dehydrated, their thirst center gets stimulated and hence they drink more liquids. Either it could be milk or sometimes it could be just water. So a child who has got increased urination in terms of volume, continues to pass large volumes of urine at night and has got associated polydipsia should be considered to be pathological and needs further evaluation. So for all practical purposes, a child may pass urine 30 times during the daytime, but he sleeps for 8 hours without wetting a diaper, does not get up at night to drink water. We do not need any investigation. All we need is a complete urine examination looking at the specific gravity. This child does not have polyuria. So these two parameters or symptoms are important to help us decide whether we need to evaluate further or not. Again, how do we define polydipsia? We all know that we all consume water to replace the water lost either from insensible water losses or through the urinary losses. Physiologically, we all need to take about 1500 ml per meter square per day. Polydipsia is defined as something which is more than 2 times the upper limit of physiological intake. How do we characterize polydipsia in a child? Again, we cannot quantify, especially when the child is on mother's milk. But if a child has got excessive irritability, which resolves only after feeding, and if the child continues to ask for liquids at night time, these are the two parameters which should make us think that yes, this is abnormal, we need to evaluate this. So nocturnal polydipsia is an important symptom when evaluating a child with polydipsia who are not able to quantify their intake. So friends, what came first? Did polydipsia come first or did polyuria come first? In children, for practical purpose, it is polyuria which results in polydipsia. Compulsive water drinking or so-called psychogenic polydipsia is uncommon in young children and we should not be thinking about that. That should be the last differential in our approach to a child with polyuria polydipsia syndrome. So how do we approach a child with polyuria? I think 3 quick questions. What is the duration of polyuria? Is it associated with polydipsia and is it associated with failure to thrive? So if I can divide this into 3 broad categories, if there is polyuria but no polydipsia, no failure to thrive, it could be behavioral. Yes, they would be doing a lot of water drinking during the daytime, but they do not, they sleep well, they don't have polydipsia at night, they don't have polyuria at night. It could be overfeeding by the parent or it could be voiding dysfunction in an older child. In contrast, if you have polyuria with polydipsia, but there is no failure to thrive, limited causes, it could be improper dilution, very common in our young babies who are on formula feeds, resolving ATN, it could be post-obstructive diuresis, it could be new onset diabetes mellitus, or it could be diabetes insipidus. So these children will have polyuria with polydipsia but no failure to thrive. Our focus is going to be on children who have polyuria, polydipsia, and failure to thrive. Here we can broadly categorize them into two groups. Is this solute diuresis, meaning are the children losing a lot of sodium chloride in the urine and hence it's dragging water with it, or is it a pure water diuresis where there is more of water loss as compared to sodium chloride or glucose or urea losses? So if we have solute diuresis, meaning polyuria with urine osmolality more than 300 milliosmoles per kilo of water, it could be diabetes mellitus. It could be protein when some children, especially in the ICU, are fed high protein formula feeds. They can give rise to high urea production and the urea drags water along with it. It could be salt losses as we seen with distal renal tubular acidosis, renal Fanconi syndrome or Bartter syndrome. Or it could be diabetes insipidus, which we already discussed in the panel discussion in the previous session. So stepwise approach to polyuria, is polyuria associated with polydipsia and failure to thrive? That's the first question which we need to answer. Before we investigate the child, I think we should look at a complete urine examination, and this is something which we often ignore. I think complete urine examination should be part of our physical examination. We should not relate it to an laboratory investigation. A simple complete urine examination or urine routine is going to give us a lot of information, including the specific gravity, the pH, the presence of protein, glucose, and the microscopic examination. The third point is we should first get a renal parameter. Are we dealing with a chronic kidney disease? If we are dealing with chronic kidney disease, we would not be thinking about renal tubular disorder. So first obtain a complete urine examination, then obtain a blood urea creatinine. Look at ultrasound abdomen. It gives you a good clue as to what is the size of the kidney. Is there any hydronephrosis, hydroureter, nephrocalcinosis, hypodysplastic kidney, posterior urethral valves, vesicoureteric reflux, nephrocalcinosis? A lot of information can be obtained from a simple ultrasound abdomen. Look at a venous blood gas. We don't need an arterial blood gas when we are evaluating renal tubular acidosis. A simple venous blood gas to look at the pH, PCO2 and bicarb is sufficient. And also serum electrolytes, calcium, magnesium and serum phosphorus. And this is something which is available in most centers in our country. So I have some time to go through the cases which we came across in Hyderabad. This is a 10 years girl was referred to us for failure to thrive and resistant rickets. She had polyuria, polydipsia since early childhood. Her weight was below the 5th percentile, and she had rickets with genu valgum of 15 centimeters. Certainly, with the ultrasound picture showing nephrocalcinosis in the medullary area, diagnosis is clear. We are dealing with distal RTA. Unfortunately, when she presented to us, she had a renal parameter showing creatinine of 1.1. Even though the reference range reported in that particular laboratory was 0.5 to 1.1, please remember this is for an adult population. In children less than 12 years of age, there is not enough muscle mass and the creatinine should be less than 0.6 milligram per deciliter. This is very high for a young girl of 10 years who is malnourished. So her eGFR is around 55 mL per minute per 1.73 meters square, giving her a diagnosis of CKD stage 3. She was started on Sonament as well as potassium citrate. Unfortunately, a delayed diagnosis in this child resulted in inadequate growth, even though we were able to correct her metabolic acidemia. Her serum creatinine remained at 1.1 and she's at a risk of developing progressive chronic kidney disease in her second and third decade. So could we have prevented this CKD? Yes. What factors would slow CKD progression? Early diagnosis, below 2 years of age, if we can pick up these children, they have an excellent prognosis. We need to target bicarbonate at 24 milliculons per liter. We have to be very, very particular. Nothing less than 23 to 25 milliculons per liter of bicarb is going to be acceptable. Anything less than 23, they are going to have ongoing loss of calcium carbonate from the bones and the risk of nephrocalcinosis. These families have to be educated on the importance of low salt vegetarian diet, low salt to reduce hypercalciuria, reduce animal protein intake, which is a source of acid production in our body, and increase fruits and vegetables, which is a natural source of citrate in our body. The second is a 2 years boy who presented with slow growth, passing urine frequently and drinking plenty of water since early childhood. Weight was 8 kilos, he was mildly dehydrated, no rickets, spine is normal. I think very commonly we come across these situations. Urine had trace protein, electrolytes showed a slightly elevated chloride, lowish bicarb, confirmed on our blood gas to be a mild metabolic acidemia, urea of 35, creatinine 0.8, no nephrocalcinosis, kidney sizes were appropriate for a 2-year-old, mild bilateral hydronephrosis. Can the younger group over here guess what this child could be having? Anyone's guess? 2-year-old child who has presented with slow growth, passing urine frequently, drinking plenty of water. So if you look at it, polyuria, polydipsia, failure to thrive. Are these renal parameters normal? Creatinine 0.8. It's not normal for a 2-year-old. It's very high. Especially in a child who is malnourished, who does not have enough muscle, the creatinine should have been 0.3. This is very high. Additional investigations, urine pH is 6.0, electrolytes showed a sodium of 60, potassium of 10 and chloride of 80, urinary anion gap of minus 10. Still we don't have a clue. What are we dealing with? Weight, renal function test and bilateral mild hydronephrosis. Did we ask for a urinary stream? In a young boy who comes in with failure to thrive and urinary complaints, we should think about posterior urethral valves unless proven otherwise. And this child has got classical PUV with bilateral high-grade reflux. So a child with PUV will also present with failure to thrive, increase urination because of concentrating defect, and increase water intake because of polyuria. A third girl who presented with 3 episodes of generalized weakness of 1-day duration, no vomiting, diarrhea or fever, weight of 12 kilos, 99 centimeters, blood pressure acceptable. She is euvolemic, no rickets in normal genitalia. This girl just came to us last week. Serum electrolytes 138, 2.2, 112, 18. No sugar, no protein. Creatinine is okay for this girl. No doubt, this girl has got recurrent episodes of hypokalemic periodic paresis. She was treated with IV potassium chloride. Within 24 hours, she started walking. She was sent home the previous 3 episodes, only to come back again and again with the similar episodes of hypokalemic paresis. So why did she come back again and again? What did we miss? We picked up the diagnosis of hypokalemic paresis. We treated her. Family is happy. The child is happy. But why did she come back the 3rd time? What did we miss over here? Did we inquire about history of polyuria and polydipsia? Did we plot her growth percentiles? And did we do a blood gas? So any child who comes in with recurrent or first episode of hypokalemic periodic paresis, please do not think about a channelopathy. Please do not think about thyrotoxicosis. Please think about a renal tubular disorder. That is the most common cause of hypokalemic periodic paresis in our population. Look at this girl, her growth 12 kilos, I did not highlight that, but this child at 6 years was 12 kilos, height was 99 centimeters. We did not plot this on the growth percentile. We did not look at the electrolytes, chloride was high. In a child who has got a channelopathy, your chloride is going to be normal, the blood gas is going to be normal. This child's bicarb was 16. The blood gas showed a moderate metabolic acidemia. Ultrasound showed she had medullary nephrocalcinosis. So now the revised diagnosis after the 3rd episode is a child who has got hypokalemic periodic paresis due to distal renal tubular acidosis. Next is a 2-year girl who presented with slow growth, polyuria, polydipsia, constipation and vomiting. Born at term with lowish birth weight. She's got inadequate growth and no physical signs of any abnormality. Urine showed trace protein, trace sugar. Electrolytes showed a mildly reduced bicarbonate. Hemoglobin was low. Any additional tests over here? We said complete urine examination, renal function test, ultrasound abdomen, venous blood gas, electrolytes. These are the only 5 investigations which we need when evaluating a child with failure to thrive, polyuria, polydipsia. VPG did show she's got mild metabolic acidemia. She has got a significantly elevated renal parameters, and ultrasound showed hypodysplastic bilateral kidneys. So this child has got chronic kidney disease due to hypodysplastic kidneys. So not everyone with failure to thrive, polyuria, polydipsia have renal tubular disorders. It could be chronic kidney disease, it could be posterior valves. And my last case is a 14 years girl, again whom we just saw recently with bilateral severe PU junction obstruction. Left was poorly functioning, less than 5%. She underwent a right pyeloplasty to preserve the right kidney function at 1 year, followed by left nephrectomy because it was poorly functioning. Creatinine of 0.8 at 2 years, again high for a single functioning kidney status. She had anemia at 4 years and 6 years, was just given blood transfusion, not evaluated. She presents to us at 10 years now with slow growth, polyuria, and at 14 years, her hemoglobin is 4, creatinine is 6.2, and blood urea of 115. So this girl has now got a CKD stage 5 due to single dysplastic kidney. Blood transfusion is required for children who have got severe anemia, but only after evaluating the cause of chronic kidney disease. So learning point is to need to evaluate the cause of anemia before blood transfusion. These are the 5 cases which we have presented. First child presented with resistant rickets was due to distal renal tubular acidosis. Second boy with poor urinary stream, PUV. Third child with recurrent hypokalemic paresis had got distal RTA. CKD due to hypodysplastic kidneys. And the other child came in with unexplained anemia who has got a chronic kidney disease. So to summarize, polyuria is a common symptom of children with kidney disease and often associated with polydipsia and failure to thrive. Please remember, polyuria alone, without failure to thrive, it could be physiological, resolving ATN or behavioral in older children. However, when polyuria with polydipsia is there without failure to thrive, think about diluted feeds, very common. It could be diabetes mellitus, central DI in an older child, or resolving ATN. More importantly, when a child has got failure to thrive with polyuria and polydipsia, it could be first CKD, obstructive uropathy in a boy, CACUT, or it could be a renal tubular disorder. Evaluation requires a stepwise approach with detailed history going back to the antenatal scans, physical examination including plotting of the growth percentiles and specific investigations which should start with complete urine examination. Request the lab to give you the specific gravity. A child who has got a specific gravity of 1030, you can say has got an intact medullary concentrating ability and does not have a CKD or a renal tubular disorder. RFT and serum electrolytes. Not to forget a venous blood gas and ultrasound. Thank you so much.
Thank you, sir, for your very nice presentations. And you have explained very nicely how the different renal causes or renal diseases can cause failure to thrive. Any questions we can ask, Dr. Rajiv?
Yeah, we can have a few questions.
Yeah,
anyone in the house with any questions?
It's a very interesting topic. If any questions?
No questions? No. Hey, Jaffa, sabhi to khelen.
Yes.
Usually in these cases, we get that the child is not thriving well. We get this because diluted feeds are given, the weight is not increasing. So you told that with the adequate growth, but this is what we find in our practice, that these kids come with failure to thrive. Might be the polyuria, polydipsia is not there, but that is like with diluted feeds.
Absolutely correct. If there is failure to thrive, then besides the diluted feeds, we need to look at the other organic causes of failure to thrive. What I was referring to in this particular group is that many times mothers in the attempt of either giving more volume, they take the same amount of milk powder, but they use 45 ml or 50 ml of water to dilute it. Either they want to feed more or they want to conserve some money. So I think this is what we have seen, and when we just inquire, they say that we are adding so much of water. We ask them to show us how much they are adding. So that could be one reason, but certainly if there's failure to thrive, that is not the reason. We have to look at other causes.
Any other question from the house? I have a question, like a practical question. In very small babies, like how do you document polyuria at home? Because they don't like to get admitted.
Correct. I know. I think that's a practical question, Raju. It becomes very difficult. One thing is we ask them to see the number of times the diapers are being changed or the nappies are being changed, and daytime and at night time. So that is one thing. And is the diaper heavy? Is it, again, it's going to be a subjective evaluation by the parents. That's one. Second thing is we ask them to compare with the sibling. In case if they have a sibling, it's very easy to compare how many times the older child was passing urine. And
Yeah,
that
that's-
becomes a reference point to say whether it's more or less. Yes. I know in an hospital environment we do that, but since this was at home, Shakil.
Like we have sometime
Yes.
asked them to get that weighing scale from the the cornerstone.
Absolutely correct. That's something which we do it in the hospitals also, but that's another way of looking at it, Shakil. Absolutely.
Yeah, we can measure
Yes,
at home
yeah.
also. Thank you.
Thank you so much, Dr. Mehul Shah sir, Dr. Mukta Manthan ma'am, and Dr. Rafiqul Rahman sir for the engaging session. I would kindly request ma'am and sir to collect the memento from the memento corner from Dr. Jayati Sengupta ma'am.
So we now break for the tea break. We'll quickly have tea and try to come back and start the next session in 10 minutes. A quick announcement for the poster delegates, those who are supposed to be presenting posters.
Okay, before
today.
going to the tea breaks, for the poster delegates, please submit your PPT for the delegates who are supposing their original articles. It is at the boardroom, just left outside the room. Go to the boardroom, upload your PPT. Dr. Aditi will be there to help you. You have find your subgroup, I think, subgroup A1, A2 and A3. And those with case posters and case series and case reports, go to saffron room. Saffron room is straight left. There is also Dr. Subhankar and others are there to help you. If you don't have a pen drive and your PPT in your pen drive, then please let us know. We'll try to retrieve your email. So please upload now only before the tea session. Otherwise we'll be late. So for the poster delegates, please upload your PPT now. Hall.
I request you, sir, to kindly introduce our moderator for the session, Dr. Himesh Burman.
Good morning, everyone. So I was supposed to be with Dr. Shukantu Chatterjee, but somehow is down with fever. So we have our next session, which is a child with red urine, and our moderator is Dr. Himesh Burman. I would kindly ask Dr. Himesh Burman to come on the stage. Dr. Himesh Burman. So he's a professor and HOD, Shillong, years of practice 18 years with interest in glomerular disease, AKI, medical education and quality improvement, 46 publication, H index is 10 and achievements of established pediatric nephrology services, past secretary and president of IAP Meghalaya, past secretary of APNE and Purvanchal Pioneer Awardee. Over to you, Dr. Himesh.
Thank you, sir. So, good morning, everyone. So, we are going to start this discussion. So, I would want to invite my panelists on the stage, Dr. Divyani Roy Chaudhary. Sir, are you there? Yeah, sir is an associate professor at Medical College, Kolkata, and he's a very active IAP leader and a strong opinion leader. Dr. Swarnim. Dr. Swarnim is associate professor at AIMS. Dr. Pragya Pan. Yeah. Dr. Pragya is associate professor of nephrology at RIMS Ranchi. And Dr. Suchismita Saha. Dr. Suchismita is a young pediatric nephrologist, finished her fellowship in pediatric nephrology and currently working at Medical College Kalyani. Welcome all. And we have experts with us for this program. Dr. Karhui. Madam needs no introduction. We had a beautiful session with her yesterday, and she will also be talking about on the microscopic hematuria in the next talk. And she is from Singapore. And Dr. Rajiv Sinha, and who is our very own from ICH Kolkata. So let's start the discussion. So today in this next 40-45 minutes, we will continue this discussion with this objective. At the end of this discussion, we should be able to distinguish between hematuria and red discoloration due to other causes, differentiate glomerular and non-glomerular hematuria based on clinical clues, identify red flag and that requires urgent referral to pediatric nephrologists, and interpret common investigations like dipstick, microscopy, and imaging. Understand a stepwise approach and when to investigate further. So before we start, just a teaser for all of you. You don't need to answer. Keep the answer in your mind. If a child comes to you with red urine, what comes to your mind first? Okay? So hold that thought and let's go to the rest of the panel discussion. So we all know that red urine is it's not uncommon in clinical practice, and sometimes it brings some diagnostic dilemma. How do we approach and how to go about it? And in these next 45 minutes, we will try to take it on a case-based level and find pertinent questions that are practical for our clinical practice as a pediatrician. The whole talk is focused on pediatrician, and we are limiting ourselves to the diagnosis mainly. We're not going to management of the conditions. So how do we go into it? Okay, so Dibyendu sir, first question I would like to ask you, and the format is, as I narrate the case, I would want all of you to think about the answer. You get just 10 seconds, maybe hold that thought in your mind, and then we will come to Dibyendu sir. So here is a 5-year-old child with mild periorbital puffiness, blood pressure of 136/86. You have given this stage 2 cutoffs are given there, altered sensorium, and that presented to emergency department. On history of urine output, there was not very clear-cut history. The child was admitted to the ICU for the altered sensorium and the severe hypertension, and the Eurobag shows this color. So what do you think? Just 5 seconds, no responses in between, hold your thought. Dibyendu sir, what's your clinical response?
So as
approach?
we are seeing in this case, this is a 5-year-old child who has mild edema and hypertensive, and the urine color is showing here, which is maybe high color or cola color. So it is a reddish urine. So first we have to differentiate whether it is hematuria or not hematuria, number one. And if it is hematuria, then we will try to find out the etiology. So that should be our approach, and in that perspective, our clinical approach should be, first I would like to take the history in detail and then the clinical examination. So for history, we try to ask whether there is any recent sore throat or any upper respiratory tract infection, whether there is any skin lesions like boils, folliculitis or ulcer, whether there is any LUTS, lower urinary tract symptoms like pain, dysuria, burning sensation, etc., to differentiate from glomerular and non-glomerular hematuria, and whether there is any intake of any drugs which can cause these colors of urine, and any history of trauma or any bleeding disorder. So
yes,
that
sir,
history
I'm
should
just
be
interrupting you, sir, here. So if we look at the history, this child presented with periorbital puffiness and hypertension and a red urine. So it looks like, prima facie looks like a nephritis.
Exactly,
right?
exactly.
So our approach would also go towards looking into the etiological causes of types of nephritis, like whether we have multi-system involvement, and as you pointed out, sore throat or skin infection. Yes, sir. Please go ahead, sir.
So for that reason, we have to ensure that, and then we for thorough clinical examination, and for clinical examination, whether there is a pallor, there is edema and hypertension in which grade, the sensorium. So these should we take into consideration.
Okay. So here some more clinical details I have added. It's not a complete list, but the child did not have any fever. Child was otherwise well before this acute onset problem. There was mild swelling of the eyelids for one list, which parents ignored initially. Urine output was not, parents were not sure about the urine output, but when the child was admitted to ICU because of the hypertension and for a provisional diagnosis, furosemide was added and the output recorded was 1.3 ml per kg per hour. But on proper exposure and examination, we find that there are some healing skin lesions of impetigo in the leg. So, and the sensorium gradually improved as the blood pressure was control. Dibyendu sir, does that makes things a bit more
So
clear?
there is hematuria, hypertension, altered sensorium. So there is nephritic syndrome, and it may be post-infectious nephritic syndrome.
So we'll have to, yeah. So next I come to Dr. Pragya. So once we have clinically collected this information, how would you want to investigate this child, your laboratory approach?
So this is a case of glomerular hematuria. It might be either acute nephritic syndrome. Syndrome-wise, it can be acute nephritic syndrome. It can be rapidly proliferative glomerulonephritis. With this in mind, I would like to order some basic tests like CBC, LFT. KFT will be very important to differentiate between the acute nephritic syndromes and rapidly proliferative glomerulonephritis. If we find that there is a derangement, marked derangement of renal functions, then goes more in favor of RPGN. And because it is some nephritic disorder, so I'll also like to investigate for the etiologies in the form of urine routine will be done, urine albumin creatinine ratio, urine routine to confirm the proteinuria, to confirm the hematuria and whether pyuria is present or not. And then C3, C4, that is the complements levels, and ASO titer, and if available, anti-DNase B titer should also be done.
So, ma'am, from the madam's approach, it is clear that please do not assume any nephritis to be post-streptococcal nephritis straight away. You need to keep your mind open and collect enough information to be able to make a positive diagnosis of post-infectious GN. So here, when some of the investigations are there, so it had a dipstick positive, and there are plenty of RBCs per high power fill, and there is protein in the urine. Protein creatinine ratio was 0.9, so that is in the more than normal of 0.2. Then blood counts are more or less normal. Creatinine of 0.7. Dr. Pragya, what's your thought on the creatinine?
Creatinine is normal, so we can safely rule out rapidly proliferative glomerulonephritis.
Yeah.
Now it turns out to be a case of acute nephritic syndrome, which can be due to many causes, most common of which is PSGN, but other causes also need to be ruled out.
Kept in mind. But also remember that if you calculate the eGFR on a creatinine of 0.7 for this age, it would come around 86 or something. Nephritis may have a slightly depressed, that is okay, but mind you that it could be 0.9 or 1, and if you may assume, sometimes think that that is normal, but remember that you need to look for the age-specific cutoffs for creatinine when you are evaluating such a child. Thank you, Dr. Pragya. So we can come that there is a glomerular hematuria and most probably post-streptococcal GN. So now another common cause of gross hematuria is IgA nephropathy. Right. So how would you differentiate this case from IgA nephropathy, Dr. Pragya?
If we consider this case, so it is less likely to be IgA nephropathy.
Right.
First of all, basic fact that PSGN is much more common than
Yes.
IgA nephropathy. Second thing is that the patient has a very acute course, and certain symptoms which are commonly attributable to PSGN like hypertension and altered sensorium are present. And patient has a history of skin lesions also, they were there. And most important, C3 is decreased, which is not a feature of IgA nephropathy. IgA nephropathy does not involve the complements.
Okay. So just as a show of hands, can I see how many of you regularly do C3 when you are making a diagnosis of PSGN? Okay. So that's a good number. So because it's important, if C3 would have been normal, then we would have thought about some other causes. And also, it is also important that you need to follow up the C3, right, Dr.
Yes.
Pragya?
So one thing is, if C3 would have been normal, then we would not have left this case like this. We would have in the initial go when the patient stabilizes, we should be doing a kidney biopsy. Because if C3 is normal, then it is likely to be certain other etiologies also, and the possibility of IgA nephropathy will be very high. Even if it is depressed, we have to follow the patient. We have to follow the timeline, and if the reduced C3 persists over a period of maybe after even 12 weeks, then also we need to do a kidney biopsy to rule out certain other causes like C3 glomerulonephritis, MPGN.
Yes, thank you. IgA nephropathy develop after a viral infection within 48 to 72 hours.
Yes.
That is the most important differentiating point.
Right.
Diagnosis.
Right, sir. That's correct. That's a classical picture, but in real line situation, you sometimes here, as I said, oliguria is a very important feature of nephritis, but the history of oliguria itself was not there. So there could be a lot of things that actually you may not have all these details. So it is important that we try and document wherever possible these factors. And regarding skin infection, if you survey, go to low socioeconomic status, if you survey a lot of children, you can get skin infection in many cases. So just having a coincidental skin infection may not necessarily make it a PSGN in all the cases, because we are talking about a highly prevalent condition in the society. So you are correct, sir, but there could be misses, so we should try and make our diagnosis much more precise. So that's why we should go it. But if you do not have resources, a clinical judgment would be still fine. And when you follow up, you have to see whether the patient is behaving like a PSGN or not. And at any point the patient is not behaving like PSGN, then you please take help of a pediatric nephrologist or make a referral. Yeah. So just an approach. So we did a dipstick, then we had a proportionate number of RBCs in urine. So that means we have documented that this is hematuria. Then the urine was cola colored. There is features of nephritis that gives rise to our impression that this is a glomerular hematuria. And because there was a history of healing impetigo, low C3 and ASLO positive makes the diagnosis of PSGN. So the key points, here this is how this looks like. A microscopy of the urine microscopy for this one, and these are RBCs that are being shown. Another point that we can, normally pathologists do not report it, but when you have a problem between whether it's glomerular or non-glomerular, you can ask your pathologist to look for dysmorphic RBCs in the urine, and your pathologist can still comment, because the gold standard is a phase contrast microscopy, and light microscopy, many of them do not make a report, but if you talk to them, they may be able to tell you, even on light microscopy, whether there are dysmorphic RBCs or not. These are light microscopy picture given by one of my colleagues in my institute. So these can be looked for differentiating between glomerular and non-glomerular causes. So key takeaway for pediatricians, any child with hematuria, edema and hypertension, think of glomerular disease unless otherwise proven. A PSGN should have low C3 and it improves by 6 to 8 weeks, and if either it did not have low C3 or if it doesn't recover on time, it should prompt that there could be an alternate diagnosis, and please make a referral for this patient. Pediatrician can manage the initial phases, but if there is prolonged proteinuria, rising serum creatinine, or normal at presentation, or persistently low C3, you should make a referral. Dr. Suchismita, we spoke about two tests, dipstick and microscopy. So which one do you do, and in what sequence do you do in your practice?
Sir, so
and can you compare these two also?
In the institute where I am presently working, usually when a child comes with high colored urine, the first test that we do is a urine dipstick. The reasons being that it is easily available, the cost is cheaper, we get the results immediately, the interpretation that we have, and also because it's a bedside test, it can be done as when the patient is there in the OPD itself. Moreover, urine dipstick is a very sensitive test to diagnose the presence of RBCs in urine, and it is basically, as we know, the free hemoglobin in urine, which has peroxidase activity and converts the tetramethyl benzidine that's present in the urine dipstick to its oxidized form and gives it the typical color that is seen.
How do you compare microscopy and urine dipstick?
So usually urine dipstick, as we just discussed, that it's a sensitive test, but we know that the disadvantages are that even if there is hemoglobin or myoglobin in urine, the dipstick will come positive. Moreover, if the patient is having a urinary tract infection and has microbial oxidases, it can also give a false positive test. So always a better test is urine examination by microscopy, because it will help us find the presence of RBCs in urine.
Dibendu sir, what is your practice in your medical college?
In our practice, we do microscopy first always, because always the dipstick is always not available for the reason, and there are some advantages also, as we are seeing. It is more specific for hematuria, and there are other informations like RBC morphology, cast, it should be available there, though it takes little bit time.
Okay. So again, raise of hands, how many of you use dipstick in your practice in evaluation of hematuria? Okay, so very less number of hands. So what is recommended is, because it both has its pluses and minuses, so it's probably good to combine both. So use both in sequence. If you, either approach could be okay, you do a microscopy first or a dipstick first, but you can use both the approaches, and the algorithm that we have provided you in the handout gives the both type of approaches, one with a microscopy first approach and one a dipstick first approach. Please do whatever suits your setting. Now we come to Swarnim. Again, before going to Swarnim, please see this and hold your thought, and let's see what Swarnim has to say about this. So this is a 7-year-old child with septic shock admitted to the pediatric ICU. And this is the Eurobag that you see in the morning rounds, when you come for the rounds in the morning and you see this Eurobag. What are your thoughts and how would you approach this? Swarnim.
Yeah. So what we can see here is that this particular child has reddish urine. So definitely, as already discussed, the approach should be first to confirm that this reddish urine is actually hematuria. So for that, we can do a bedside dipstick, but definitely do a urine microscopy, see whether it is actually showing RBCs. And then what we can do is, the next thing would to differentiate whether there is a glomerular hematuria or a non-glomerular hematuria. So definitely from that differentiation point of view, we will take some clinical clues and context and then go for the lab evaluation. So one thing which is very strikingly seen here is that hematuria is bright red in color, and the bright red color, and then if we can see clots, these things would probably point more towards non-glomerular cause. And another thing which is very strikingly seen here is that in the rest of the bag, you can see that the urine was normal in color. So this particular red colored urine has developed in a short duration of time in a catheterized patients. So this can be a very important clue towards what could be a possible etiology. So if the lab reports confirms that it is a non-glomerular hematuria, I will rather just observe, wait for the clearance, because mechanical trauma would be the most obvious cause. And I mean, if we are doing a dipstick, sometimes we actually use a multi-stick in our institute, and we can look at the leukocyte esterase and nitrates and look at the WBCs and bacteria to actually rule out like presence of UTI. And in context of sepsis, maybe additional evaluation for coagulation studies would be required if it persists. Yes. But currently, I would say that we can just wait and watch, wait if it is resolving over hours.
Yeah, this was actually a case whose catheter was not fixed properly. Yeah. And because the child was moving and then it got pulled and there was some injury in this one. That explains that why it was such a bright red, but the previous urine was absolutely fine, and then you have a red urine there. Yeah. So if you have, if diagnosis is clear circumstantially and the urine clears after waiting in the subsequent voids, then you need not necessarily investigate these children extensively in these cases. So that's the message, and this is a not so uncommon, and it's also important that we fix our catheters properly, that these children do not have this kind of injury. So here you have dipstick positive and proportionate RBC in urine. So that means there is hematuria, bright red colored urine. If you had urine dipstick, you would find absence of proteinuria. So this is non-glomerular hematuria, and clinical scenario suggests a catheter-induced trauma. And if we waited for this child, then hematuria slowly disappears. So that would make the diagnosis of catheter injury in this case. So key takeaway are sudden red urine in a catheterized child. Think about possibility of iatrogenic or mechanical trauma. Look for timing, pain, or gradual clearing of the hematuria. Okay, so if it's gradually clearing in subsequent voids, it probably is coming from a local area. Presence of clots, as Swarnim has pointed out, there was no clot in this picture, but if you have clots, then that should think about a lower tract bleeding. And in such cases, you need not extensively evaluate for other causes of hematuria, and you can leave it there. Dipendu sir, this is another child who is brought, this father has brought this urine with him to your clinic, and that this child has this one. You do a dipstick test there, and dipstick is negative. So how would you?
So this is also reddish urine. Yes. Color is not normal, it's reddish urine. So, and as the dipstick is negative, so there is no RBC and no hemoglobin. So this is probably not hematuria. This is non-hematuria. And so as there is non-hematuria, so we have to explore the history. What may be the reason? So from the history, it is obvious as a patient having history of intake of lot of beetroot in the previous day, so the cause may be like that. So we have to explore that. And there is no other urinary symptoms also. So for that reason, it points to that.
Yes. So would you want to do a microscopy also on this child?
Microscopy can be done, but there will be no RBC.
Yes.
There will be
So
no use
it's-
of
it's
it, I think.
Usually good to document both because you have false negatives in both microscopy as well as this one. So if we both are negative, we are more confident that there is no RBCs. But here is an history of intake of lot of beetroot in the previous day. So that's
that may be the cause. So that is the cause, I think, here.
Okay. So here, this is, we have, yes. Yes. Right. So if, as we follow up these cases, then subsequently the urine would be clear. So that is another clue. So we had no RBCs in urine and dipstick was negative, no hematuria, no dipstick negative, that means no heme pigment was also present, and that goes to we should take the history of food colorant, and in this case we had beetroot, and that leads to the diagnosis of beeturia. And you can have other food, like you have any colored food, ice creams, cotton candy, all those stuff can also give rise to such color in the food. So, Suchesmita, sorry, before coming there, so this makes the point that not all red urine is hematuria. So when you have red urine, first thing that comes to mind is hematuria, but think that there could be causes of non-hematuria red urines, okay? And dipstick plus microscopy is essential, okay? So either each one have their weaknesses, but if we use both, then we are better off. And history of food or drug is often enough to make a diagnosis in such situation. So talking about drug, I'm coming to Suchesmita. Can you list some food, or especially drugs, first I have already mentioned, that can cause colored urine?
Yes, so as we just discussed that certain food can be associated with reddish discoloration of urine, the common being beetroot, any vegetables containing keratin, as you mentioned, sir, any cotton candies or substances containing color pigments. The question can arise that why some patients are having the reddish discoloration while others are not. It depends on the absorption and excretion rate that varies from individuals, so it's usually not something to be concerned about. Among the drugs, the most commonly used drugs that can be associated with reddish discoloration includes the antitubercular drug like rifampicin and the less commonly used clofazimine, both of which can cause a orangish red discoloration of the urine. Along with that, the other body secretions can also have that yellowish discoloration. Then, sir, among the other drugs, pyridium, which is commonly used in urinary tract infection, can also cause a reddish discoloration of urine. Iron chelators like desferoxamine can again cause a discolored urine because of the chelated iron that is present in urine. Among the chemotherapeutic agents, doxorubicin is commonly known as the red devil because it again, because of its typical color, can cause a reddish discoloration of the urine. Again, over-the-counter use of drugs like ibuprofen can cause reddish discoloration. This is something to be cautious about because here the reddish discoloration is not benign. It can be due to interstitial nephritis that develops due to intake of NSAIDs, so we need to be concerned about that. So it's a good practice for clinicians to make parents aware of drugs that can cause reddish discoloration of urine so that there is no unneeded panic among patients.
Right. So, so if we get any child with red urine, as the approach we have seen, first we will try to document if there is hematuria, RBCs are there or not, then whether dipstick is positive, looking at any heme pigments are there or not. And if both heme pigments and hematuria is not there, as in the case with the beeturia we have seen, then we need to explore what are the food colorants or drugs can be possible. And you may not remember all that big list, and information nowadays are available and just a click away. So just look at what are the drugs the child would have taken and see any of those drugs can cause red urine or not. So that would be good. So next, move on. Doctor, yes. 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 Right. So that's what, so if well, thing is, once you have thought about something, you will find the solution. So first thing what we are insisting is think about drug as a possible red urine. As just pointed out, like ibuprofen can cause hematuria per se. Other drugs are causing reddish urine. So that is more theoretical discussion. But once you start thinking in that line, I'm sure you will find what it is, right? So Dr. Pragya, there is another child for you, a 3-year-old boy with fever for 3 days and breathing difficulty, treated by local pediatrician. Details of medications were not available, but the child looked pale. There is decreased urine output for 1 day, that's as parents told, and there is a report that shows creatinine of 5.6. How would you clinically approach this child, and what would be your differential at this point?
So this is a patient of febrile AKI, which is probably of glomerular etiology, because we can see that there is cola colored urine. So it is a febrile AKI of glomerular etiology. So the first possibility will be RPGN, rapidly proliferative glomerulonephritis, which is a syndromic diagnosis, and it can be caused because of many etiologies. The second possibility will keep, which is less common, but it is probable in this patient because there is presence of coexistent severe pallor. So might be it is a patient of intravascular hemolysis leading to pigmenturia, hemoglobinuria. And then it can be thrombotic microangiopathy also. So first possibility RPGN, second hemoglobinuria, third TMA.
Yes.
So these are my differentials.
There will be like a broad basket of differential diagnosis, as Dr. Pragya has pointed out, but once we do the dipstick and the routinary, we found that there is dipstick is positive for and urinary shows no RBCs. So how does it change your diagnosis?
If hematuria is absent, then we were suspecting more RPGN. But absence of hematuria rules out. It is a sine qua non. If hematuria is absent, RPGN can't be the syndromic diagnosis. Most probably this is a case of intravascular hemolysis. We'll investigate in that line only as a cause.
Right. So common causes, all pediatricians, you know what could be causes of intravascular hemolysis. It could be G6PD child presenting with drug-induced. There could be pyruvate kinase deficiencies and other immune-mediated hemolysis. Right. So we investigated this child. This child creatinine kept on jumping. Hemoglobin when we was 3.0, so that was very low. Despite transfusion, the hemoglobin dropped again further. So that means probably some ongoing hemolysis was going on. LDH was high, but direct Coombs test was negative, and we tested for G6PD. That was also, there was no deficiency. But when we investigated further, we found this child to have a cold antibody positivity, and our blood bank could even identify which antibody against which antigen this, wherefore I'm not included those details. So we treated this child with saline washed RBCs transfusion. We transfused using blood warmer, used peritoneal dialysis for stabilization of the child, and used rituximab, and all that helped the child recover. So this is one example where using both dipstick and microscopy helped us make a correct approach in this case. So this underscores the importance of using both dipsticks and microscopy in such situation. So key takeaways are if you have hemoglobinuria, you will have a dipstick positivity, but there is no RBC, and same can be in case of myoglobinuria also, but you have to make a clinical judgment on whether this case is fitting more towards myoglobinuria or hemoglobinuria. So if the same setting was with a child with a crush injury, we would have thought about myoglobinuria more. Always check about the hemolysis labs where possible, and track the renal function, because that can cause the pigment nephropathy. Alkaline diuresis again is controversial, but traditionally has been used, but it's important that you keep these children hydrated enough so that there could be some protection to prevention of AKI. So here RBC is in the, there is no RBCs in the urine, so that means no hematuria. Dipstick was positive, that means there is a heme pigment, either myoglobin or hemoglobin, and given the clinical setting, and we got a cold antibody positivity, that leads to a cold agglutinin disease as a diagnosis in this case. Okay. Now, Swarnim, this is a 15-year-old girl with pallor, fever, and pleural effusion. No edema, blood pressure was normal. There is history of oral ulcers and hair fall. ANA was positive, C3 is low, hemoglobin of 4.5, normocytic, normochromic, total count, platelet count 1.2. There is, sorry, again, this is, there is hematuria, but there is no bleeding from any other site, no petechiae, no gum bleeding, nothing. Urine shows plenty of RBCs, those were isomorphic, and there was trace protein. Okay, what is your take in this case?
So here we have a 15-year-old adolescent girl, and as we can see, it is a multisystemic affection. There is pleural effusion, history of oral ulcers and hair fall, alopecia, and with a positive evidence for ANA positivity and low C3. The most likely diagnosis that is coming to my mind is systemic lupus erythematosus. But in SLE, the first thing that we think of whenever we think whether it is hematuria, it could be lupus nephritis. But there is, as we go through the approach, again we have to differentiate whether it is glomerular or non-glomerular. And several points here is actually pointing towards a non-glomerular cause. If we would have had evidences in terms of a cola-colored urine, or if the dysmorphic RBCs were present, then definitely lupus nephritis would have been the most probable diagnosis. Other could have been HUS associated in cases of lupus. But in this particular scenario, where the urine is again bright red, and then we can actually see clots here with the evidence of plenty RBCs which are isomorphic, and again proteinuria is also absent, there is no hypertension. It appears to be a case of a non-glomerular hematuria in a case of lupus. So considering what could be the possible differentials here, one would be that the child has had fever. So again UTI is one of the commonest thing that we should actually rule out. The other possibilities sometimes could be that even though the platelet is not that low, but a functional thrombocytopenia is often seen in cases of lupus, so that should also be kept in mind. The third thing is that we should definitely look at the history, whether the child has received any drugs or not, because many of the times in a multisystemic affection like that, we tend to use cyclophosphamide, and then we actually can have a complication called hemorrhagic cystitis. So that is one of the possibilities that needs to be considered here. And another thing that I often tell is that when you have an adolescent girl, always try to rule out whether she is menstruating or not, because sometimes that is a common thing that we can miss out. And again, mechanical injury can be taken as one of the additional consideration because it's a catheterized child.
Right. So usually menstrual thing is a very valid point when they're collecting it, but in a catheterized child that will not be this one. But in catheterized child, like the previous child, again injury should be kept in mind in these cases. And then cystitis, it could be bacterial cystitis, it could be viral cystitis, it could be drug-induced hemorrhagic cystitis, or it could be the disease-induced hemorrhagic cystitis also. So even when the picture is like a glomerular disease, you can still have a non-glomerular cause of hematuria in this setting. So always, irrespective of the thing, try to approach it in a methodical way to find out whether it's a hematuria or not first, and then decide it's glomerular or non-glomerular, and then look at the etiological clues for these cases. So in this case, we thought about this child, we couldn't follow up, they went away from our hospital, but we kept our diagnosis as possible hemorrhagic cystitis or possibly related to thrombocytopenia. So dipstick was positive. There were proportionate RBCs in urine that makes hematuria as a diagnosis, bright red urine, and clots, presence of clots. And there was also, we didn't mention in the previous slide, but there were lower urinary tract symptoms in this case, so which points towards possibility of a bladder involvement, and absence of hypertension, proteinuria all give rise to a possibility diagnosis of non-glomerular hematuria. And thrombocytopenia, urine culture negativity in this case gives diagnosis of either a thrombocytopenia associated bleed or a hemorrhagic cystitis. 2, yes sir. Yes, sir, that's a big query marks there. So we don't know. This child, we couldn't follow that up. There was no bleeding from any other site as well. Yes. Possible, but that's one thing that we considered because it was a lower tract bleeding. Yes. So Yes. So key takeaways, even in glomerular disease, bright red urine is uncommon. So if you get a otherwise looking glomerular, but you have a bright red urine, then think about possibility of a lower cause. Clots are almost never present in a glomerular hematuria. So presence of clot would take it steer away from the diagnosis of glomerular hematuria, and think of lower tract bleeding. Thrombocytopenia, sometimes though 1.2 is a bit high for this case, but thrombocytopenia can cause isolated lower tract bleeding. So keep that in mind. So rule out coagulopathy, platelet dysfunction if you need to, if the clinical setting is like that. And in presence of lower urinary tract symptoms, urinary tract infection or hemorrhagic cystitis could be differentials. Before going there, Swarnim, just for sake of completion, not like directly related to this case, can you tell us about what are other differential of non-glomerular hematuria, not related to this case? For completion.
So the most common causes that are seen in which causes non-glomerular hematuria are hypercalciuria, which we come across plenty of time, and it could be idiopathic. Then again, UTI is one of the commonest things that we come across. Then in a catheterized child, as I said, mechanical injury. Sometimes even exercise, strenuous exercise can lead to transient hematuria, which is non-glomerular in origin. Then other things that can be because of presence of any tumors in the bladder, or there can be hemorrhagic cystitis, and even renal involvement, which is non-glomerular, could be interstitial, interstitial nephritis, or there could be polycystic kidney disease. Unusual causes could be nutcracker syndrome, and then other causes could be because of, as I said, some sort of obstructive etiologies in the urinary tract, which can also lead to non-glomerular cause.
So the key point is that you make this distinction of glomerular or non-glomerular, because your line of investigation is going to change completely. If you are thinking of non-glomerular, then mostly imaging based, and whereas if you're a glomerular, it would be mostly that investigations would be titrated to your potential differential diagnosis. Okay. So Suchasmita, here is this child with who underwent renal biopsy, and there is this biopsy was done for a glomerular disease. And after biopsy, there is reddish urine that is getting collected here. So now your resident is worried that because it's a glomerular disease, so is it the glomerular disease causing hematuria, or is it the biopsy causing hematuria?
Okay, sir, so if we see the consecutive urine samples that are collected, a thing that is strikingly visible is that the color is gradually fading, and 4 being the latest urine that is collected, it is almost as clear urine. So we know that post-renal biopsy, mild hematuria, transient hematuria is a common finding, and if bedside we collect the urine consecutively in different containers and see that the color is fading over time, probably we should not be worried that it is a sudden glomerular cause that is causing the hematuria. Basically, once the child gets adequately hydrated, the urinary tract gets flushed, the color fades. So I think that this is probably non-glomerular hematuria and nothing much to be worried about immediately.
Okay. So as you have pointed out, some hematuria could be seen post biopsy, and that is fine. And here the color also looks like bright red color, so that points towards a non-glomerular hematuria, and it's fading with each void. So that all point towards a non-glomerular and biopsy associated hematuria. So that brings us to the end of this panel discussion. So to summarize the key points, all red urine is not hematuria, that you need to keep in mind. A methodological approach is important. So use both microscopy and dipstick in your approach. Use dipstick first is preferable, but if your setting doesn't allow that in some situation, a microscopy first approach is fine. Why the discrete advantage of using dipstick first is it saves time. You can take decision at bedside in this situation. Microscopy usually need to wait till the evening or next day sometimes to get your report, so you lose a lot of time there. UTI, trauma, bleeding diathesis, and a typical PIGN can be managed by pediatrician or allied specialty, but most other causes needs further focused investigation and treatment, and therefore it merits a pediatric nephrologist consultation. So thank you. Any closing comments from any one of you?
Is that in both the cases we saw that the urine which I discussed was bright red in color. One thing that I would like to add is that when we are evaluating, we should also look how long it has been standing. Sometimes just the appearance can be misleading. So if it's a long standing urine and it is looking brown, we should actually not really take it as an evidence, because even in a non-glomerular cause, on a prolonged standing, it can actually get lysed and get oxidized and it can have a pigmented appearance.
Yeah, that's a very important point. Sometimes, say suppose there was a hematuria in the evening and the resident thought that, okay, let the faculty come tomorrow morning, I'll show you the sample. And by the time standing in the urine for some time morning, when you come, the urine is dark red, and you don't mistake this for a dark red or glomerular hematuria, because we know that the difference occurs because of standing in acidic urine and conversion to acid hematin, and these can sometimes be misleading. So, so keep that factor in mind when you are interpreting whether hematuria by color is glomerular or non-glomerular. Very good point brought out, Dr. Sen. Ma'am,
So one thing I wanted to say, like as we discussed that urine, if it is hematuria or not, should be confirmed with urine routine microscopy to see the presence of RBCs. But we should keep in mind the importance of time here again, because if we are doing a urine microscopy, it needs to be processed immediately. So if we keep the urine sample and think of processing it the next day, or even if we are sending it to the lab and they're processing it the next day, we might not get the report that we want. So it can lead to misinterpretation.
So there can be lysis of RBCs in the urine if it is allowed to stand. So that can give false negative. Yeah, Pragya ma'am, any thoughts?
I think the most important takeaway from today's discussion will be that whenever a case of hematuria comes to us, first of all, just think whether it is lower urinary tract or upper urinary tract. If it is lower urinary tract hematuria, plan your investigations accordingly. Look out for the causes which can lead to such a case. And if it is a upper urinary, that is glomerular hematuria, then again think whether it is acute nephritic syndrome, whether it is rapidly proliferative glomerulonephritis, or it might be certain other cause of AKI like we discussed, pigment nephropathy, and then plan the investigations accordingly.
Okay, Dibyendu sir.
So when a patient with reddish urine comes to you, first you have to differentiate whether it is hematuria or non-hematuria. Then if it is hematuria, then you have to find out the cause. And if it is the hematuria, and if the cause is like rapidly progressive, and you have to work first.
Yes, thank you. And if there is any doubt, then you can always reach out to your friendly neighborhood pediatric nephrologist, as Dr. Rajiv says, right? So they are all around. So you can, they are just a call away. So please reach out to the person you are comfortable with, and then you can always discuss this. So thank you so much. And because we have 2 minutes time, I would want to take this opportunity on behalf of all the panelists and myself to thank BSPN for giving us this opportunity. Thank you so much. And over to experts. Yes.
Thank you, Dr. Varman. Very interesting and nice case presentation regarding a child with red urine. Continuing with that, we'll be having a diagnosis and treatment algorithm of the same.
So basically the diagnosis algorithm, and this was primarily done by Himesh, and then both me and Dr. Karvi did give some input. So as Himesh, and you don't have to take a picture of this because it is in your handout, and we will definitely post it also in your WhatsApp group. So as Himesh said, that there is two ways of approaching. One is that you can go for a urine microscopy, or you can go for the urine dipstick, and we had a healthy discussion between Dibyendu and Suchismita, like which was the urine microscopic or the urine dipstick. I'll not go into the detail of this, but basically another thing I want to add is like urine microscopy is very good if you are doing it immediately, and urine dipstick is very good if the dipstick is not expired and you have kept it in a nice way. So just remember that. So if we are going for the urine microscopy, then obviously we have to remember that all that glitters is not gold. So all that is red is not always blood. So you have a red urine, but your RBC is not plenty. Then so a red urine, even if a RBC is 10, 20, I would say that it is the red urine is not because of hematuria, it is because of some heme. So it can be hemoglobinuria or a myoglobinuria, or it can be a non-heme thing, some sort of dye. How do you distinguish it? Because in if it is dye based, then your dipstick will not be positive. Dipstick positive, red urine, dipstick positive can be only two things. Either it is RBC or it is hemoglobinuria or myoglobinuria. Red urine, dipstick negative, it is usually some sort of a pigment like those bituria. Red urine, dipstick positive, RBC positive, that is hematuria. So that's what is documented in both of it. And once you have documented that it is RBC, that is the main thing, that is it is hematuria, then very important thing is complement. And one thing I am very happy today is like when it's almost, I think, more than 10-12 years that I've been back in India. When I did the first sort of a thing like this, most of the pediatricians said that they are not looking at C3. Now I'm sure Dr. Pahari, who has been doing this much beyond my time also, like he will also agree that maybe previously they were not doing C3, but now I feel very happy that you are looking at C3 now. Most of you raised your hand and you are following up the C3, because that is the most important thing in differentiating between the PIGN and the non-PIGN, because often the history is so question of Rafiqul Bhai is like whether we should be doing C3 or C3, C4 both. I normally yeah. So I'll try to answer that quickly. So I usually send both C3 and C4. Just remember that C3 low, C4 low is most probably, if we think of the common thing, is the SLE. But then in 10% of the population, normal population, you can have a low C4. So those are the other things you have to remember. But if you are having a normal C3 and hematuria, normal C3 hematuria, it is all those things like the IgA and Alport. Alport is something that is coming up very big, and Dr. Karhi will be dealing with this in the next lecture also, because of some new development that has come up, where it is being pushed that if you can diagnose Alport early, then you can delay the end-stage kidney disease. Some says that maybe even prevent the development of end-stage kidney disease in the lifetime. So I think that's all I wanted to dwell on this algorithm, because it is with you. You can have a look at it, and we can have another 5-10 minutes for any questions if you have. Dr. Karhi, do you want to add anything?
I think this is super intensive discussion. I think it's great. Maybe I just have one comment. I remember one patient that came to me for gross hematuria, and I actually asked one question which was very, very discerning for me, and that was whether the urine stream, the color of the urine stream, whether it changed in color. In other words, do you have more red or more dark red in the initial part of the urine or in the later part of the urine? Some patients can say the answer, some patients can't. But if you have a patient that can tell you, oh, it's very clear, the red color urine only comes out at the end of the stream or at the beginning of the stream, then clearly you already know this is not a glomerular case.
So
and you don't even need to do
terminal
anything.
hematuria, if it's a terminal hematuria, then it is more likely something lower down. It is happening.
So just one question might be enough for you to differentiate between glomerular and non-glomerular. But not all patients are able to say that. A lot of parents will say, oh, I just see it in the toilet bowl, and then you can't, right? But if you just ask the patient to just notice it, then that actually can be a very important
And nowadays with the smartphone, I always ask them that next time when it is happening, can you take a video of it? And you can see, like I have got few videos where initial all white, then at the end, drop by drop, the red urine is coming. Any other questions or comments?
Two basic questions. One is, what is the
Faculties are not
cutoff?
supposed to ask questions. Anyway, yeah.
Very nicely presented, Himesh. Just a few things, like when you want to see the dysmorphic RBCs in urine, so ideally you should be doing the phase contrast macroscopy, which is not available in most of the centers. So that becomes a bit of difficult. Even if you say to the pathologist to look for dysmorphic RBC, it becomes very difficult in most of the centers getting that being done. Even in our centers, it becomes very difficult picking up that. So that's one point I want to raise. Secondly, what is the cutoff of RBCs, number of RBCs that you see? Because various countries across the world has different cutoffs. Like Japan, which does the routine school screening programs, their cutoffs are slightly on the higher, maybe 8 to 10 RBCs per. But normally, as per the ISPN guidelines, we take 5. But current consensus says that even 3 could be, like in US and all, they are more strict about that, and even 3 RBCs per hyperfield can be significant. So any number of RBCs is not good, rather than taking a cutoff of 5. So your take on this?
So, this is for definition of hematuria. So we are
Right.
sticking to that 5 ISPN guidelines, so we'll not confuse the crowd here. Regarding dysmorphic RBCs, if you have noticed, we have not put a lot of emphasis in our case discussions and arriving at a diagnosis on dysmorphic RBCs. We debated that, and we know that it would become more theoretical than practical, because most of our urines are not reported as having the proportionate disproportionate RBCs. But again, I spoke to a couple of pathologists in our institute also. If required, they can give us an estimate of dysmorphic RBC. So if you are confused, we can talk to our pathologist one-on-one, and they may actually be able to tell us. Again, absence of dysmorphic RBCs will not rule out a glomerular hematuria. That is another caveat. So presence, it's a specific sign, but it's not a sensitive sign. And where you draw the line, so normally 20 to 30% is taken as a thing, but there are differences. Even some centers say that 70 to 80% they take. Higher you take, more specific it becomes. Lower the cutoff you take, less specific it becomes. But it is not a sensitive sign of glomerular hematuria.
Just a quick point to add what Dr. Himesh just now mentioned. A friendly pathologist in your institution is often the key. You don't need a dark field examination for really looking at dysmorphic RBC. A freshly voided sample, even if you do the sediment immediately and do for right stain or Leishman stain, will usually identify dysmorphic RBCs. All you need is a friendly pathologist who will be very happy to look at those immediately, even at odd hours.
I think Amlan has a question.
Words on it, I think. It is quite common, I think.
So the
And
question for the panelist is like, or Himesh is like, how common is the benign hemorrhagic cystitis?
There is a pleural effusion, and ANA was positive, C3 was low, and you have shown that what platelet count is 1.2 lakh. In your differential diagnosis, come to the cystic hemorrhagic cystitis or isolated thrombocytopenia maybe. But if there is C3 is low, ANA is positive, if C3 is low, it's most likely it is the glomerular cause. So we should think from that only. We will see the isolated thrombocytopenia or is the hemorrhagic cystitis, and ANA is positive, low C3. So I think
So,
more cause is the C3.
just summarizing it, so there's 2 different questions. One is like any comment on hemorrhagic cystitis, and the second is that the case that you presented, why didn't you think of SLE continuously? So we can ask one of the panel to comment on the hemorrhagic cystitis, and then Himesh can defend his case.
Drug-induced hemorrhagic cystitis, actually cyclophosphamide induces like 5 to 40%, just variably reported. And just commenting on the second part is like when we actually approach, when we have to differentiate between glomerular and non-glomerular, and if there are so many evidences in the urine analysis, and if you are, if you're confident about the place that they have reported the dysmorphic percentage adequately, so there was no dysmorphic RBCs, there was no proteinuria, probably we did not show there was no AKI, no hypertension. So a lot of clinical clues is actually pointing towards a non-nephritic presentation.
So summing it up, firstly, hemorrhagic cystitis is not uncommon. Like being like practicing only pediatric nephrology, we do see hemorrhagic cystitis quite commonly. Usually they present with dysuria, and the culture is negative. If you are very good, you can ask for adenovirus PCR, etc. But I normally don't, because I just ask them to drink water. Ultrasound will be showing that ragged urinary bladder wall, and usually they do resolve. So it is something, it is not that uncommon, and make sure that you have ruled out hypercalciuria also, and make sure that you bring the child back to document a normal ultrasound. Now, commenting on Himesh's case of low C3 and ANA positive, I will definitely keep like maybe the cause of the hematuria may not be because of the SLE lupus, but lupus will be in my mind, and we have to rule out lupus in other ways also, and follow up this child for the complement normal, etc. But I think what Himesh was trying to highlight is that the cause of the hematuria per se was not because of the lupus. Why? No, because there was no dysmorphic RBC assessed.
Diagnosis was lupus in this case. There was no and then the hematological parameter also we diagnosed as a possible Ivan syndrome, which can be associated with.
So we will have one last question, and then we will complete.
But the hemorrhagic cystitis is known to be associated with lupus also.
Multi-system disorder.
Okay, we will have one last question and one comment by Dr. Mehul. No question is allowed.
Some dysmorphic child present with hematuria. So what are the dysmorphism looked for if a child present with hematuria in clinical examination?
So, so the question is that dysmorphic child presenting with reddish urine, what would you be looking for? So definitely we will be thinking about syndromic some sort of things, and like whether that is and do an ultrasound scan, you can have a UTIs on it, etc., etc. And hypercalciuria sometimes with a syndromic. I think we will have a comment with Mehul, and then we'll wrap it up.
I think it's an excellent discussion over here. Just a thought process over here. Urinary tract infection is not a common cause of hematuria. I think that's what I would like to share with the group over here. When an older child comes in with gross hematuria, reddish or brown, we do a complete urine examination. There are some WBCs and RBCs. Please get a blood pressure checked, because this could be the starting phase of a post-infectious AGN.
Very important point.
And we often treat this child with antibiotics, saying that there are pus cells, there are some RBCs, it's a UTI. Usually UTI does not present with gross hematuria, unlike adenovirus cystitis, that's uncommon relatively as compared to chemotherapy induced. Because in any child with acute nephritis, be it lupus or be it C3 or be it IRGN, the initial urine is going to show WBC because there's inflammation in the glomeruli. So the WBCs in the urine would be a clue that this is a glomerular.
Gross hematuria secondary to UTI is quite rare. Okay, any final comment by Dr. Asma, and then we can maybe, or Dr. Kavi, and then we can wrap it up.
Yeah. Thank you, sir. Thank you, all the panelists. That was a very nice and very informative discussion, and I think we end the session here.
I thank the moderator, the panelists, and also the experts for that excellent discussion. But I would request them to stay back for the audience quiz questions. For the audience quiz questions which are related to this session, I would request Dr. Niladri and Dr. Rohit to please ask the questions.
So continuing with our quiz for the second session on the Mentimeter. So for those who have been with us since morning, they have already known that you have to click on the link that has been posted in the delegate group and the faculty group as well, and wait till we start. And those who have joined later, we have posted a link of Mentimeter quiz in your group. You just click over there, put your name, and wait for us to start. And for all, if you have network issues, the quiz might load a bit slow or later on. So you have to be very fast, and only the fastest finger will win. So tell me when you are ready, then we will load the quiz. Your screen might be showing something like this, that to get ready, and don't click anywhere else. We wait till 100. 100. So here we go. So this is a 5-year-old boy with gross hematuria for 3 days. Urine shows blood 3 plus, 2 plus protein, normal BP and creatinine. Complements are normal. How to differentiate glomerular versus non-glomerular cause?
Excellent.
Okay, excellent one.
Explanation ta dida.
So it has already been discussed that the presence of clot is usually from the lower urinary tract, and that is a non-glomerular cause. So get ready for the next question. Question number 2, please.
Excellent. 108.
108 players are ready. So here we go. An asymptomatic child is found to have microscopic hematuria during a school screening. BP and renal functions are normal, no family history. What is the next best step? Excellent.
Excellent.
Excellent, excellent. So the previous talk has been excellent. Thanks to the panelists, Dr. Himesh, Dr. Rajiv sir, and everyone. So definitely, when you are getting an asymptomatic hematuria, don't go into fancy tests. Wait for at least 2 weeks to repeat the tests. And if you get persistent hematuria with other issues, kindly refer to us. Otherwise, it is our bread and butter only. So thank you so much. We'll go for the next session. Thank you. Thank you.
And though 96 people put right answer, the fastest finger got more marks. So it is between 500 to 1000. Okay, thank you.
So thank you. So I would request the faculties of this last session to kindly collect their mementos from the memento corner. So now we move on to the next lecture, which is a plenary lecture by Dr. Karhui ma'am on management algorithm of microscopic hematuria in the current era. And to preside over the session, I would request Dr. Raja Lahiri sir, Dr. Priyankar Pal sir, and Dr. Shopan Kumar Rai sir to kindly come over the stage. Dr. Raja Lahiri sir is a renowned pediatrician and neonatologist. Dr. Priyankar Pal sir, he is the professor and head of the Department of Pediatrics and also head of the Rheumatology Unit in Institute of Child Health, Kolkata. And Dr. Shopan Kumar Rai sir, he is the president of the West Bengal Academy of Pediatrics. So over to you, sir. Kindly introduce the speaker.
Hello. So it's a good afternoon, and in this session I will request Dr. Karhui to deliver this session. And all of you know Dr. Karhui for the last 2 days, and she is practicing for 24 years. She has got publication of 40, and with a high index of 18, and interest is genetic kidney disease. So he has got a lot of achievement in her baskets. So without wasting time, let's hear to her. So welcome, ma'am, in Kolkata, and please proceed.
Thank you. Thank you for having me here. It was such an exciting trip this time. I'm here with my daughter, and I really want to thank Dr. Rajiv and his team for being so hospitable to me and my daughter. Really, really very appreciative. And I'm very happy that this talk is after the previous intensive discussion on red urine, because a lot of the things have already been discussed. So that makes my job really easy. So let's see, how do I move this? Okay. Oops. All right, so I will start off with a patient here. So this is a real patient that I was referred was referred to me is by a good friend of mine who's a general pediatrician. It's a 3-year-old girl that came to her for fever, and as part of routine evaluation for UTI, a urine check was done, and that revealed hematuria. And then I think this one would have been covered just now already. There was some discussions about what is the cutoff in the definition of hematuria. I think there is no real consensus. The KDIGO did say it should be more than 5 per high power field. And the KDIGO feels that the high power field is better than microliter because it is a centrifuge sample. But I think in general, if it's more than 5, more than 3, typically a real hematuria, you'll usually be in a double digit or more. So after we confirm that this is hematuria, we got to make sure that it is indeed persistent. So as mentioned earlier in the Mentimeter question, you would want to repeat it 1 week, 2 weeks later, and if it's persistently there for 3 consecutive samples, at least a week apart, and it's not associated with anything else like exercise, trauma, etc., then you will say that this is persistent microhematuria. So in this particular patient, it was already repeated by my friend, the pediatrician, and it was indeed persistent, and hence it was referred to me. So my talk is very simple. I'm just going to divide it into 3 big parts here, trying to answer the question of how you should manage a child with microscopic hematuria in a primary care practice. And I will cover a little bit on the typical diagnostic pathway. Then I will talk about why you should think genetic, why, and then how. Okay, so the typical diagnostic pathway, is it hematuria, is it persistent, is it glomerular or non-glomerular? Okay, fine. We have lots of discussion on this. I'm not going to cover very much. But I think if you have a patient that has pain, that pain may be dysuria, maybe pain in the suprapubic area, maybe pain in the loin area. As long as the patient has pain, it's more likely to be non-glomerular. I'm talking about microhematuria. If the patient also has passage of anything that was solid, it could be sandy particles, it could be literally solid particles like that, then that already tells you this is likely to be non-glomerular. We talked a lot about dysmorphic, CAS, and all that. I think in my experience, I find the dysmorphic red blood cells to be quite unhelpful because often the urine is not being processed immediately, and the dysmorphism percentage is often a very subjective percent. So I've seen patients with clear-cut glomerular clinical picture having isomorphic urine red blood cells. So I don't find that very helpful. But anyway, in isomorphic RBCs, essentially the RBCs are like, very round. But in dysmorphic RBCs, basically they have protrusions coming out, and they have irregular shapes or donut-looking shapes. If you have the ability or facility that can tell you whether there's red cell CAS, then that itself would be very specific for a glomerular disease. But I know not all facilities will have that. So, if you are able to find a clue as to tell you whether this is glomerular or non-glomerular, then you can do very targeted investigations, right? So if you have a clue that this is non-glomerular, then you do the investigations according to the likely differential diagnosis. If you are lucky, you find a cause. If you're not lucky, you watch and see. But sometimes with the watchful watching, you might be able to, over time, realize that this is actually a glomerular case. So at this stage, most people would do the usual investigations, ultrasound, stone, calculi, and all that. And an answer may be found, and an answer may not be found. But let's say you do find something, and this patient did manifest some features of glomerular hematuria, then what next? I think we talked a lot about it just now in the discussion on red urine. It's really trying to answer what is the clinical presentation that the patient have. So in glomerular disease, I like to think of the clinical presentation of the patient. Is this a patient with just isolated microhematuria, nothing else, just microhematuria that's persistent? Or is it microhematuria with proteinuria, which may be microalbuminuria, might be sub-nephrotic range, might be nephrotic range, but just that. And these patients are typically have no symptoms, no signs, right? Because it's just urine abnormalities. Or it could be somebody with clear edema, nephritic picture, you know what I mean, how these patients look like, raised GVP, etc. Or it could be somebody with declining serum creatinine, and that would be, to me, it's like a tsunami, right? It's really fast. The patient is really sick, and you can lose the kidney in 2 to 3 weeks. And that is the one where you really need to act very, very fast, and you can't wait. And finally, the patient could have chronic kidney disease already, and to me, that's an irreversible thing. So while we try to figure out this patient having glomerular or non-glomerular, separately, we do need to look for clues clinically to put the patient into one of these clinical features. And sometimes things get a bit messy because the patients can have microhematuria all over the place. They may have other reasons of AKI or AKD. For example,
So now I would like to request Dr. Jayati Sengupta ma'am, our organizing chairperson, to come forward and give the vote of thanks.
Thank you, Deblina. Uh, I think most of it has been already spoken by Dr. Komitapa Bahari. So, good afternoon, esteemed guests, distinguished speakers, our dedicated delegates, our valued sponsors, and all these wonderful individuals who have made this event and is making this event a grand success. So, on behalf of the organizing committee of the West Bengal chapter of the Indian Society of Pediatric Nephrology, I again welcome you to this annual, this is the first time that we are holding it, the annual, hopefully going to be for years to come, the Pediatric Nephrology Conference held in Kolkata. And I stand in front of you with immense gratitude and pride to express my heartfelt thanks for the participation. First, I think I should express my deepest appreciation for our speakers and experts who have come from pretty far and near to share their invaluable this knowledge, their insights, and their expertise. Their thought-provoking presentations and discussions have all enriched us. The delegates, the doctors, all our students, the PG students, the residents, the postgraduate trainees, and students, thank you all for your heartfelt participation, your active participation today and in presenting giving in so many abstracts. It's really heartening to see that on a Sunday morning, all of you have taken the trouble of coming over and presenting your papers. And the whole engagement of all the delegates during the sessions has been really, really heartening. My sincere gratitude to the generous sponsors and partners, without whose unwavering support we would have not made this thing possible, because you must have realized that we had a very low fees for the delegate fees, and so to put up a whole conference with the ancillary, the expenditure that we all know, it would not have been possible without them. So they have also been, I think, very responsible for their commitments for advancing pediatric nephrology. And nothing is short and is of immense thanks to the organizing team. I think first comes Dr. Pahari. Every minute for every decision, I had to ring him up sometimes. And he is kind of an umbrella under which we all work. And I don't have really enough words to express how much I owe my this present stature that I am in. Next comes Deblina. Deblina has been the star of the show. I think you should all give a very good big round of applause to Deblina. She has worked extremely hard. Extremely hard is an understatement. She's worked morning and night and ensured that nothing is left untouched. Everything has been taken care of by her. Rajiv, as usual, has always been very critical of everything and has ensured that the best comes out. The best in scientific deliberations, the best in the timekeeping, and the whole conference as general is done completely without any flaw. Shushmita Di needs no introduction. Dr. Shushmita Banerjee, she's a pillar on which I know I kind of taking her for granted, because I know the pillar on which I can take a support at any time that I want. The junior team has been, apart from Deblina, has also been extremely helpful. Shakil, Shuchishmita, Shongjukta, they've all been of immense help in every minute. The delegates from the eastern and the northeastern part of the country, Himesh, Subal, if I'm missing anybody, they have all been, again, very helpful, especially with all the algorithms. A big round of thanks to Shumandro. I think again a big round of applause should go for him. He has done all the hard work for the abstract presentations, putting the whole thing together. Then comes Niladri and Dr. Tathagata Bose for the wonderful thing that we are not yet over with, that is the quiz which is going to come, all the Mentimeter and everything. Big thanks to Mr. Rohit Banerjee also for putting this show up of the quiz and helping us with the Mentimeter. I do not know if I'm missing anything. I'm sure I am, but just in case I'm not said your name, please remember that every one of you who has helped us is in my minds. And sometimes I'm not a very good orator. I keep missing things, but the whole show has been a complete teamwork, and hopefully this will continue for the years to come, and every year we'll be putting up even better shows and help spread the pediatric nephrology education all around. And thank you once again, delegates, for coming and help us and picking up the show. Thank you so much.
I thank all the dignitaries. Now we break for lunch. Thank you, sir. Thank you, ma'am. So now we'll break for lunch and we will try to come back by 1:30 so that we can be right on time for the next half of the day's event. And yes, the faculties kindly have lunch in the Saffron Hall, which is near the entry gate in the first floor. And the delegates can have their lunch in the common area. Thank you.
Ghosh Sir, who is the Senior Consultant and Neonatologist, President Hooghly Academy of Pediatrics, and Dr. Mridu Plabun Bora, who is a Senior Consultant, Pediatrics and Pediatric Nephrology at Apollo Excel Care Hospital at Guwahati. And the moderator would be Deblina Ma'am, who is an Assistant Professor at Division of Pediatric Nephrology at Institute of Child Health, Kolkata.
So this session will be based on how to approach a child with proteinuria. And I'll be moderating the session, and I'm very lucky to have a very bright group of panelists with me. I would request the panelists to come up on stage. Dr. Moshumi Nondi ma'am. She is professor in the Department of Pediatrics and also principal in Midnapur Medical College, West Bengal. Dr. Niladri Bose, he is consultant pediatric nephrologist in Amri Hospital, Salt Lake, Kolkata. Dr. Amit Satpathy sir, he is additional professor in the Department of Pediatrics of AIIMS Bhubaneswar. And Dr. Manik Kataruka sir, he is senior consultant nephrologist at Fortis Hospitals, Kolkata. And I'm very lucky to have very experienced and learned experts to be having our back in this session. Dr. Mehul Shah sir, he's consultant pediatric nephrologist in Apollo Hospitals, Hyderabad and Little Star Children's Hospital, Hyderabad. And Dr. Sushmita Banerjee ma'am. She is a consultant in Department of Pediatrics in CMRI and also honorary consultant in the Division of Pediatric Nephrology, ICH, Kolkata. And ma'am is also a member of the Senior Advisory Council of the Indian Society of Pediatric Nephrology and associate editor of the Pediatric Nephrology Journal. So I'll start off with the very basics. So we all know that the glomerular filtration barrier provides it provides a barrier to the passage of proteins such that no high molecular weight proteins are able to pass through. Some amount of albumin is able to get filtered across the glomerular filtration barrier, but majority of it gets reabsorbed in the proximal convoluted tubule. And almost all of the low molecular weight proteins, they are able to pass through the glomerular filtration barrier, but they get almost entirely absorbed by the proximal convoluted tubule. So normally, whatever protein that we get in the urine of any normal individual, 50% of it is made up of TAM horsefall protein, which is actually secreted from the renal tubules, and only 20% is albumin. Pathological proteinuria can be found in a variety of conditions. For example, if there is any glomerular injury that causes injury to the filtration barrier, thereby causing albumin, with or without other high molecular weight proteins and low molecular weight proteins to seep into urine. Tubular, when there is a tubular injury that causes low molecular weight proteins and varying amount of albumin to be present in urine. Overflow proteinuria, when there is increased amount of a certain protein in the blood and that gets filtered and that starts coming out in the urine. For example, myoglobin in rhabdomyolysis, hemoglobin in intravascular hemolysis, and secretory proteinuria, where non-albumin proteins, IgG, IgA, they get secreted into urine in conditions like UTI stones. And why is it important to learn about proteinuria? Because it's a marker of kidney disease, and not only that, it also causes kidney injury and has been associated with long-term adverse cardiovascular consequences as well. And it can be intermittent or it can be persistent. Persistent proteinuria can again be because of glomerular etiologies and tubular etiologies. So I'll start off with a clinical case scenario. So we visit a school for a kidney health screening program where we encounter an apparently healthy 8-year-old male child who is detected to have 1+ protein in urine dipstick. So my first question will be to Dr. Niladri. Can you tell us the principle and interpretation of urine dipstick test for proteins?
Thank you. We use this dipsticks-based method as a screening tool in our day-to-day practice. It is kind of a colorimetric analysis where the reagent in the presence of a negatively charged protein turns greenish, and that helps us to detect protein. Although it's a semi-qualitative kind of a method where it is characterized by trace 1+, 2+, up to 4+, and we take positive when it is trace or greater than or 1+ or more, keeping in mind the specific gravity of the urination. Why it is so? Because it has got high chances of false positivity and as well as false negativity. And high rates of false positive in which cases? Like where the urine pH is more than 7, where there is contaminants, there is concentrated urine, so that even the presence of normal protein becomes higher. And also in presence of antiseptic or iodinated contrast. It can also become as a false negative when the urine pH is less than 4.5, or if there is diluted urine, or there is tubular or overflow proteinuria. So definitely it has to be taken in a pinch of salt. It can be used as a screening marker in low risk population, and if it is detected that there is a proteinuria, it should always be confirmed with a spot or timely urine sample.
Yeah, so thank you, Dr. Niladri. You have very nicely summarized about the principles and interpretation. So now we come back to this child. So this was an apparently healthy male detected to have 1+ protein in urine dipstick. So my next question will be to Dr. Moushumi ma'am. Ma'am, what should we do next in this child?
So as we encounter this child who's apparently healthy, but dipstick urine 1+, we have to evaluate the child. First, history taking, then clinical examination. From history taking, we have to see whether there is there is history of gross hematuria, also family history of hematuria, then whether there is swelling around the eyes, legs. We have to take history of whether there was skin rash, joint pain, and also past history of urinary tract infection. We have to ask whether there is increased frequency of urination or urinary problems like incontinence, or there is interrupted stream. And also medicine history, what medications, NSAID, whatever drugs the child is taking. Also, it is very important to know whether there is past admission in hospital with some serious illness. So the history taking, we also have to ask whether there is eye problems or having any history in the family with hearing deficit. So after the history taking, we will go to examination. From anthropometry, we have to see whether there is failure to thrive. Blood pressure is very important. We have to search for pallor, periorbital edema, pedal edema, features of rickets in examination. And while seeing the mouth, whether there's any oral ulcers or over the skin's rash. On abdominal examination, we see whether there is palpable bladder, or suprapubic, in the suprapubic region, as well as whether the kidneys are palpable or not. There's also importance of preauricular skin tags or facial dysmorphism, which points to some congenital anomalies. It is very important to examine the lumbosacral spine region, genitalia, perineal region to see, because we have to exclude neurogenic bladder. So after this history taking and general examination, clinical examination, we will go to further evaluation. We will see by doing now urine routine examination. Initially in this child, we see that dipstick was 1+. Now routine urine examination, we will evaluate. Clinical evaluation, if there is suggestive of some positive findings, then like also in urine, we will see whether there is RBC or proteinuria, then further evaluation needed. Supposing after doing the routine urine examination, we see that no RBC, no protein, then we have to follow up the child. Further, after 1 week, we do a dipstick. And in that, after 1 week of doing dipstick, we see the child is negative, then we have to do after every 3 to 6 months. But if it is positive after 1 week, then further assessment needed. So the whole examination, history taking, very important. And after the general examination, it will point out whether whether the clinical evaluation, we need other further investigation, which has to be followed up with routine examination of the urine.
Yeah, so one thing I wanted to stress upon here is that don't be misled by the fact that the child was apparently healthy, because many a times we see this kind of children coming to us and we see that the child is actually having short stature, whereas the parents actually had not noticed that, and maybe they may also be having some urinary symptoms like increased frequency, etc., which the parents might not have noticed. So it is very important that when a child comes to us, even if the parents say, okay, my child is otherwise healthy, but do take some time to evaluate the child properly, take a proper history, do a proper detailed examination. So suppose we did all this, like we did a urine routine and we found that the child did not have any microscopic hematuria, but there was proteinuria 1+ present in urine routine, but the clinical evaluation did not reveal anything suggestive. So my next question will be to Dr. Niladri. Like as Moshe ma'am already told, that if in urine routine we see that there is proteinuria 1+, even in urine routine, even if there is no microscopic hematuria, even if the clinical evaluation is not suggestive, we should try to evaluate the child further, because already we have got 1+ proteinuria on 2 occasions. So, but my question to Dr. Niladri, what considerations will you, what will you think before going for a further evaluation in this child?
So on a school screening program, when we got a child with a 1+ proteinuria, when the rest of the clinical examinations are quite normal, so we should not we should not hurry to jump into any conclusion. We should keep in mind 2 scenarios, which is usually commonly we encounter. That is something is called transient proteinuria, which is quite common after fever, or after exercise, or after stress, or after dehydration, or after any kind of illness. So which should be only followed up after 1 or 2 weeks, and we should see that whether it is going out or not. And the second most important thing is that is called orthostatic proteinuria, which might be seen in at adolescents as well. Around 2 to 5% of adolescents we can see, and also amongst 66 to 19 years of age, around 20% of population it can be seen. There are some pathophysiological mechanism is working under this kind of orthostatic proteinuria, where there is intraglomerular hemodynamic changes, subtle glomerular abnormalities, left renal vein entrapment. So all these things should be kept in mind. We should follow this up, these children, like in morning urine samples, in time proteinuria with BP, and eventually this orthostatic proteinuria does not need any significant management. Only routine follow-up, BP and growth is usually required. So these 2 things actually should be kept in mind before going further into any kind of fascinating diagnosis.
Yes. So thank you, Niladri. Now my next question to Dr. Amit sir. So we have this child who was apparently healthy. Clinical evaluation is completely normal. Found to have 1 plus protein in urine dipstick on first 2 occasions, and then we repeat early morning dipstick in the early morning urine after 1 week, and that also comes out to be positive. So by this time, it is established that the child is having persistent proteinuria in the absence of any microscopic hematuria or any other active urinary sediment, and clinically the child is normal. So do we need to quantify the proteinuria? That is my first question. Secondly, if yes, then how do we quantify the proteinuria?
Okay, already madam has already told if your urine protein is 1 plus and it is it is 1 plus in 2 occasions, 1 week apart, you need further evaluation. In that, first thing you need to do is quantify the protein, right? So for estimation of the proteinuria, gold standard is always we can go for a 24-hour urine protein estimation. So how will you do that? In general practice, what we used to do is we ask the child to collect the sample, void the first sample in the early morning. From the second sample till next morning, first sample will collect the. This is what the conventional we are doing. Though the literature says you can take any time 24 hours, but convention what we are doing is discard the first urine after early morning, from second to next day morning first word to collect the 24-hour sample, then you send to the lab, right? So in that, then the second thing you need to know is, while seeing the report, not only order for a protein, 24-hour protein, you ask for a creatine value also, because that tells about the amount of urine, adequacy of sample, right? So usually creatine of anything more than 10 milligram per kg is taken to be adequate sample. If it is on lower side, then probably inadequate sample is inadequate. So always remember, don't only send the protein, 24-hour protein, always ask to do a 24-hour creatine also in that, and calculate whether it is adequate or not, right? But the problem is this creatine, normal creatine value is, studies are almost, it is in 1960s, 1560s, right? So the lean body weight, all these things are over period changed. Right now the obesity, everything is this thing, right? So probably what is normal at that point of time may not be normal right now. So once you get the report, so any protein, 24-hour protein, more than 4 milligram per meter square per hour is considered as proteinuria. So if you calculate in 24 hours, anything more than 100. In suppose in a bigger child, so if in a bigger child, anything more than 3.5 in adults, and in children, more than 1 gram per day is considered as per meter square is considered as a nephrotic range proteinuria. Anything more than 4 milligram per meter square per hour is considered as proteinuria. So that we need to understand. Seeing on the basis of that, we can whether the child is proteinuric or not, right? The problem is with 24 hours, it is cumbersome. Right? In non-toilet trained, suppose in a 1-year child or a 3-year child is not toilet trained. Even a school children, 8-year child, you can't admit the child for only to collect the 24 hours or catheterize the child for collecting the 20. It is cumbersome, right? So for that reason, what else you can do is you can go for a spot urine. In spot urine, usually you can check for the only albumin or protein. The problem is with albumin and protein is that can change with the hydration status, right? So to negate that, what you can do is you go for a protein creatine ratio, right? And that too, it is more done in the morning sample. Why morning sample? Because that will take care of the hydration part as well as the variation in the creatine excretion. Though the whole basis of urine protein creatine ratio is that we assume that this excretion of creatine is steady throughout the day, which may not be always true, right? So, so if you see, if you're not able to do the 24 hours, you can go for a spot sample. Till recent years, it is confirmed that 24 as the gold standard, right, in predicting the long-term outcome, everything. But recent studies have shown that spot urine is spot protein creatine ratio is as good as your 24 hours in predicting the cardiovascular outcome as well as the progression of the kidney diseases, right? So if you're not able to do so, you can go with the protein creatine. This recent KDIGO guidelines as well as the IDA guidelines are suggesting that you can go for a spot protein creatine ratio. So when you go for a protein creatine ratio, what you have to see is anything less than 0.2 is normal, anything 0.2 to 2 is nephrotic range, anything more than 2 is nephrotic, right? And the unit you need to see, right, always. So many times we forget to see the unit. If it is always this, what we get in the MBBS days we learn is 0.2, 0.2 to 2, and more than 2 is milligram per milligram, right? So if it is milligram per mole or milligram per gram, you need to check this thing. You have to just multiply by 10, right? So that is you need to always see in the reports, right? So don't go by the numbers, because with the numbers will change with the units. So this is how you report the spot sample. The third question what comes when you look for the spot urine is many times you get a report of proteinuria, whereas if you ask for a protein creatine ratio, patient will come with micro albumin creatine ratio. So don't worry about that. In children, at least urine protein creatine ratio and albumin creatine ratio are almost similar. You need to read the reporting carefully. In predicting the long-term outcome in form of cardiovascular outcome and renal progression, it is equally efficacious, right? So there is no, even if you get a ACR instead of PCR, it is no problem at all, right? So only thing is the way, so your protein creatine ratio, when it is protein creatine, you take 0.2, whereas your ACR, it is 30 milligrams that you need to take care of. So you check the units. So the whole message of protein quantification is you can do it 24 hours. If you're not able to do, protein creatine is as good as 24 hours. While ordering it, make sure that looking at the unit properly, and ACR is as good as PCR. You can ask for a PCR. It is well and good, right? So these are the three messages I want to give.
So thank you, sir. So yes, sir has very nicely enumerated like how do we quantify the proteinuria. So I'm not going through all these slides again. One thing I would just like to state here that whenever we are interpreting the urine PCR, ACR, we should always keep in mind that, as already sir told, that it depends upon the body mass. So it will depend upon the age of the child. So we should be using age-related cutoff. Another important thing to remember is that we should not be using these things in a child who is having AKI. Because in that case, the creatinine excretion in urine becomes very erratic, very dynamic, and as a result of that, that tends to affect the urine PCR, ACR. So it becomes very unreliable in children with AKI. So the normal values already sir told. Timed versus spot also sir told, but here I would like to say one thing. Although even the pediatric literature also says that spot samples are as good as timed samples, but in our clinical practice, like that's what I was discussing with Sushmita ma'am also, like we have seen that our UPCR values and our 24-hour values, they do not correlate that much. Like if we get a UPCR, will we be able to derive the 24-hour urinary protein excretion from that? Not exactly, although there are some formulas, but they have not been validated yet. But more or less, we can agree, like ma'am was also telling, like she did a study and she found that at least it can tell us whether it is nephrotic or subnephrotic. And that's why it's always better that suppose in a child, you have done a 24-hour urinary protein excretion first, and then when you follow up the child, it is preferable that you use the 24-hour or the time sample collection so that you can monitor the trend. See, similarly, if you have gone for a spot protein creatinine ratio estimation in urine, early morning urine, then also every time when the child comes for follow-up, you decide to quantify the proteinuria, you better stick to the early morning urine PCR so that you can understand the trend. And sir has rightly told about albumin versus protein. I won't go through all these things. So the cutoffs and everything, he has very nicely elucidated. So suppose we do quantify the proteinuria in this child, and we find that the child is having early morning PCR values of persistently 0.5 or less than that, and somebody even did a 24 hours urine protein and found that the child was having 24-hour urine protein to the tune of 435 mg per meter square per day. So my next question to Dr. Manik sir is, sir, would you like to investigate the child further, and what are the other investigations that you would like to do in this child?
Yes, as the child is having a significant proteinuria, may not be in a nephrotic range, but at least we can say the child is having a subnephrotic range proteinuria, so we should not neglect this child. Further investigations are warranted in these cases. Proteinuria less than 300 mg per day may resolve, or sometimes we don't investigate further, but more than 300 per day in a 24-hour sample is definitely needed some investigation. And the first line investigation will be a detailed urine examinations to evaluate whether there is any RBC is accompanied with proteinuria, because presence of RBC and absence of RBC sometimes gives us diagnosis. Presence of RBC definitely signifies a glomerular nephritic pathology rather than a nephrotic, like minimal change disease, and are ruled out. And then presence of any cast or any pus cells or any crystals also help us to diagnose, to rule out. In blood investigation, definitely we have to have a serum albumin levels, lipid profile, and normal CBC. Serology, viral serology is also important in a case of nephrotic syndrome because some viral like hepatitis B, hepatitis C also can predispose for some nephronephritic syndromes. And even if you are planned to treat a patient with steroids, so knowing the serology status is also important. So viral serology investigation is one of the important workup for a child with a proteinuria. And then special serological tests like C3, C4, ANA, dsDNA, and other immunological workup can be done for this child. And yes, for the we have to remember that a child with proteinuria, we have to rule out Alports. So for that, sensory neural hearing loss or further examinations of to rule out lenticonus or sensory neural deafness may be done. And last on the final investigation will be the renal biopsy, and that can give us the definite diagnosis whether the child is having which kind of nephrotic or nephritic syndrome.
So thank you, sir. So yes, sir has roughly elucidated what all investigations we need to do in a child with proteinuria. So what I'll do, I'll first, as sir rightly said, I'll just discuss the investigations that can help us in a child with proteinuria, and then I will come back to this particular index child. So in a child who is having proteinuria, as already stated before, we should look for urine routine, specifically to look for RBCs. If there are presence of RBC cast, dysmorphic RBCs more than 25%, it is suggestive of a glomerular etiology. Presence of WBCs can indicate a glomerular etiology, interstitial nephritis, urinary stones. Eosinophiliuria can be suggestive of acute interstitial nephritis, and presence of crystals should also be looked for. In blood investigation, a normal, an RFT we should always do to rule out whether the child is having any underlying CKD or an AKI. If the child is having nephrotic range proteinuria, then we should definitely look at the serum total protein, albumin, and the cholesterol. Since in children, most of the, the most common etiology is glomerular only, so it could be some glomerulonephritis, especially if active sediments are present, so we should definitely look at the C3, C4. Other serological tests like for PSGN, ASO anti-DNase B, or for lupus nephritis, ANA anti-dsDNA, ANCA, HIV serology, etc., we should do only when indicated, when the clinical features and the other investigations are suggestive of that. And we can go for a genetic analysis if there is evidence of the same, like in the form of sensory neural hearing loss or a positive family history of CKD or any dysmorphism or extrarenal anomalies. Kidney imaging, we should do a basic ultrasound of the KOB to look at whether the child is having any CACOT. Renal Doppler, if we see that the child is having hypertension, any asymmetry in kidney size, then we should think of maybe whether the child has any renal artery stenosis. In that case, renal Doppler will help. Also in Nutcracker syndrome. And DMSA we should do only if we are suspecting reflux nephropathy. So the child may be having history of recurrent UTI, and the child may be having some irregularity in the shape of the kidney or some asymmetry in the shape of the kidney. Kidney biopsy has got a very clear-cut indications, like if we see that the child is persisting to have proteinuria with UPCR more than 0.5, if the patient is having active urinary sediments, if the patient is having persistently low GFR, persistently low C3, or if there are clinical features pointing towards a suspected vasculitis, we can go for a kidney biopsy. And yes, if the child has hearing impairment and also if there is a family history of hematuria with or without proteinuria, of CKD deafness, then we should go for an audiometry. Now coming back to this index child, this is actually a child whose clinical evaluation was normal and who had actually presented with persistent asymptomatic isolated proteinuria with UPCR less than 0.5. So in this kind of scenario, since there are no active urinary sediments, so chances of any glomerulonephritis or any collagenopathy becomes less likely. FSGS, which may be primary or which may be secondary to some maybe hyperfiltration injury, becomes more likely. So in this child, these are the etiologies I'll think of, and in that case, what are the investigations that I'll go for? I will like to reconfirm with the urine routine whether the child really has any active urinary sediment. I would like to look at the renal function test. I would like to look at the serum C3, C4, and also very important will be an ultrasound KOB. And if there are features suggestive of reflux nephropathy, then maybe a DMS scan will help. And lastly, if I don't find anything in any of these things, and if the child continues to have persistent proteinuria, significant persistent proteinuria, then I can think of doing a kidney biopsy. Child with only, yes. Yes, ma'am. So family testing is also extremely important. Again, thinking of basement membrane nephropathy in a child who is having only isolated proteinuria without hematuria is not, because we don't see proteinuria without any hematuria in children with basement membrane nephropathy. So this is more or less the investigation, further investigation that I will do in a child who is presenting to me with isolated persistent subnephrotic proteinuria without any other active urinary sediment. So, okay. So, as Dr. Manik sir said, I run a couple of tests and I find that the child's blood investigations are normal. The child is having normal RFT, the child is having normal C3, C4. I again did a urine routine just to confirm, and the child did not have any active urinary sediments, and the ultrasound KOB is completely normal. So, how do we investigate this child, or how do we go forward in managing this child? My next question to Dr. Moushumi, ma'am.
Hello. Okay, so this child does not have hematuria, and also we see that USG is normal, but 24-hour protein excretion rate is less than 1 gram per 1.73 meters square per day. That is, there is subnephrotic proteinuria. This is persisting. So we have to, there's less chance of chronic kidney disease in this case, and also this child most probably will not progress to some serious kidney disease. But we have to evaluate. We have to do a periodic follow-up, 6 monthly initially. What do we have to see? We have to record the blood pressure, whether there is a body weight, the height, the anthropometry. We have to do the routine urinary examination and also the renal function test, urea creatinine, and also ultrasound. So initially 6 monthly, still if we do not get anything positive, then yearly. But if the subnephrotic proteinuria persists, it is better to give a ACI or ARB.
Yes. So rightly said. So now again I come back to this child. I twist the scenario a bit. So suppose this is a healthy 8-year-old male child. Suppose instead of having isolated persistent proteinuria, the child actually had active urinary sediments. The child had a microscopic hematuria with persistent subnephrotic proteinuria, UPCR being more than 0.5. As I told earlier, in these conditions, some glomerular etiology becomes even more likely, like a glomerulonephritis or a collagenopathy. And I run a couple of blood investigations and I see that the C3, C4 are normal, the child is having normal RFT, and the ultrasound KOB is also normal. So my next question to Dr. Niladri will be, what can be the possibilities in this case and how do you manage?
So keeping the scenario in mind, definitely some glomerulonephritis or collagenopathy will be our first differentials. Amongst them, IgA nephropathy, Alport syndrome, or some kind of vasculitis, or even FSGS could be in the top of our differentials. Now, management totally depends on our differentials, of course. Apart from the routine urine analysis, blood test, and USG-QB, there are certain things I need to highlight. Number one, that is when we often miss the pedigree analysis, whether there is family history, whether the maternal or even paternal side are already affected or not. Then most importantly, hearing screening and eye screening, we should always keep in mind that even in case of Alport, it is not that the whole classical triad will be present from the very beginning or day one only. It can eventually appear in second or third decade as well. And also routinely, we can also send, if we suspect any kind of collagenopathy or even FSGS, the whole exome sequencing. As we have already been discussing since morning that Even the cost of CT scan is almost as good as whole exome sequencing. And in case of suspected IgA nephropathy or FSGS, that can only be done through kidney biopsy. Even Alports through electron microscopic testing by kidney biopsy, it can also prove as Alports. And as far as the management is concerned, definitely the management depends on our diagnosis only. So in the next slides, we will be showing you the diagnosis as such. But the main general management is most important irrespective of the etiology. For example, promoting a very good healthy lifestyle in the form of liquids should be liberal, avoiding of fast foods. So that is very, very important. Second thingly, using anti-proteinuric agent have shown that the kidney morbidity is quite lesser if we start the anti-proteinuric agent quite early. And also during our day-to-day routine practice, we often fail to check and monitor the BP. That is very, very important with the pediatric age-specific BP cuffs. And the most importantly, growth. Growth is the most important whatever treatment we are actually using, whether the child is growing well, whether the child is thriving well, that is very important. So to monitor the growth, the height, weight, and if possible, putting it on a growth chart and serially monitoring, that actually helps us to guide that where we are correct on the road to health or not.
Yeah, so yes, very pertinent points made by Dr. Niladri.
And also vaccination, that is very, very important because many of these children will be on immune suppressive agents. So their proper vaccination is also important.
So the management overall narrows down to, we try to control the proteinuria by giving ACE inhibitors, ARBs, which also help us to bring down the BP, and also by other lifestyle modifications like maintaining optimum weight, etc. that helps to add, to prevent adding on an element of hyperfiltration injury. And then the other treatment is based on the underlying cause. Like if it's an IgAN or an ANCA vasculitis, we give immunosuppressants. In FSGS, we rule out secondary causes. If it's primary, we give immunosuppressants. So it depends on the underlying cause. So in the first case, we dealt with a child who had initially isolated persistent subnephrotic proteinuria and then persistent subnephrotic proteinuria with active urinary sediments. So, I mean, the concepts will become even more clear when we discuss the algorithm. Now I move on to the second child, who is actually a child who presented with symptomatic proteinuria. So this is an 11-year-old female who presented with anasarca, 4+ proteinuria on urine dipstick, hypoalbuminemia. Initially, the child was managed as nephrotic syndrome and the child responded after 5 weeks of daily steroids but relapsed after 2 to 3 weeks and then became steroid resistant. The child was also hypertensive. So my question to Dr. Amit sir, what are the investigations, in very brief, can you enumerate the investigations that you will do in a child with nephrotic syndrome?
So with any child with nephrotic syndrome, the common investigation what we are ordering is, first thing we already documented the proteinuria. The allied investigation, like you can go for a serum albumin, you can go for a lipid profile to look at the cholesterol and CBC. And I'll try to do a X-ray before starting steroid. Tuberculin test, nowadays we stopped doing because the RNTP also taken out the tuberculin test. So we will not, if there is a strong family history, rather I'll go for X-ray along with GF for AB, gastric aspirate for AB, and but will not do tuberculin for sure. And if you get some systemic signs, then you evaluate for the same, like if there is a thinking that it could be secondary to SLE or other vasculitis, you can evaluate for that, like doing a C3, C4 investigation. If you get transaminitis, you can look for the hepatitis B, C, other things. But this is what we require for the steroid-sensitive nephrotic syndrome. For steroid-resistant nephrotic syndrome, along with this investigation what you're doing for the steroid-sensitive nephrotic syndrome, you will consider for the 2 more things. One is biopsy and the other thing is genetic test. So I'll tell where it is biopsy is not indicated and where genetics I will not do, right? So
sir, actually the indications of biopsy will be covering in the subsequent slides. So biopsy and genetic testing. So.
Those who are steroid resistance, you need to monitor for the steroid toxicity in the form of monitoring blood sugars and eye evaluation, the calcium alkaline phosphatase, all these things, vitamin D levels you can do. So these are the common investigation, and do a ultrasound KUB before a biopsy. That is because there are certain contraindication of biopsy in a child. If you solitary kidney with a nephrotic syndrome, there you want to avoid the biopsy. So these are the things you need to keep in mind in evaluating patient with nephrotic syndrome.
Okay, thank you, sir. So we go ahead.
Excuse me.
Yes.
For the diagnosis of nephrotic syndrome, we see the PCR value more than 2 is significant for diagnosis of nephrotic syndrome. Dr. Amit said the PCR and ACR we do in the same. So what is the cutoff of ACR value to diagnose the nephrotic syndrome?
So it is more than 300 milligram.
So more than 300 is enough for diagnosis of the
yes,
nephrotic syndrome.
Yes.
30 to 10.
So for pediatric nephrotic syndrome, the current criteria that are that is evidence-based is PCR. So we do not go by ACR. Okay, we have. So if you go by ACR, it's like a guess. It's like a guesswork. But so just let me complete. So in our center, we have recently we are almost finishing a study where we are comparing PCR and ACR in nephrotic syndrome children. And just an average equation that we have found that you can use is PCR multiplied by 0.7 is equal to ACR. So PCR, if you have like 2 is your nephrotic range, 2 multiplied by 0.7 is 1.4. So 1.4 milligram per milligram would be your ACR criteria for diagnosing nephrotic syndrome. Understand? 1.4 milligram per milligram, not milligram per gram, and so you would have to convert. So this is something which is still very experimental, and so I don't want really for you to go back with this understanding. So I think for the time being, the evidence base is as per PCR for glomerular diseases in children.
Yeah, so here I would like to, yes sir, please.
So I think just for practical point of view, if we have 2+, 3+ proteinuria, the child has got periorbital puffiness, serum albumin is low, serum cholesterol is high, which we may or may not be doing. I don't think it's clinically necessary for us to do a urine protein creatinine ratio or urine albumin creatinine ratio at the first go, because most children are going to respond to steroids. This is going to be more helpful when we are dealing with steroid dependent or a steroid resistant nephrotic syndrome. This is more from a clinical point of view. Means, guidelines are different, but clinically if we have a proteinuria 2+ and all, we can.
So I would like to just make one point here that in children it's better we go for a PCR because see, in children, especially in a child who is having a difficult to treat nephrotic syndrome or maybe an SRNS, we may have a significant component of interstitial fibrosis tubular atrophy. There may be interstitial involvement, and in that case, a significant amount of non-albumin protein may also start coming in the urine. So in that case, the urine ACR may not actually reflect the amount of protein which is getting excreted in urine. So that's why it's better we stick to PCR in case of children, unless in specific conditions like not in nephrotic syndrome, but like in diabetic nephropathy and etc., where predominantly it will be glomerular injury to start with. In that case, initially we can do a urine ACR as a screening test, but otherwise we should more or less stick to urine PCR. So as Dr. Amit sir told that we went ahead with these investigations in this child, and we found that the child was having low C3, the C4 was on the lower side, and there were a lot of active urinary sediments like 10 to 15 RBCs, 5 to 10 WBCs, granular cast, and the child was also having nephrotic syndrome with nephrotic range proteinuria and hyperalbuminemia. So my next question to Dr. Manik sir, what possibilities will you consider in this child?
Okay, like in this case, C3 is low, C4 is normal. So my first diagnosis will be a C3GN. But again, lupus and infection-related glomerular nephritis can have us like normal C4. Although both low C3 and C4 are normally found in lupus and infection-related GN. And again, one point I want to highlight it is that the level of C3, that is normal levels are mostly reported as 90 to 180, but it varies. I think in this 90 level is quite high, but sometimes we have seen like 70, 80, but again in a dubious situation like no hematuria. So taking C3 isolated, it should not be in an isolated view. In a presence of proteinuria, hematuria, if C3 is between 50 to 90, we can call it a low value. But if there is no only mild proteinuria, no hematuria, C3 is like 60, 70, and the report is like cutoff of 90 to 180. So we should not give some over importance to C3, that like that the C3 is low, so he is having glomerulonephritis. So C3 value should be evaluated in the presence of every other, it should be evaluated in the context of other presence, other symptoms or other clinical investigations that are present.
Yes. So point very well taken. So I only C3 low should not worry us because transiently because of infections also it may be low. So what matters is persistently low C3. But however, if we have a low C3 in presence of, as Manik sir told, active urinary sediments or maybe other extrarenal features like joint pain, rash, etc., in that case we may consider, and we may consider the possibility of SLE nephritis. So yes, so in the context of nephrotic syndrome, how are the serum C3, C4 levels important? How are we going to interpret? So if we see that a child is having nephrotic syndrome with normal C3, C4, possibilities can be FSGS, minimal change disease, IgA nephropathy, HSP nephritis, ANCA vasculitis. Rarely Alport syndrome, because Alport syndrome usually doesn't manifest with nephrotic syndrome. Low C3, normal C4 can be there in lupus nephritis, C3 glomerulopathy and infection-associated GN. And both low C3, C4 may be found in lupus nephritis, infection-associated GN, membranous nephropathy. Let me also iterate one fact that C3 glomerulopathy can sometimes have normal C3 levels also. So in this child, since C3 was low, normal C4 with lots of active urinary sediments, I will consider the possibility of lupus nephritis, C3 glomerulopathy. So my next question to Dr. Moushami ma'am, how will you investigate this child further?
Now, as you said that there is low C3, low C4 also, there is hematuria, persistent, there is proteinuria, 3+ with granular cast. So initially I will go for antinuclear antibody, then serum dsDNA, and definitely most important, we will go for kidney biopsy.
Yes. So yes, so these are the investigations that we need to do to clinch the diagnosis. My question to Dr. Niladri. So what are the indications of kidney biopsy and genetic testing in a child with nephrotic syndrome?
So the indication is straightforward as per our very own ISPN guidelines. For nephrotic syndrome, even the nephrotic syndrome is associated with different atypical features like hypertension, like hematuria, like low C3, C4, we can do the kidney biopsy. Otherwise, that whenever there is any kind of extrarenal manifestations like rash or arthralgia, in case of resistant nephrotic syndrome, before starting CNIs like TAC or cyclospin, we can do the kidney biopsy. When the child is already on CNI, is having recurrent AKIs, we can do a kidney biopsy. And when the child is already on CNI and for a prolonged period of time, like 30 to 36 months, we can do a kidney biopsy. And as far as the genetic test is concerned, initial steroid resistance that is onset below 1 year of age, when there is familial steroid resistance, there are extrarenal features or syndromic kind of nephrotic syndrome, there is CNI resistance, and most importantly, before kidney biopsy, before kidney transplant, we can do the genetic testing.
And usually, like as Niladri said, if it's a child who is having initial steroid resistance with onset in infancy, familial steroid resistance, extrarenal anomaly, we can even skip the kidney biopsy and go straight for genetic testing. So in this index child, this child actually turned out to be lupus nephritis. So initially when the child presented, she had no extrarenal manifestation. Somehow doing a simple urine routine in the first presentation was missed. Probably if it was done, probably microscopic hematuria could have been picked up and then we could have actually investigated the child further, but it was not done. And the child was treated with steroids, initially late responder, then became steroid resistant. It is then that the child was sent to us and we investigated and we found that this was actually a child with class 4 and class 5 lupus nephritis. So we treated with IV methylprednisolone pulse followed by oral prednisolone MMF, and she is doing well. She went into complete remission within 3 months, never had a flare thereafter. So now case 3. It's a 10-year-old male child presented with 1+ proteinuria in urine dipstick persistently. Clinical evaluation again was unremarkable. Urine routine did not show any abnormality. The early morning PCR showed subnephrotic proteinuria with the PCR being 1.3. 24 hours urine protein was to the tune of 800 mg per meter square per day, subnephrotic. Somebody did an ultrasound KOB and found that the child was actually having medullary nephrocalcinosis and on further evaluation found to be having hypercalciuria. So my question to Dr. Amit sir, what could be the probable etiology in this case?
So in this case, you got a proteinuria in the spot, this thing is 1 plus in the dipstick, but if you measure 24-hour, it is less than 1 gram. In this in scenario where there is a discordance between the dipstick and the 24-hour protein, always think of a tubular proteinuria. So and that first comes to mind is the dense disease, right, where you get the triad of this hypercalciuria, nephrocalcinosis with some degree of tubular proteinuria. So so basically when you see a urine routine microscope report of 1 plus proteinuria with a glucosuria and due evidence of rickets and other features like nephrocalcinosis, all the systemic signs are there, you think of more tubular origin rather than the nephrotic or subglomerular origin.
Yes, so as currently said, when do we suspect a child to have tubular etiology behind the proteinuria? When there are associated features of tubulopathies present, like the child may be having dehydration, failure to thrive, urine routine may be showing glycosuria, the child may be having dyselectrolytemias, metabolic acidosis or alkalosis, hypercalciuria, phosphaturia. There is some discordance between the urine dipstick and the urine protein quantification, because in tubular etiology, lot of non-albumin protein will be coming, and we know that dipstick only helps detect the albumin. And usually the protein in tubular causes will be in the subnephrotic range. So just quickly, in a few lines, Manik sir, can you tell how do we investigate a child with suspected tubular proteinuria?
So, the tubular proteins are the low molecular weight protein rather than like albumin. Albumin is a high molecular weight protein. And to identify or to differentiate between the low molecular weight protein and high molecular, the best way is to do urine electrophoresis. Urine electrophoresis will definitely show whether this is alpha to beta to microglobulin or alpha to microglobulin. So just asking for urine protein electrophoresis will differentiate between the tubular proteinuria from albuminuria. And the gross way or rough way to determine the tubular proteinuria is to ask the total urine protein versus urine albumin ratio. Because in a tubular proteinuria, the albumin will be low and the tubular protein, urine protein will be high. So one way is to diagnose the tubular proteinuria is by urine ACR divided by the urine PCR.
Yes, thank you, sir. So that brings us to the end of this case-based discussion. So some very pertinent take-home messages I wanted to make. So we have to know our battery of tests well. We have to know that what are the fallacies and how to interpret the urine dipstick. Quantification is important if it's a child with persistent proteinuria. Timed versus spot. Spot is enough for routine clinical care. You need not take the pain of doing a 24-hour timed collection every time. But whatever we do, we have to stick to the same method every time for monitoring. Mostly proteinuria in children is because of glomerular etiology, and the syndromic categorization helps to narrow down on the causes. So whether the child is symptomatic, asymptomatic, whether the child is having active urinary sediments or not, whether it's a nephritic presentation in a child who is symptomatic, will help us to narrow down on the differentials. And further investigations like doing a serum complement level with or without the other serological test, and eventually kidney biopsy with or without genetic testing can help us clinch the diagnosis. ACE inhibitors, ARBs and supportive therapy form the cornerstone of management. We should refer to a pediatric nephrologist if the child is having persistent asymptomatic proteinuria or symptomatic proteinuria, except in a typical case of steroid-sensitive nephrotic syndrome or a typical PSGN. So I come to the end of case-based discussions. So, now we'll...
Expert speaking, Dr. Susmita Banerjee. Expert comment. One question I asked her, when I should describe it is a steroid-resistant nephrotic syndrome. How long giving the steroid? After that, we can go to that. It is a steroid nephrotic syndrome,
Yes.
resistant type. How many days?
So, sir, if we have given daily steroid at 60 mg per meter square per day for 6 weeks, and we have ensured that the child is compliant, giving the medication properly, and despite that the child has not attained remission, and we have ruled out any underlying infection,
after
we
6 weeks, the child is okay.
Yeah,
But
but
after
if a child is
stopping the
having
steroid-
steroid toxicity features, then even at the end of 4 weeks, we can declare it to be steroid resistant.
Can we have the question after the algorithm? Na?
We can start the
Algorithm, yeah.
Yes, ma'am.
So we can have maybe 5-7 minutes for the algorithm and then for the questions.
Yes.
Sorry. We have the algorithms are printed for you, and mainly Dr. Deblina has worked on these very hard with a little bit of input from us, minor input from us. You, you can, so you can go through the algorithm in a few minutes, but what I would like to say is that the majority of proteinuria that we see in our day-to-day practice is plain and simple minimal change disease causing steroid-sensitive nephrotic syndrome. So that is by and large the greatest component, and usually these patients they have a very typical disease where they do not have hypertension normally, they have normal creatinines, and you treat them with steroids and the majority will respond. So most of the time we don't have to think too hard about these patients. But it is when there are atypical features, for example, nephritic features as has been detailed before, hypertension, raised creatinine, extrarenal features, that's when we need to rack our brains and think of all the different glomerulonephritis conditions if there is nephritic features. And the other thing is when you have subnephrotic proteinuria, which is asymptomatic, to rule out the physiological causes, to rule out orthostatic proteinuria, exercise-related proteinuria, transient proteinuria, and to have a clear idea in your mind as what the differential diagnosis may be and proceed step by step. So if you would like to just go quickly over the algorithm.
Yes. So in a child with asymptomatic proteinuria, first we do a proper history examination, urine routine, as Moshe ma'am had already told. Now suppose we have a child, either the child can have clinical features suggestive and having a urine routine that shows presence of proteinuria with or without RBC, or we have a child, clinical evaluation is normal, urine routine is also showing no proteinuria, no RBC. So if it be that the urine routine is normal and clinical evaluation is not suggestive, so then we have to consider, was the initial urine dipstick that came 1+, was it falsely positive? So then we repeat the urine dipstick after 1 week. If it's negative, then probably it was a transient proteinuria or a false positive dipstick. In that case, we just repeat after 3 to 6 months, persistently negative, we can reassure the parents. However, if the repeat urine dipstick after 1 week is positive, then we need to evaluate the child further. Now, suppose the child had some clinical evaluation which is suggestive of an underlying kidney disease, or the urine routine is showing proteinuria without RBCs, then we check the first morning urine PCR. If it is normal, then probably it was just a case of orthostatic proteinuria or a transient proteinuria or a false positive dipstick. However, if the first morning UPCR is more than 0.2, then we need to think, okay, what we are dealing with, then we need to look at whether the urine routine is showing active sediments. If the urine routine is showing active sediments, then probably it's a glomerular etiology like glomerulonephritis or a collagenopathy. So in any case, we have to do an RFT. We can do a C3, C4 with or without other serological tests if indicated. And if it's a nephrotic range proteinuria, we need to look at the total protein, albumin, lipid profile. But if it's a child, and definitely ultrasound, but if it's a child who is having persistent proteinuria without any active urinary sediment, then I think an important investigation will be to look for an ultrasound KOB to see whether there is any evidence of reflux nephropathy, any hydronephrosis, any asymmetry in kidney size, and then if needed, DMSA. Kidney biopsy and hearing and eye evaluation if there is microscopic hematuria or if there is family history. Kidney biopsy in a child with asymptomatic proteinuria without any active urinary sediment we need to do if persistently the subnephrotic proteinuria is there with the UPCR more than 0.5. Or in a child who is having active urinary sediment, then it's better to go ahead for a kidney biopsy unless it's a simple case of suspected PSGN. And genetic testing we need to do when indicated. And treatment will depend upon the cornerstone as already discussed earlier, ACE inhibitors, ARBs, control of BP, control of proteinuria, other supportive therapy, and treatment of the underlying cause depending upon what the etiology is. Now, if it's a child with symptomatic proteinuria, that is somebody who presents with edema, oliguria, gross hematuria, and you see that the urine dipstick is positive, then you go for urine routine. So if it's a child who is having gross hematuria or active urinary sediment, again, we come to the same thing. We need to understand whether it's a nephritic or a nephrotic syndrome, but in this case, we should keep in mind that we also need to rule out acute tubular necrosis due to hemoglobinuria, myoglobinuria. And if it's once we have ruled that out, how do we rule that out? Now we will definitely look at the urine routine. It will not show any RBC, but the urine dipstick will show presence of blood if it's a child with hemoglobinuria, myoglobinuria. So suppose we have ruled this out, then either it's a nephrotic or a nephrotic nephritic syndrome. Possibilities can be glomerulonephritis, glomerulopathy, collagenopathy, etc. So once again, history, examination, investigations, already enumerated them so many times, I'm not going into all those. And finally, we go ahead for kidney biopsy directed by target therapy unless it's a typical case of PSGN. But if it's a child who is having no active urinary sediments, no gross hematuria, presented with proteinuria along with some edema, then we need to understand whether the child is having nephrotic syndrome or not. So we will do a early morning UPCR and a serum albumin. If the early morning UPCR is more than 2, if the serum albumin is less than 3, then it's nephrotic syndrome. So then the clinical evaluation, as we do in any child with nephrotic syndrome, will go ahead. No atypical features, we can just give steroids. And if the child is having any extrarenal manifestation, persistent hypertension, AKI not attributable to hypovolemia, probably it is some glomerulonephritis we are dealing with, which has presented with nephrotic syndrome. In that case, we can go for kidney biopsy followed by directed therapy. But if it's a child who has presented in infancy with a family history of sRNA, CKD, dysmorphism, in that case, we can go for genetic testing straight away. Positive, we go for supportive management. Negative, we go for a trial of steroids. Tricky is when we see that this child does not have nephrotic syndrome, does not have nephrotic range proteinuria. So in that case, so once again, like try to think about it, child had symptomatic proteinuria. That is, there is subnephrotic isolated proteinuria with presence of edema. So then the question comes, is my urine routine really normal? So I would like to cross-check that once again. I would like to really be sure that there are no active sediments so I can repeat the urine routine. I should also consider CKD, whether the edema is because of decreased GFR, so I should look at the RFT, and I should also rule out other causes of edema. So this is more or less the algorithm.
Thank you, Ujay. Good discussion. Dr. Devolina, who is the organizing secretary of this conference, and also the panelist. So having that, and also the audience of the. Thank you so much. Thank you.
So, if you have any questions, you can do. We can take 1 or 2 questions, definitely. Because this
ARB or ACI, any proper selection for this, and how long to continue it to reduce proteinuria?
No, I think there is nothing specific because there have not been a lot of studies of ACE inhibitors versus ARBs in children as compared to in adults, and most of the data which we have been referring to is extrapolated from the adult studies. We definitely could use any one of the two in gradually increasing dose. We maximize one, and then if required, we add another agent. There has been now little bit of anxiety among the adult nephrologists in using dual therapy, which is both ACE inhibitors and ARBs, mainly because of the fear of hyperkalemia. We have still been using it in children as long as the potassium is under 5.5. Any one of the two can be used. Start with a low dose, gradually increase it depending upon your target reduction in proteinuria and the side effects, mainly the potassium. Creatinine should not go up. If it goes up initially, up to 20% is acceptable because of hemodynamic changes. It should not go up beyond that. It's mainly the potassium and the blood pressure. These are the two major.
And question of a combination of ACE and ARB.
Dry hacking cough, because number of these our nephrotic children are atopic, and to differentiate these two, I have often actually changed them from ACI inhibitor to ARB, and the cough dissolves. So it's very important to look into even minor symptoms. Might be a lot of worry for the parents.
Yeah.
About
I think it's an important thing which Shushmita has she wants to highlight, and I would say it's very important is because we share the patients of pediatric nephrology diseases together, and we should mention to families who are on ACE inhibitors or ARBs to discontinue this molecule whenever they have any fever, any vomiting, loose motions or infections, because all these conditions are going to give rise to volume depletion. And ACE inhibitors or ARBs are known to cause AKI when we are volume depleted. When we are euvolemic, it does not. But when they are volume depleted, we should, because these molecules we are using not so much for blood pressure control. We are using for proteinuria reduction, and discontinuing it for 1 week is absolutely okay. In fact, it's going to be safer and prevents AKI.
And this is more important for nephrotic syndrome, because nephrotic syndrome often can become, when they relapse, hypovolemic. And on top of that, if you continue ACE or ARB, then the high chance of AKI. So if you are having a nephrotic syndrome relapse, then. And combination of ACE and ARB, Mehul?
Yes, I think we have been using it in children with Alport syndrome. Once we have maximized one dose, I was asking Dr. Hui also, because we have not been that fortunate that we increase and maximize one dose of ACE inhibitors and the proteinuria reduces. So we have used...
Exactly. At this moment, I have one child who is now on a maximum dose of ACE inhibitors. So
and
what to do?
We do...
Okay.
Okay.
Any other question?
No, if the blood pressure is normal, then we can start ACI.
Yes, it's absolutely fine. I think that's the beauty of human body. We use any antihypertensives as long as we are euvolemic, our counter-regulatory mechanisms are going to take care of our blood pressure. So we can safely use this medication without any fear of hypotension, unless when we are volume depleted.
Dose is same with hypertension or without hypertension.
Yes, that's true. Only thing is, certainly patients who are euvolemic to begin with or eutensive to begin with, they are at a risk of developing hypotension. So we have to ask them symptoms of giddiness, which sometimes they do manifest, and in that situation we may need to cut down on the dose of ACE inhibitors. Otherwise, it's very safe.
So if there are no more questions, then we can go to the quiz section.
Thank you.
So I thank Dr. Mehul sir, Dr. Shushmita ma'am, to all my panelists, Dr. Niladri, Dr. Moshumi ma'am, Dr. Amit sir, Dr. Manik sir, and definitely the chairpersons, Chandrokantu sir and Ridu sir. Thank you.
So we would request for the panelist and the chairperson to stay on for some time, because we will be having the quiz, and then you can go to the memento corner for the memento. Till Niladri is loading up the quiz, I have a important announcement, two important announcements. One is like many of us have come for the CME point. Now that is very important. You will only get the CME point if you scan your barcode before going, and that is in the evening, late evening. That is one of the advantages now that the organizers are having. And the second is like for the audience questions also, that will, the answer will be only in the late afternoon. We will give the answer and the prize also for the audience question.
So we'll proceed with our third session of Mentimeter quiz. So we'll wait for the players to get ready. Don't click anywhere. We'll start and then you will click. Last time we had 100 plus. Still already 84 and counting.
So 90 now, shall we start?
Just. If we can reach the century again, third time. Yes. So, are you ready now? Your question is on the way. Which of the following is the investigation of choice for proteinuria quantification in an 18-month-old girl visiting OPD? Yes. Oh, excellent, excellent, excellent. So this one doesn't need any further explanation for proteinuria quantification in an 18 months old girl. So it has to be an early morning urine sample test, not dipsticks. Dipstick it is for screening purpose. So question number 2, are you ready? 103 players ready. Chalo, next. In which of the following conditions is kidney biopsy not usually necessary?
Fastest finger first. So much distributed. Huh?
Why such mixed kind of answer? Huh? So, can.
No, so the mixed answer is what we were expecting. I already mentioned that we are undergoing a paradigm shift in Alport. And the fact that Alport can be diagnosed even without a biopsy is something that is difficult for me to also accept. But yes, Alport can be diagnosed even without biopsy, and that's why this is...
Absolutely, absolutely.
This is not there. So you are suspecting correctly, but then you suspected Alport, but you don't need biopsy. You can diagnose through a genetic also.
Yes, that is why the question was put. So thank you. We'll be meeting on the 4th session after the next quiz.
So the result will be cumulative from 1 to 8. No, it started from 1 and 2 more questions are there, and the end result is the result of all 8. The marks will be for all 8.
So I would request our previous panelist, chairperson, and the expert to go to the memento corner for the memento, please.
Hello. We move on to our next session, plenary lecture 3 on perinatal management of cystic kidneys. I would like to request Dr. Santosh Kumar Agarwal sir and Dr. Joydev Ray sir to please come up on stage, our chairpersons, and Dr. Kar Hui ma'am, the speaker for today's lecture. Dr. Santosh Kumar Agarwal, sir, is a consultant pediatrician at Manipal Hospital and examiner and nodal person representing the RPCH in Eastern India. Dr. Joydev, sir, is the principal and professor of pediatrics at the Institute of Child Health, Kolkata.
Good afternoon, everyone. My sincere thanks to Dr. Amitabh, Rajiv, Sushmita, Jyoti, and their teams for having me here this afternoon. I'm delighted to introduce Dr. Kar Hui, who's been with us for the last 2 days. Thank you very much. And I don't think we need to know more about her because she's been introduced quite a few times. I would like that she should start her presentation on perinatal management of cystic disease, cystic kidneys.
Thank you. Thank you. So, other than genetics, the other thing that makes me excited is to see pregnant mothers with fetal kidney abnormalities. So, more than 10 years ago, I set up a fetal kidney clinic in my hospital and receiving referrals from the obstetricians. Mainly, these are very worried couples because their FA scans, their fetal anomaly scans, revealed something very unexpected. And sometimes I may even need to see them on the same day because it was often a very shocking news to them. So in this presentation, I'm just going to share some of my experience in managing these cases over the years. So basically, a cyst in the kidney is like having a blister, right, filled with water on the kidney. when we look at the ultrasound of the kidney, it's important to remember that the cysts can look quite different. So the ultrasound can only pick up cysts as black holes if the cysts are more than 2 to 5 millimeters in size. If the cysts are very small, like less than 2 millimeters, the ultrasound may not be able to pick it up. You will need an MRI kidneys. So, but if we have many, many small cysts put together, who are less than 1 millimeter together, the kidney actually will look bright. They will look white in color. So what I'm trying to show you here is that cystic kidney disease actually can look black on the ultrasound if the cysts are big enough, but it can also look white if there are many, many small cysts put together. So basically that's what it means. You have an ultrasound probe, you send off ultrasound waves to the kidney reflects the ultrasound back to the scanner. So the stronger the reflected waves, the brighter the kidneys or the whiter the kidneys. So what reflects ultrasound well will be water. So anything that contains excessive water, you will turn out to be a white kidney rather than a grayish kidney. So things like cysts, small cysts, edematous kidney, parenchymal abnormalities, they will all look like white kidneys. Right? So the other thing we need to know is that a newborn kidney can look very, very holy. So these are pictures of normal newborn kidneys. Because the pyramids, the renal pyramids, actually will look blacker than the older children or an adult kidney. So when we look at it, they will look like they have these black holes in it, but these are not cystic kidneys. These are normal kidneys because the renal pyramids will look blacker. But then the interstitial areas will look more whiter. So this is a normal kidney on the right-hand side, where you actually see that the parenchyma of the kidney actually looks whiter compared to the liver. And this is normal in a young baby. And usually as the baby grows older, by about half a year of age, then they will revert to a more normal-looking kidney. So generally speaking, in a very young child, the cystic kidney disease can present largely into 3 big groups. If it's just a single cyst in one kidney, many cysts in one kidney, or many cysts in both kidneys, right? So just remember what I said, the cyst can look black if it's big enough, or it could be a white kidney if it's many small cysts together. So the main thing that comes to my mind, right, whenever I receive a call from the obstetrician would be, will the baby survive, and what is the cause? Very simple, just these 2 questions. And really, one of the first questions I always ask if the obstetrician hasn't told me the story is it one side or both sides? Because if it's just one side, I can breathe. If it's 2 sides with bilateral kidneys, then we know we have to move fast because this will be very anxious parents worrying about the survival of the baby. So generally, the main things we look for will be, is it one side or both sides? Whether the kidneys are big or small? Does it affect the parenchyma? And then, of course, looking at other things like family history and extrarenal manifestations. And very, very importantly, what is the amniotic fluid looking like? Is it enough or is it low? So very broadly speaking, cystic kidney disease can be divided into a developmental reason. So this is the congenital group, the Kakut group, or the monogenic groups, which is largely the ciliopathies. The ciliopathies would be conditions which affect the cilia in the body. So largely the common ones would be things like ADPKD, ARPKD, RCAD, which is the HNF beta 1, and then nephronoptosis, Bardet-Biedl, Dobay, Becker, Gruber. Largely speaking, the congenital group will be unilateral, whereas the ciliopathy group will be bilateral, but this is not black or white because it can cross. So clearly the Kakut groups can be bilateral as well, and if it's bad, the baby won't survive after birth. The ciliopathy group, if it's very early, it may be just one side and then it progresses to both sides. But generally, this is the big concept. It is also important to know that the developmental group is static. They don't progress. So you see one cyst, 5 years later, you still see one cyst, right? But if it's genetic and progressive, like ciliopathy, they progress with time. So sometimes we are confused. I can't figure out which group it is. I would just say, give me some time. Give me 5 years. Let me see whether the cyst progress. Generally, you have an idea which group the patient belongs to. So this is, this is not showing. I'm so sorry. Okay, so but anyway, the ciliopathies are generally groups of conditions which can affect other parts of the body, like the eye, the brain, the heart, right? So these are conditions that have a lot of extrarenal manifestations. Okay, just give you some time to take in this picture. This is just a very textbook descriptions of how the cyst, the appearance of the cyst may give you an idea of the etiology of the cystic kidney disease. So for example, in the Kakut group, the multicystic dysplastic kidneys is basically a mess of cysts that basically makes the kidney lose its shape, right? Whereas on the inherited monogenic conditions, by the appearance of the cyst, it can roughly give you some idea. So for example, the ADPKD group, the cysts are in the cortical regions in the baby, and they are very scattered. Whereas in the ARPKD, it's largely in the medulla. So the medulla is very bright, so you see the reverse cortical medullary differentiation. The nephronophthisis in the classical distribution, the cyst is in the cortical medullary junction, whereas in the glomerulocystic group, the cyst is just below the capsule. So, but of course, these are just textbook descriptions, and you and I know that many times we don't always follow the textbooks, but it's good to roughly know this is how it's supposed to be. And it's also good to know that sometimes the cysts are really not cysts, it's actually a very bad hydronephrosis, or it could actually be a tumor. Okay, so will this baby survive, right? So this is the key question, okay? Because it tells me how fast I need to run. So if it's a bilateral disease with multiple cysts, then I need to know whether the baby will survive, and it's largely about the lungs. I think, why is it not showing? Oh, for some reason the pictures are not showing. Okay, but anyway, the lung development usually occurs through the entire gestation. If the oligohydramnios occur after the 26 weeks of gestation, generally the lungs would be mature enough to somewhat give the baby some chance of survival. In other words, if the oligohydramnios occur before 26 weeks of gestation, the chance of the baby surviving would be lower because the chance of pulmonary hypoplasia will be much higher. Okay, so if the oligohydramnios or anhydramnios occurs later on, say at 30 weeks, there's a good chance that the baby can still survive. Maybe a bit of pulmonary hypoplasia, but they can survive. And the other thing that the obstetricians had to do is to look at the cardiothoracic ratio. So if the cardiothoracic ratio is no good, so if the chest is very narrow, then that will also give us an idea that this is severe pulmonary hypoplasia. All right, so let me just go through some cases. So the first will be a cystic, simple cyst. Okay, so a child with a simple, oh no, it's not showing up. Oh dear, okay, it's not showing up. Okay, but never mind. Okay, I actually put up some nice ultrasound pictures here. But okay, so these are babies with many black holes in one kidney, right? The black holes are usually like a bunch of grapes. It's basically distorted all over the place, whereas the other kidney looks normal. So this one would be usually a multicystic dysplastic kidney that affects only one kidney. Right? Typically, they don't have oligohydramnios. So you can see in the cartoon there, this is how it usually looks like. It's literally a mess. There is no shape in the kidney anymore. And often when we do a DMSA scan, these kidneys will have zero function. So it's as good as only one functioning kidney. Typically at this stage, it's a lot of reassurance of the parents. The kid will still be able to pursue the dreams, go to finish the studies, have a family, etc., etc. And typically that will make the parents feel a bit more settled. You just need to make sure that you adopt a healthy lifestyle, take care of the kidneys, don't give nephrotoxic drugs, etc., etc. But usually they will be fine. It's also important to know that if one side of the kidney is affected, there's a 30% chance you will find something else anywhere else in the urinary tract. So for example, the other kidney may be affected. There's a 30% chance the other kidney may be a bit dysplastic. There may be a bit of urinary tract abnormalities like a reflux or obstruction. So do you do genetic testing in such patients? Well, I typically don't unless the multicystic dysplastic kidneys is bilateral or there are evidence of extrarenal manifestations, like for example, reproductive tract abnormalities. So at some point I may scan the pelvis to look for reproductive tract abnormalities, especially in girls, because if so, that might suggest a HNF beta 1 disorder. Or if there are other abnormalities that affect the other part of the body, like the brain, the heart, and etc., then I will do a genetic test. So long-term management is really just CKD management. Over time, if it's truly an MCDK, by the time the child reaches about 3 to 5 years old, you will find the kidney will shrink until it's almost not seen during the ultrasound. Then that's a classical progression for MCDK. So there is a difference between multicystic dysplastic kidney and cystic dysplastic kidney. It's a bit confusing, but the development of the abnormality is different. So in multicystic dysplastic kidney, the disruption occurs very early and there is no ureter. The fact that there's no ureter means the baby won't have reflux on that side of the kidney. Whereas in cystic dysplastic kidney, the disruption occurs later, so there is a ureter there. And the cyst may not be so dramatic as a MCDK. Typically, the cystic dysplastic kidney may have some function. They won't be a zero function like, they may not have a zero function like MCDK, although there are some that will have, but they may have just a decreased function, but not zero. And over time, as the baby grows up, the kidney may not disappear. It will still remain the size, it may grow a little bit, but it doesn't disappear like the MCDK. Oh, okay, I'm so sorry. Just didn't turn up. Oh, oh dear. Never mind. Oh. Okay, so patients may have, what looks like cyst may not actually be a cyst, so it's important to look for solid particles in the cyst because they could have a cystic nephroma or they could have a Wilms tumor. Okay, so cyst may not be cyst, cyst may be tumor. Look for solid particles within the cyst. And the other thing will be severe hydronephrosis. The severe hydronephrosis will look like holes as well. And sometimes when I'm referred a couple with a so-called multicystic dysplastic kidney on one side, I always counsel them. Sometimes this is not cyst, sometimes this is severe hydronephrosis due to PUJO or whatsoever. We will repeat the scan when the baby is born. And typically what you need to do is the good radiologist will need to angle the probe when they scan so that they see whether the so-called cysts are actually intercommunicating with each other. If they are intercommunicating with each other, then that's actually severe hydronephrosis. The management is completely different. All right. Oh, okay. I'm not sure whether there's a possibility of reloading the slides later on, but okay. Okay, so this is a real patient that I have seen. It's a pregnant mom that was referred to me when she was 24 weeks. The baby has bilateral and large echogenic kidneys. The obstetrician... No, it's not showing on this screen too. Yeah, I don't know why. Yeah. Yeah. Okay, but anyway, so this mom came to me with bilateral echogenic kidneys. Huh? Then I give the lecture later on, or I try and reload again. And we move on to the next section first? Can I carry on? Okay, all right. It's okay, I can still tell the story. Can you imagine the pictures? They often come to me as bilateral enlarged kidneys, and then the diagnosis given by the obstetrician is always ARP-kidney. I must tell you, I never find ARP-kidney. I often find other things. So this is a mother that is like that. Bilateral echogenic kidneys. The thing about this kidney, actually I didn't show the picture, but I have cartoon here. The cyst is underneath the capsule. It's very clear on the ultrasound. right? You can imagine it's very clear it's under the capsule. Sometimes radiologists don't describe it. You literally need to find the pictures and look at it yourself. And if truly is subcapsular, that only gives you a few diagnoses. And essentially, this is glomerulocystic disease, right? And because it's bilateral, it doesn't look congenital or developmental. We went ahead and do a genetic testing and confirmed that this patient has a HNF beta 1 nephropathy. The importance of this diagnosis is that this condition actually has other extrarenal considerations. This patient is at risk of early onset diabetes, moldy diabetes, at risk of gout, and also at risk of liver involvement as well, and also hypomagnesemia. So this diagnosis is important because it allows us to better manage the other aspects of the patient. And it turned out that it's de novo, not present in both parents, which is often the case, and so there's no risk of recurrence to the next child. Okay. So this patient is now about 3-4 years old and has developed a bit of CKD, but we managed with enalapril and all that, and so now it's just having kidneys. The cysts have progressed, so you can see there's more and more cysts each time I scan the patient. So these are some of the possibilities of glomerulocystic disease. It is not just HNF beta. There are many other conditions that can cause glomerulocystic diseases. As I said, it does have other extrarenal manifestations and all that. So in girls, it is also associated with reproductive tract abnormalities. So screening of the family is important. It's also important to know that HNF beta 1 is a notorious gene because it can have large gene deletions. Okay, a large percentage of them can have large gene deletions. So a negative conventional genetic result doesn't mean they don't have. You may need to do MLPA, which is a special kind of genetic test if you're strongly suspecting HNF beta 1. So MLPA is basically it's a special way of doing genetic tests where you can look for large deletions and duplications in that gene. Okay. All right, let me move on to a second case with bilateral renal cyst. Okay, so this couple came to me. Okay, the father has a polydactyly on one side. The baby had a normal 16-week scan, but at 20 weeks already had bilateral large echogenic kidneys with multiple cysts, but the AFI was normal. By the time the baby reached 32 weeks, had oligohydramnios, that's quite severe, but the cardiothoracic ratio was normal. So it's often a very difficult counseling session. The parents get really emotional, but they wanted to keep the baby. They didn't want to terminate. But also because it was already 32 weeks. So we often had to talk a lot about what's going to happen when the baby is born. So this is really the group of people that I have to work with. The couple by right should see all these different people in my team to have a talk before the baby is born. And we talk a lot about what will happen if the baby is having respiratory distress. We will ask the neonatologist to do the ventilation first. Do we start dialysis? We may or may not, depending on how good the lung prognosis is. So by and large, the principle would be we will start dialysis only if we have a good idea that the baby will survive, meaning the lungs will make it. The lungs have to make it first. If the chance of the baby not surviving because of the lungs, we will not even do dialysis because it's just not ethical. So that often we may even involve the palliative team before the baby is born. And generally, the team needs to have a plan on what to do when the baby is born. Like when do you start putting the catheter and stuff like that, okay? And clearly, the patient also should be seen by the geneticist, right? So if we can do a genetic test, and often we have to think, how do you get the samples? Or the baby die before he comes out? Where do you get the baby samples so they can plan for the next pregnancy? Right? So we talk about things like that. Okay, so for this baby, he was born at 38 weeks and basically had quite severe pulmonary hypoplasia, but managed to make it. Oh, this kidneys appeared.
Just give us 2 minutes. I think they will upload one more.
Sure. So, okay. So I pause for a while?
Yeah.
Okay. All right. So some of the things that, when I see the couple, often they are very emotional. They are not ready to talk to many people in my team. So we will first talk about how does kidney failure look like in a young child. And then we were asked to see the couple again, in about a week or two again. And when they are a bit more settled, we will then refer to the different teams to support the family. I mean, over the years, there are some couple that will just terminate the baby. There are some couple that will keep the baby. Oh, thank you. Oh, do you want me to go back or do you want me to carry on?
If any of those pictures were interesting, you can tell them, but otherwise you can carry on.
You go on speed, but interesting picture you have to highlight.
So I just go forward first. Okay, let me see. Okay, so this is the multicystic dysplastic kidneys. These are fetal scans, yeah? Fetal scans. So you can see the holes in the kidney, MCDK. These are the big circles, the black, they're all black because the holes are big, right? Okay, so here you can see the difference between a multicystic dysplastic and cystic dysplastic. Here there's loss of echogenicity, but you can still see the kidney shape. These are the tumors, right? The cysts, they're actually tumors. So you can see that they can look pretty cystic here as well. This is a severe hydronephrosis, right? They look like cysts, but actually they're intercommunicating, so it's severe hydronephrosis. Okay, so this is the baby with HNF beta 1, the subcapsular cyst. Here, so you can see on this picture here, the cyst is actually near the capsule. So at 3 years old, you can see that the cyst is happening under the capsule. So this is glomerulocystic disease. Okay, so this is the couple that came in with, basically echogenic looking, and it's almost like a salt and pepper distribution, right? The cyst is all over the place, the kidney has no structure, and there's oligohydramnios. So this is the pulmonary hypoplasia. And you can see the kidney has no structure and the cyst is literally all over the place. Okay, so the patient survived in terms, or rather did pretty okay in terms of the lungs. So we carry on to do dialysis and started very early. But the baby also have other problems, so that the liver doesn't look normal, actually has Carolese disease, and there's actually 2 big pancreatic cysts. So it's not just the kidneys. And eventually we did a genetic testing and turned out that he had a gene mutation in MPHP3, which turns out to be an infantile nephronoptosis. So the baby didn't survive in the end because of the pancreatic cyst. There were a lot of complications that happened. So generally, the survival of the baby is, quite a lot of it is largely because of the extra-renal problems. So at least in my center, we were able to do dialysis in young children to allow them to survive, at least from the point of the kidney. But many of them eventually don't survive because of the extra-renal problems. So in this case, it's the liver and pancreatic cysts that cause a lot of problems. Okay, what are some of the other experience over the years? Okay, so this is again a bilateral large echogenic kidney. So it's a white kidneys, big kidneys in the fetus that's referred to me. The couple decided to terminate the pregnancy. We did a post-mortem of the baby that was born. And here you can see that the cyst was actually, the kidneys were actually cystic looking, but they were polydactyly in all 4 limbs. So here you can see that this is a ciliopathy because of the polydactyly. This is another couple, again, large echogenic kidneys, as you can see here. But this one had multiple same problem. So there was repeated pregnancies, and the babies just kept getting the same thing, right? Oligohydramnios, and then some of them stillbirth, some of them made it. We thought it's ARPKD, but it turned out that this is a LAMP2 mutation. Now, if you're not sure, LAMP2 is a glomerular gene, right? It causes congenital nephrotic syndrome. But this couple, they are both carriers for a LAMP2 mutation. And when they get pregnant, 25% chance that each baby will be a compound heterozygous. So I think they had terminated at least 3 pregnancies because 3 were affected. Okay, so probably this is a learning point here. here I've collected all the different samples of the different babies. They pretty much look the same, you know. So oftentimes at the fetal age, right, it's very hard to distinguish, you know, whether it's an ARPKD, it's a nephronoptosis, or is it HNF beta 1. So you do require genetic testing if it's available so that you can hinge onto the correct diagnosis. I just want to highlight this last part here on the ADPKD. So we often thought ADPKD is an adult onset disease, but here, you know, it is a baby with echogenic kidneys and detected antenatally. We did a genetic testing on the baby when he's born, confirmed ADPKD. Then we found that the mother actually has ADPKD that has not been diagnosed all along. So when seeing a couple with an affected baby, we often will go through a family history in detail, not just asking for family history of renal disease, but also asking for family history of extra-renal disease like early gout, skeletal abnormalities. And then we often will ask if the parents will allow an ultrasound scan of themselves. Go for an ultrasound scan of their own kidneys, especially if the parents are more than 40 years old, and you do an ultrasound and you don't find cysts, then you almost can confidently exclude ADPKD in the parents. So that's something that's helpful. Yep. So we will examine the baby when the baby is born. Yep. Okay, so the take-home message would be cystic kidney disease. It can look like black holes on the ultrasound, or it can look like white kidneys, but it may also mean other things like tumors or hydronephrosis. Most cases, if there's no oligohydramnios or anhydramnios, we can just have expected management with the patient and the parents. But if the babies have oligohydramnios or anhydramnios, then that's usually a very exciting period because then you involve a multidisciplinary management for the next couple of weeks. Yeah, I think with this, I'd like to thank you.
Thank you, madam, for your nice presentation. What we learned from this session is that, first, the parents will ask you whether the child will survive or not. It is not the cyst, it is the amniotic fluid. If there is a oligohydramnios, then prognosis is bad. Another, what are the factors will give the prognosis? That will mother ask. Whether there is a bilateral involvement, whether it is a progressive, whether it is a extra kidney involvement is there, then the prognosis is bad. And at that time, these are the most of the cases are related to the genetic thing. Because she told there is a two-type inheritance of the cyst. One is the non-genetic group, another is the genetic groups. In the genetic groups, the prognosis is generally bad. These are give rise to all these features. And he has shown few cases with severe oligohydramnios that prognosis was bad, that is stillbirth, all these things. When we give to the management of these cystic diseases in the perinatally, it is a multi-cystic action. Multi-personal approach should be there. Obstetrician approach should be there. Neonatologist, pediatrician approach should be there. And definitely geneticists should be there in the team. Geneticists approach should be there. And also the psychologist should be there in the, because when these sorts of things will be there, the psychological approach has given a trace in this lecture. And another thing I want to mention is that not only the patient itself, you have to, for the genetic counseling, we have to follow up the family history, family pedigree, and the others member has to be investigated for that, and proper history has to be taken. These are the things we learned from these lessons, and any questions from the audience that can be asked. Okay.
Gestational age where you can do this antenatal diagnosis possibly, which is then you can decide this baby is survivable or not survivable.
So most, I'm not sure about here, but most mothers will go for a fetal anomaly scan at about 24 weeks, 22 weeks gestation. So this is about the time where we will pick up most kidney abnormalities. But there have been situations where I've seen where the fetal anomaly scan at 18 to 22 weeks were normal. And then somebody just happened to do another scan at 24 weeks and turned out to be abnormal, or the 32 weeks then turned out to be abnormal. It's rare, but it does happen sometimes.
In our country, after 24-hour medical termination, it's not possible. So, in your this thing, what we have shown, one case is terminated, and after that, you have shown there is a multiple.
No, so So yeah, so we usually do the fetal anomaly scan at 18 weeks so that they can quickly refer to us and the parents can then decide to terminate before 24 weeks. And sometimes if you do genetic testing, it's a very quick 1 week turnaround time so that we can make it by 24 weeks and then it's terminated. So that's possible. Can we terminate on medical reasons if it's beyond 24 weeks? Strictly speaking, no. But if there is enough justification, maybe we can. Like for example, keeping the baby is going to have cause harm to the mother, for example. So if it's after 24 weeks, we will have to justify very hard to have a termination of the pregnancy.
So this is a real life picture. This child was diagnosed antenatally with left-sided cystic kidney disease and no other anomalies. After birth, she was diagnosed and proved that she has a multicystic left-sided kidney, but right-sided kidney is normal, no other congenital anomaly, and she is now 2 years old, growing normally, but the kidney anomaly is persisting. DMSS scan done, the left-sided kidney is non-functioning. So what should be done now?
Nothing. So
one thing I want to say here that always we know that a person can give one kidney donation. So if the one kidney is properly functioning, then nothing to be worried.
So I think you are asking whether the kidney should be removed. Yeah?
For a multicystic dysplastic kidney, all you one have to do is follow them up, make sure that they are having a healthy lifestyle, and make sure that the bad kidney is involuting and the good kidney is taking up the function of the other kidney.
Really, one thing I want to mention here that regarding now there is a very much treatment regarding the antenatal different treatment for the fetus is done. But really cystic disease, there is no treatment available still now. But why we are doing this thing? Because we know the severity of the disease. We can do the future plan and what is the prognosis. That is the important thing of the parental management.
Just to add, I think counseling the parents and communicating to the parents is also very important, and the family.
Yeah, so the building of the relationship with the parents is extremely crucial because if you don't have that trusting relationship, it's very difficult for them to bridge that super difficult period when a child is born. So if you start the relationship very early before the child is born, then when the child is born, it's usually a roller coaster ride for the parents. It'll be a lot easier if you already have that relationship built with them. Sorry?
Yeah, multicystic kidney, he's saying that with time it will
involate.
shrink.
Yeah.
Yeah.
It should. If it doesn't involate, then it's not multicystic, it's cystic dysplastic. Yeah.
But it can take a long time.
If it is due to non-genetic cause, specifically simple cyst can regress.
Maybe just one last point. If it's the MCDK is one side, if the other kidney is normal, you would expect the other kidney to grow really well, sometimes even compensatory hypertrophy. If the other kidney doesn't grow very well, then it means the other kidney is a bit dysplastic as well. Then the prognosis is generally a little bit not so good.
Can it produce renovascular hypertension?
So whether a multicystic dysplastic kidney can produce hypertension?
For MCDK?
Yeah.
They usually don't, not in the early childhood, but if they go on to late adolescence and early adulthood, they may, and that's just because of just CKD coming in general.
So there are, like for a long time, there was this concept of removing the multicystic dysplastic kidney. We still get sometimes that kidney has to be removed, but then studies have shown that most of the time they don't have to be removed. So don't please go by the surgeons if they say that MCDK has to be removed.
Yeah, don't take out.
They don't have to be removed, and studies have shown that they usually don't cause hypertension. बस सर्जन के पास भेजना नहीं चाहिए हाँ हम मेरा पास भेज सकते हैं
Right. Thank you very much, madam, for an illustrious talk.
Thank you, madam. Thank you. And send it to the nephrologist.
Thank you very much for this session. Now I would like Chairman, Sir and Speaker to kindly collect the memento from the memento corner We move on to the next session, which is a case-based discussion on a child with recurrent UTI. I would like to invite on stage Chairperson Dr. Subhashish Bhattacharya sir, who is HOD and Professor, Department of Pediatrics, Kolkata. And moderator is Dr. Shumatra Roth, who is Associate Professor, Pediatric Nephrology at North Bengal Medical College.
Thank you. Now it's very interesting and very much needed for our day-to-day practice. The case-based discussion on a child with a recurrent UTI. We get a lot of cases with recurrent UTI, and sometimes we are confused what to do. And we know that any UTI, especially the upper UTI associated, there's high possibility of associated with kidney damage, kidney deteriorating condition. So we have to diagnose those conditions as early and how will we treat and approach. I think we have a galaxy of panelists, moderator and expert. So and especially the moderator, Dr. Sumanta Raut, will do a justice to this very important and commonly occurring condition in our day-to-day practice.
Thank you, sir, for the nice intro. At the outset, I would like to thank my Bspncon team for arranging this conference and particularly this topic. A very good afternoon to all the pediatrician and pediatric surgeon across Bengal, across India, and obviously across globe. So, thanks for giving me the post-lunch session. Bada mast neend aa raha tha, so we'll try to go by as our expert Dr. Bahari sir suggested us. So, I will like to call upon my panelists, experts panelists. First will be Dr. Aditi Das, our young assistant professor from AIIMS Kalyani. Then Dr. Biplab Maji, another young faculty from our Asansol Medical College. Third is Dr. Suvankar Sarkar, again a galaxy from AIIMS Kalyani, consultant assistant professor in pediatric nephrology. And last and our the most support from the pediatric surgery team, Dr. Poonam Guho, coincidentally my MBBS batchmate and PGI alumni. So with this thing, we go to the topic of this recurrent UTI. And obviously इतना मस्त खाने के बाद इतना मस्त नींद आ रहा है तो थोड़ा केस डिस्कशन हो जाए. So we try to capture this guideline. This is the latest guideline of UTI for Indian scenario. Just a 40 pages guideline. तो ज़्यादा टाइम नहीं लगेगा पढ़ने के लिए और प्रेजेंट करने के लिए तो और भी कम टाइम लगेगा. तो it has just 17 recommendation and 18 practice point. That's all. So we try to finish within 25 minutes, or if I run like Rajdhani, please excuse me. So this is a day-to-day practice, common person like this. If any query, any doubts from residents or any of the pediatrician can raise hand and ask questions there and there. We'll try to solve there only. So 2 years girl, 102 degree Fahrenheit of fever. On January 23rd, there was some cough and cold also for 5 days. There is no other lower urinary tract symptoms. A clean catch urine was advised by the pediatrician. There was few pus cells or WBCs. Started on syrup cefixime. And also sent a culture before starting the antibiotic. The culture came after 3 days. It was showing E. coli of 10⁵ colony count in a clean catch sample, which was sensitive to amikacin, but unfortunately resistant to cefixime. The baby was well by day 3. So now, what is the provisional diagnosis to Dr. Aditi? Is it a UTI or not an UTI?
So according to ISPN 2023 guideline, the definition of UTI is there will be growth of a single uropathogen with a single colony count associated with symptoms. For the 2-year-old girl, in this case, the child should have for UTI symptoms wise fever, vomiting, lethargy, abdominal pain, increased frequency of urination, hematuria, associated malodorous urine or cloudy urine. But these conditions were absent for the index case.
Right.
So the leukocyturia, maybe they are associated with any fever or the LRTI the child is having. So we can, whether it is asymptomatic bacteriuria, so what is this? This is asymptomatic. That means the child is not having symptoms, but having significant colony count with uropathogen, definite uropathogen. So we can, due to absence of symptoms but presence of cough, cold, LRTI, we can diagnose it as asymptomatic bacteria, but definitely we should know how the urine was collected,
Right.
whether it is clean catch, proper or not.
So come to the point. So a fever with a clear focus of an UTI or an LRTI, so that's how becomes an UTI. There is no urinary symptoms as such. So don't blame for the culture only. Might have, if with this type of cough and cold, I might have not sent a urine test itself. Even if some had sent the urine test wrongly, just ignore the culture. If your baby is well, there is more often a reason for to do so. So it's not an UTI, it's an LUTS, and the culture was positive by asymptomatic bacteria, correctly told. So now, if the child should not have a cough and cold, suppose a fever without focus, how about the sample collection? For a 2 years of child, hardly a verbal child who can pass urine on command. Is a clean catch sample is okay, or I need to do a suprapubic puncture or etc. etc. How many of us has done suprapubic culture in last 1 month? Can raise hand. Suprapubic culture, a simple thing. Many of the times we speak. কজন করেছি বেশ আমরা এখানে লাস্ট এক মাসের মধ্যে? আচ্ছা লাস্ট এক বছরের মধ্যে কজন করেছি? এই সাবাস ক্যাডবেরিটা দিচ্ছি প্রোগ্রামটা হয়ে গেলে। তো suppose so Dr. Biplab, so what about your thought on sample collection at this age group or various age group? Sir, Biplab sir বলছেন।
So there are various methods of collecting urine for culture.
Right.
There are some non-invasive and invasive methods as well. Most commonly we do midstream clean catch urine.
Correct.
Which is commonly done in toilet trained children.
Yeah.
It may be difficult for non-toilet trained children to collect midstream, but we should try first. If we fail, then we can go for invasive techniques like catheterization or suprapubic aspiration. But in a sick child, when we don't have much time to wait for a clean catch urine, we should directly go for catheterization or suprapubic aspiration to have a quick collection.
Very good.
In many centers, adhesive bags or nappy pads are also used for...
Very important point.
Yes, for collection of urine culture. But studies have showed that they have got high contamination rate up to 60 to 80%.
Right.
So they cannot be used for collection of urine culture.
Correct. So most of the widely accepted procedure is clean catch sample, but properly with a proper soap wash and then a wide apart legs. So that's why no contamination is there. Fine. Still then, the contamination rate will vary from 15 to 60% how the samples have been collected. So explain your parents bit well, otherwise you are bound to have contaminants. The next otherwise sample, if you can't wait so long, डब्बा खोल के आधा घंटा खड़ा है, कहाँ पे बारिश गिरेगा, so we can do a quick. Dr. Kaufman has started in 2017 that give some either ice cold water or a warm water, and then there can be a improvised stimulation for the sample, but the contamination rate remains same. Otherwise, there is also easy option. These are best option for a OPD practice. For toilet trained, it is very easy. For non-toilet trained also, still we can try this. If we fail this, then we can go to the other option, the in-out simple catheter. Not for a existing 15 din purana catheter, but a in-out simple catheter. So that can be done for a indoor practice, obviously, but for OPD practice, very rare labs do so. Most of the renowned lab will not be very eager to do a catheter sample. They will ask the doctor to catheterize and take the sample, right? And otherwise, the gold standard for a sick child, as Dr. Pilbab told, is a suprapubic puncture. जो the gold standard, but इतने में एक ही हाथ उठा है, तो ठीक है. So may not be feasible always. So then, what is a big no is this one. Many of the centers practice this. This can be a good thing to rule out thing. Negative आया तो negative है भाई, but positive आया तो it's a huge chance of contamination by stool or anything else. So better not to practice this. Okay, you can do it for urine volume, but not for urine culture at least. Fine. So just a reminder, if there is a no symptoms, don't send the culture. If your friend has sent the culture wrongly, ignore the culture. If you are telling the mom to send the culture, tell them the antibiotics should be started after giving the sample at least. So if it is most of the UTI will happen on Saturday. When you are closing your chamber, then only it will happen. So please tell them to keep the sample reserve in refrigerator or somewhere, then start the antibiotic and give the sample deposition next day. And obviously, proper sample collection techniques to be explained well. So now, clean catch sample has been taken. The case was, this was same girl after 5 months of age. Again, there was some dysuria. The previous episode was not an UTI, right? This was an URTI, upper respiratory tract infection. Currently, she is having dysuria, frequency, febrile on July 24. So now, Dr. Aditi is happy. So urine ka symptoms मिल गया हम लोगों को. Fine. So now, there is a clean catch sample having a 2 to 3 WBCs only. Started on cefixime obviously for the fever as a knee-jerk reflex, but luckily sent the sample for culture before starting antibiotic. This time Klebsiella with 50,000 colony count on a clean catch. And obviously as the most common pattern आजकल तो cefixime sensitive आता ही नहीं है शायद, तो micacin sensitive and cefixime resistance on day 3. Baby was well on day 3. So is it a UTI? The pus cell is hardly 2 or 3. Dr. Subankar.
So actually the guideline, so easy to do for the screening of the UTI.
Yeah.
The current guideline is not giving importance to do the microscopy actually because it's not feasible for the all center. So that's why the screening tool is very important to use a dipstick. So if it is dipstick is positive, on the basis of that we can start the antibiotic. If you have a microscopy facility, you can go for that actually.
Right.
So if you have a symptoms plus dipstick is positive, then you can consider as empirically as a UTI and start the antibiotic and send the culture, you confirm your diagnosis by the culture.
Correct.
That is the take home for this situation.
Right. So this is one of the changes of the 18 changes over the 40 pages. First thing is, हमारे पास patient आया for substituted UTI, we sent a urine RE. Here they says, please keep a polished multi-stick in your own OPD chamber. Whenever the patients come, just do the dipstick then and there. Write the leukocyte esterase, like the nitrite. That is more or less equivalent to if your stick, as Ajib sir told, if the stick is well, stick 2 साल पुराना है, 1947 का है, so that might not work. But the stick will give you a ready point of care test. And then as per that, you act accordingly. You may parallelly send RE also, not an issue, because RE will have a documentation proper. But this is also one of the way. So Indian guideline is one of the thing where there is no role for during WBC or pus cell, whatever we say. So here symptoms plus culture positive on a significant count is UTI. So here no role of pus cells, that can be 2 or 20 or 200. But AAP or other guidelines also have a cutoff of WBC or pus cell of more than 5 per Harper field, etc. etc. So for ISPN guideline, urine WBC even if 0, that can still be UTI. Just remember, but symptoms should be there. Fine. So in presence of symptoms, single uropathogen of significant colony count, that's UTI. No mention of how many pus cells, 2 or 20 or 200, nothing is there. So next. So now, sorry please. Colony count, sir, next wala. अगले वाला ही question है. So was the colony count sufficient? 50,000. 20 साल से पढ़ के आ रहे हैं. 10 lakhs is the colony count required for a clean catch, right? बाकी 1 lakh, sorry, 10 to 5, 1 lakh. So is the 50,000 is enough? So Dr. Aditi ma'am.
So Bspncon 2023 guideline wise, the colony count for suprapubic aspiration is significant when it is more than equal to 10 to the power 3. For catheterized sample, it is more than equal to 10 to the power 4.
Right.
And for clean catch, it is more than equal to 10 to the power 4 to 5 colony forming unit per ml. And definitely adhesive bags and nappy pads sampling should not be done.
Right, as told earlier. So this is the second change in our guideline. The colony count has been reduced from 10 to the power 5 to 10 to the power 4 in clean catch sample if you have a significant symptoms. So 10,000 भी चलेगा. So don't go by the colony count alone कि 50,000 है तो negative. If the child has symptoms, consider UTI, treat the child. Yes, please. Mike bhai. Sir, बोलूँ. Yes, sir, right. So the thing is same. Any count means, yes, please.
It is corresponding to 10 to the power 3.
Right, so the loop we use is having a 1 microliter size.
Yeah, yes, sir. Any count, it is corresponding to 10 to the power 3.
Dr. Aditi is trying to say that 10 to the power 3 means any count. Single count is 10 to the power 3. Chalo, we proceed further. So, how to treat the child? On day 3, the child is well, but you got a report that it is sensitive to amikacin but resistant to cefixime, but the baby is well. We treat the report, we treat the child. What we do, Dr. Biplab? What's your opinion? And suppose the opposite side, the child is not well, the child is still toxic on day 3, then what decision will be?
So, because the child was having symptoms of lower urinary tract as well as culture was positive, so
Yeah.
I will consider it as an UTI.
UTI, correct.
And when you diagnose it UTI, you have to start antibiotic as soon as possible.
Started? Cefixime was
Preferably
started?
Yes, cefixime was started. But the culture report shows that it is not sensitive to cefixime. It is sensitive to amikacin.
Yeah.
But as we know that in vitro and in vivo sensitivity varies.
Right,
So,
may vary.
Yeah,
May vary.
may vary. So it is not the sensitivity report. Rather, we should look into the clinical response, which is more
Right.
crucial.
Right.
So we can ignore the sensitivity report here because the patient has responded to the antibiotic that we have prescribed.
Correct.
And and in the other clinical situation, when as we have discussed that if the patient have a sensitivity report and we have given antibiotic as per sensitivity report, but the child has not responded even after 48 hours. So in that case, we have to think about two situations.
Yes.
One is the child might have an organism which is resistant to that antibiotic, or the child have some other kind of complication.
Right, other focus.
Complications
Correct.
might like VUR or bladder ball dysfunction. So we have to send a repeat urine culture to find out the sensitivity pattern.
Right.
And then also we do an USG to find out if there is any VUR or bladder ball dysfunction. And we have to change the antibiotic. Even if the antibiotic, even if the sensitivity pattern shows that the organism is sensitive to that particular
So correctly
drug,
told. So
yes.
even if your child is well, don't chase the antibiotic pattern, chase the child. If the child is well, continue the same suffixing antibiotic for whatever the duration we'll talk to later. So this is not a new guideline. This is the old guideline was similar. If the child is not well on day 3, please upgrade your antibiotic as per your culture report, or if you still have a culture report not suitable, then please send a new culture before upgrading antibiotic. Yes, sir? Yes, sir. It's legally, it's in a guideline, sir. You can use the guideline for legal acceptance. If the child is well, it's not for UTI, sir. For any sepsis part, whenever there is, as the critical care person also says, if there is a culture is still come positive with some ABCD antibiotic and resistance to the given antibiotic, but the child is well, we can still continue the antibiotic for desired duration. So this child, the same is the child. Amikacin was sensitive and cefixime was negative. Most of the pediatricians sitting here are centurions, not by age, by seeing patient per day or per shift. 100 patient देखते होंगे. ये report तो आए दिन देखते रहते होंगे. So obviously this type of reports not to be chased. Chase the baby, please. So change or not to change? Not to change. Thank you. So ठीक है. So now how to treat? So the baby was not toxic. So day 7 antibiotic was completed. Baby is still wet. Baby is still well. So now we want to repeat a urine culture. Do we want to repeat a urine routine test? Yes or no? Dr. Subhankar.
So I think you answered already. So no need to repeat the urinary. The many times we thought that is responding or not, but not need to repeat in urinary urine culture. That's fine.
Right. So if the baby is well, please don't repeat the urine culture. And if your friend has done that wrongly, ignore the culture. But Dr. Poonam, can you make the situation a little bit complex? So now our surgeon enters the picture. See, or he wants to intervene something. Any intervention, MCU, UDS, cystoscopy. So now before that, does he need a clean picture? Either a routine culture, a repeat culture or a routinary. What's your take on this?
If we want to do any intervention, like suppose this child has had repeated episodes of UTI,
right.
I would like to do an MCU for her.
MCU on day 7 or day 8, then?
Yes, then I would like to have a urine routine which shows the pus cells have reduced.
Okay, so if a well child, you don't need a repeat culture, but at least a routinary, right? Yes. Because ISPN guideline is clear on the fact that we don't need a repeat culture, but do we need a repeat urinary? That is a little bit muted here. So it's as per your clinical decision.
So I think another guideline is coming that is focusing on doing urinary before MCU or not. So that is also a controversial part actually. Hopefully the guideline is going to clear.
That's fine, but there is still a dilemma on that one. So anyone, so now imagine, so UTI diagnosed, treated, baby well, घर जाने वाला है कि अभी भी कहानी बाकी है. So what imaging do we need and what time, Dr. Aditi?
So Bspncon 2023 guideline shows that for the first episode or any UTI, the child should undergo ultrasound.
Right. 100% mandatory for all patients with UTI, right? Yes. Then?
And if the child is having bladder bubble dysfunction or non-E. coli UTI for less than 2 years old or recurrent UTI, then we should go for the along with ultrasound for MCU. Otherwise, if the ultrasound is showing any abnormality, we will go for the MCU.
Correct.
And definitely after 4 to 6 months of UTI, we will go for the DMS scan.
Correct. So there is also a next change in the guideline here. So previously, infant for less than 1 year, even a single UTI by any organism, we are doing all 3 tests, right? Ultrasound, MCU and DMSA. So current changes is we are going away from radiation hazards of the investigations, which may not have much of the clinical significance on the milder effect. So if it is a Klebsiella or something in infant, then you do the MCU. If it is highly abnormal, then only DMSA. Or if it is only simple E. coli, then your ultrasound is normal, then you can bypass rest of the 2 tests because they are invasive or semi-invasive, or they are also having radiation injury, and many of the centers doesn't have it. একটা বাচ্চাকে মিডল বেঙ্গল থেকে ডিএমএসএ করতে গেলে they have to reach to Kolkata or might be in some other big towns to have a DMSA and a good pocket money. So that's why the guideline is for more focused. So now coming to the point. So yes, sir, that ma'am speaks. So Misty having a normal ultrasound. So ultrasound came normal, so we stopped then and there. No MCU, no DMSA for this episode. If there is a recurrent UTI, then we forget every guideline, we do all the tests. Fine? So now, what is the timing, sir was asking. So we can cover here only. So Dr. Aditi, regarding the timing of ultrasound, timing of MCU and timing of DMSA.
So DMSA is only for late DMSA we will prefer, but MCU if the child is having on antibiotic and child is well, now we can go for MCU. We may not wait for after the stoppage of antibiotic for 1 to 2 weeks. We can may
So
not wait.
the
We
current
can go
guideline is very
immediately.
clear that DMSA is not before 4 months at least. Once a UTI, do it after 4 months. If your child is unfortunately having UTI every month, राशन दुकान जैसा हो गया, तो you can't do DMSA. Wait for 4 months clearance and then do it. Okay. And MCU, once you are pretty sure that your child is clear of infection, you are not going to harm by the MCU, then you can go for it. That can be a day 8 or day 10, but don't go so far so the child go lost to follow up. So now, Misty, the same girl. So now after 12 months of the first episode, this time again dysuria, frequency and fever. So clean catch urine was taken. There was 20 to 30 pus cells. Cefixime was started. It is a favorite drug. You always tried Cefixime, Augmentin. 2-3 drugs are there for our nephrologist. We go around this. So day 3 culture came as E. coli with 50,000 colony count. It was sensitive to nitrofurantoin and colistin, but resistant to Cefixime. I am pretty sure you have seen this type of report also. But unfortunately, this baby on day 3 still not well, still vomiting, having some fever. So is this a recurrent UTI, Dr. Biplab?
Oh, so yes.
What is recurrent UTI then?
So recurrent UTI is defined as 2 episodes of febrile united infection in any time period in this childhood. So that should be febrile UTI.
Correct. So 2 febrile UTI in full lifetime. Maybe 1 महीने बच्चे में हुआ और 17 साल में हुआ तो भी recurrent UTI documents रहना चाहिए. Right. So,
but if you carefully review the case, then we'll find out that the first episode was not an UTI, it was an upper respiratory infection.
Right. Second,
and the culture was positive because of asymptomatic bacteria.
Second,
in the second episode, there was no fever, but there was UTI, but there was not febrile.
So
in the third
UTI.
episode, yes, in the third episode, there was a febrile UTI. So actually, this is the first episode febrile UTI. So we have to wait for maybe one more episode to occur.
So nomenclature doesn't still justified for recurrent UTI. Right.
Yes.
So now regarding the treatment, how to treat this child? So definitely Cefixime is not working. So now do we change the antibiotic or still Cefixime में ही रहेंगे? Change तो करना ही पड़ेगा. तो सर कौन सा करेंगे जी? Nitrofurantoin, colistin.
So it's a difficult
Usually
situation.
mom and dad don't want to get admitted for this costly drug of colistin. Suppose it's a high costly drug and need admission. So Suvankar sir.
So it's a difficult situation. I think choosing between nitrofurantoin and colistin. So
Right.
in adult actually they use nitrofurantoin a lot
Very
for
good.
treating UTI. Because adult could have a not upper tract infection. Most of them have a cystitis and lower tract infection. So nitrofurantoin is a very good drug for them. But in pediatric age group, nitrofurantoin is not a drug, therapeutic drug actually. So you have to choose the other drug that is a colistin. Definitely colistin is not a good choice, but you have to choose right now. And you repeat the culture. Many times the report is coming from the outside, it's not adequate. So this is the indication to repeat culture. The child day 3 of antibiotic not responding, symptomatic, you have to repeat urine culture.
Correct.
Definitely you do the ultrasound also if there is
Correct.
a, other anatomical abnormality. And start the colistin and also look for the other complications like the child could have a AKI, child could have dehydration because the child is repeatedly vomiting, electrolyte imbalance. So all these things need to be managed. And for that child need a admission and fluid therapy also if it is ratio is required and then you can treat. So colistin should be started and look for the other sensitive drug so you can change in future after IV antibiotic is gone.
So though we do our job very easily with oral nitrofurantoin,
One comment here.
Please sir.
Monotherapy with colistin is usually not recommended for any child with features of systemic bacterial infection. So even when you are actually changing to colistin, it's always sensible to give a carbapenem with it because otherwise you are exposing colistin only, and colistin obviously it has got its
Right,
own
sir.
side effect as well.
Right,
In any critical situation, colistin monotherapy is not recommended.
So
That
point
you have
well
to keep
taken.
in
To
mind.
protect the drug of colistin, we are taking the policy, but nitrofurantoin is not a favorite drug for therapy. Many of the child, particularly for pediatric age group, they don't tolerate well. They vomit repeatedly. Even for UTI, they are vomiting. Nitrofurantoin again cause more vomiting. So
Nitrofurantoin is
is
not
never a
a
therapy
drug to
for
treat
therapy.
UTI.
Yes.
You should be only using nitrofurantoin
For prophylaxis.
as a
Right.
prophylaxis.
Right, sir.
Never use to treat UTI, particularly in a febrile child who might be having features of systemic bacterial infection, as nitrofurantoin is not a systemically absorbed drug going through the kidneys. It only deposits in bladder and used is a very good chemotherapeutic agent to prevent urinary tract infection recurrence and used as prophylaxis only. This is a simple take-home message for all pediatricians. Never use nitrofurantoin even when it's actually showing sensitive in a ESBL organism giving rise to UTI for treatment of UTI with systemic features like febrile infants.
Correct. Correct.
Cholesterol, there's a possibility of nephrotoxicity.
Right, sir. So we can
Closely
always check the
nephrotoxicity.
RFT on a periodic period because the child is always admitted to get cholesterol. Yes, sir. For nitafurantoin, yes, sir. We'll come to that. We'll come to that, definitely.
So it's a girl child actually, very unlikely to have a GSPD positive, but there is a chance of polyp. So yes,
Still we do it, right. So now, what are the interim history? The child is having UTI, some symptoms. When the child is not having this UTI, does the child still have some lower urinary tract symptoms? That has to be asked on first episode only. Somehow I missed. So my colleague catch that. So Dr. Aditi, what are the symptoms you need to know the child is having in between the episodes of UTI?
So we should take the history regarding whether the child is having constipation or not.
Must
We
take the
should,
history.
Show the Bristol stool scale to the mother or ask how the stool is formed or not, number one. Number two, whether the mother noticed any lower limb weakness or excessive thinness of the bilateral lower limb, which can be suggestive of neurogenic bladder.
Right.
Dribbling of the urine, hesitancy, urgency, frequency, all these symptoms should be asked
Correct.
even in the first visit also. And one of the important, whether the child is adopts any delaying tactics or not for the bladder bowel dysfunction part. And other history of previous febrile UTI, we should take care of this.
Right, very well taken. So this history has to be asked repeatedly. एक दो बार पूछेंगे, mother नाक पे ना बोलते रहेंगे. Particularly constipation, mother will deny you a constipation unless you do an X-ray or a ultrasound rectal diameter and you prove that or take a potty picture and match with the Bristol stool chart. They will never accept that the child is having constipation. सुबह सुबह तो एक बार बढ़िया कर रहा है, क्या problem है? मैंने me and Dr. Poonam does a nephro clinic there and we just hit the head of the mother to ask the history of constipation, and believe me, after doing an X-ray or something, there are clear-cut pictures of constipation, and treating them are rewards for treating UTI. So ask of the history of interim symptoms, what are the urgency, etc. Is there any prior UTI or not? Ask for a family history of UTI in siblings, not direct UTI is familial, but viewer may be familiar for that some reason. So you have to ask for that reason. So this is case of urgency. He or she can't wait the toilet after he get an alarm. So within a minute he has to pee, otherwise he will lick the pant. This is a classical history for a girl child who holds the urine by doing a hip flex. So any of the physicians can tell this, what is the symptoms? Anybody? सुनाई नहीं दिया, खाना जोर से बोलना है. हाँ जी, Vincent Cursi, correct. So इतने लोगों को कैडबरी कैसे देंगे? तो for the time is skipping. So not to miss the history of constipation and constipation. So at least check the urine stream video properly, particularly for a boy child, because we are not that lucky कि हमारे सामने मेरे OPD practice के सामने वो पेशाब करके दिखाएगा. So better to take multiple videos of the urine and obviously try to capture the stool picture and match with the Bristol stool chart, which was discussed in a length in our morning session already. So a urine video and a stool chart. Fine. So what are the examination findings, Dr. Poonam? Now come to the point. What are the special examination? We are doing lots of examination in our Centurion clinic. We get hardly 1 minute time for a child. History के लिए 5 second, examination के लिए 3 second. So what are the examination for 3 second?
Yeah. So first of all, the constipation that has been spoken about, we just check the abdomen whether there is a fecaloma palpable or not. Even
Correct.
if the mother says there is no constipation, if there are fecalomas present, get an X-ray done.
Right.
Show it to them. That's
Right.
constipation.
That's
and these are the very common things which we usually miss. Female child with labial synecdoche, there may be phimosis in a boy child, there may be ballooning of the prepuce, that may be an indication of that there is a phimosis over there. These things can cause UTI. And again, these are the telltale evidence of a occult spina bifida, which can lead to neurogenic bladder, which the parents also do not know, nobody has ever noticed, but the child is having recurrent UTI. This points out the cause of the UTI.
Right. So spine examination and back examination is important. Easy to say, difficult to do. In my North Bengal Medical College, 50% are standing outside. For an 11-year girl without any curtain, how can I examine a private part by that? So you have to make some arrangements, but not to skip the examination. Otherwise, you skip a vital diagnosis might be. So important examination is blood. Yes, please, sir.
One important
Yes,
thing
sir.
here, that's not actually simple phimosis that Dr. Poonam showed. That is balanitis xerotic obliterative. And that has got very strong association with urinary tract dysfunction and UTI. Simple phimosis might not be actually giving that much importance.
Right, right. So high blood pressure, a very, very important thing, particularly for repeated UTI, kidney scars. This is one of the missed vital. Most of us does weight of a child regularly, height, more than 50% does the height also. Blood pressure, I believe hardly 10-20% of the pediatrician, for all patients does this blood pressure. So at least for UTI kids, please do the blood pressure with a proper cuff and also when the child is not crying. So then, this girl again, this lucky girl, Misty, who still don't have a recurrent UTI as per definition. So now having another fifth episode with a fever and lower unit tract symptoms. So now become a girl with recurrent UTI, making us happy or unhappy. So now a second ultrasound was done. Previous one was absolutely normal, and that does happen. Ultrasound 10 दुकान से करके लाएगा, 10 टाइप के रिपोर्ट्स आएंगे. किसी में लेफ्ट किडनी स्वेलिंग, किसी में राइट किडनी स्वेलिंग. So this time having a left kidney hydronephrosis. Rest of the things are okay. And this is the 2 lines in the ultrasound reports. A very busy radiologist doing this. So this is the hydronephrosis. You can see obviously. So what's the MCU finding, Dr. Poonam, for this child? Yeah. So recurrent UTI, by default we are going to do ultrasound, MCU, DMSA. MCU was done, but पढ़ना तो आता नहीं.
So MCU in a child with UTI, usually we perform MCU to check whether there is reflux or not. Although USG also showed left kidney hydronephrosis. This MCU shows nicely rounded, a bit elongated bladder, but otherwise smooth outline. Okay. But there is no VUR. So can we say that there is no cause of UTI from this MCU? No. There is a distinct finding, the lower down, that is the spin top urethra. The upper part of the urethra is dilated, lower part of the urethra is narrow. This happens when there is dysfunctional voiding. The sphincter is contracted, bladder is contracting. Right. So the child is not able to pass urine properly. This dysfunctional voiding, this is a very common cause of UTI.
So Lattu bladder, the spin top bladder. Whenever your bladder is contracting, your sphincter should be dilating to have an easy pass out. Yet the sphincter is also parallelly contracting. So this is a classical case of DSD. मतलब क्या?
This dysfunctional voiding. This is not DSD. DSD is different.
It's a voiding dysfunction, correct? So need to be corrected. Otherwise, repeated UTI will happen for this reason only. And this is not a benign aqueous thing. It can be something bad also. So after that, how to confirm this diagnosis? Only by the MCU, or we can have other semi-invasive way at least?
Yeah, there is another non-invasive way.
Non-invasive way.
There is a
what is this Hebrew? Like Hebrew or? What is this?
This is the uroflowmetry with EMG. There are both the things together. Uroflowmetry we have talked about in the morning also. This is the flow of the urine, how it is flowing. Over here we can see there is rise and bit fall, rise and bit fall. So this is this would fall into a staccato curve. Staccato curve happens when the sphincter is contracting in between. The bladder is contracting, the sphincter is relaxing, then contracting, relaxing, then contracting. So the flow.
So for general information, that should be ideally bell shape.
Yes.
Right?
Rather
so this
than
is not a bell. This is
staccato.
Intermittent staccato.
And this is the EMG curve. EMG showing intermittently increased activity. Right. So this again goes in favor of what we saw in the MCU, that the sphincter is contracting at times.
Right.
So this
so
is a
during
dysfunctional
voiding, there should be zero activity there. This should be a straight line.
Absolutely.
If there is any activity, this is now voiding dysfunction. And this is obviously a non-invasive test. We don't need to put a catheter also for this test.
Is it possible to do the uroflowmetry for the infant?
For infants, it's
toilet
very difficult.
Sir, toilet trend change आने वाली. इसको 4 साल का हो गया बच्चा, तो whenever a child is toilet trained, then only you usually do uroflow. If the child is infant, we can do UDS, but that can become invasive. Okay? For uroflow, we need a toilet trend.
No, in infants, dysfunctional voiding is itself common. It's a physiological phenomenon because the sphincter does not relax properly in an infant.
Right. That's
so we are not looking for a dysfunctional voider in an infant.
If the patient is having the recurrent UTI with the infant, if you suspect the dysfunction, then urometry is not possible.
Uroflowmetry is usually
not
possible.
Sir, not possible. UDS can be.
We do UDS
possible.
in infants also.
So now 10 days of antibiotic completed. Baby is pretty well. She has constipation and intermittent holding behavior also at 4 years of age. What is the follow-up management, Dr. Biplab? So antibiotic and completed, or do you need further management for the constipation, etc., etc.?
So Misty has clearly recurrent UTI.
Yeah.
And the cause of recurrent UTI is bladder bowel dysfunction.
Happy?
So yes. So the diagnosis DSD that you have said detrusor sphincter dyssynergia, and so prevent further relapse of UTI, you have to give antibiotic prophylaxis.
Prophylaxis.
Yes.
So what thing? Meropenem or colistin or what prophylaxis?
So prophylaxis, the drugs we commonly use is nitrofurantoin or cotrimoxazole, and we should give prophylaxis as long as the 3 things achieved.
Right.
One is toilet training.
Right.
And number two is resolution of the bladder wall dysfunction either by urotherapy or other medicines. And number 3 is there is no febrile UTI in last 1 year.
Right.
So after starting antibiotic, we have to look for all these things.
Right.
As well as there are some other issues on the background, like the child is having constipation. So we have to use a bowel regimen to relieve this constipation. And we should treat the we used to treat the bladder bowel dysfunction by urotherapy for at least 6 months, and some other medicines like anticholinergic or alpha blocker, whatever is required for treatment of
So
DSD.
bladder therapy, bowel therapy, and antibiotic prophylaxis for this child at least. And antibiotics should be, there is a clear guideline, very low spectrum, either Septran or maybe nitrofurantoin for at least the desired duration. And before, yes sir, please. Sir, the duration was variable. the duration as is told, maybe suppose you treat the constipation well, you have no UTI, then after 1 year you can stop that. So usually 1 to 2 years for this type where there are no VUR, only for BBD. For VUR the guidelines are little bit different. Yes, sir, right. If the child is having same child, 2 months of age, we start with cephaloxime. Below 3 months, we are not preferring Septran or nitrofurantoin. That's why we are using cephaloxime, because the spectrum of cephaloxime is much more than Septran and nitrofurantoin. And for prophylaxis, we need a narrow spectrum. So that's why for therapy, we have higher spectrum. So cephaloxime is by default choice for less than 3 months, where nitrofurantoin cannot be given. Yes, sir, right, you can tell. More or less 1.5 to 2 milligram per kg on a single dose, maybe night dose, preferably a night dose.
So Septran can be given after 1.5 months.
Yes, sir, usually we 2 to 3 months after we
Only
give it.
problem is the hyperbilirubinemia. So
Right, sir. The liver issue is the issue. Better to do, as sir told, as Dr. Rafiqul told, we need to do a G6PD. For Asian girls also we do a G6PD by default.
So as per the ISPN 23 guideline, below 3 to 6 months, as per the ISP 23 guideline, below 3 to 6 months, we should avoid nitrofurantoin or cotrimoxazole.
Right,
the drug
right.
is cephalexin.
Correct.
But because it's broad spectrum and the chances of resistance is high, so we should stick ourselves to up to 3 to 6 months.
Right.
And beyond
After
that,
that we
we
switch.
should shift
If
to
you're-
nitrofurantoin or cephalexin.
If you need longer, just shift the antibiotic after 4 or 5 months of age. So does this child needs a DMSA also? Recurrent UTI? Yes or no? Audience? Yes. So हम लोग करवा भी दिए. मम्मी को पकड़ के मार के पीट के करवा दिए. So कौन सा स्कार आया? हाइड्रोनेफ्रोसिस किस तरफ था? भूल गए थे. स्कार है कि नहीं है? कौन सा तरफ है? लेफ्ट राइट? लेफ्ट और राइट? लेफ्ट और राइट? चलो. लेफ्ट इज लेफ्ट इन DMSA because the view is on AP view. चलो. लेफ्ट साइड में ही हाइड्रोनेफ्रोसिस था. As far you remember? No? Left kidney nephrosis? तो चलो. It's a joke. चलो. So dysfunctional voidings are not always benign. That can cause a toll on your life. So better to treat your bowel habit well, your bladder habit well, so you don't land up in this problem, because these are permanent scar. They will create either hypertension, proteinuria, etc., and can damage the opposite kidney in due course. So now, DMSA got a scar, unfortunately. When to refer to a pediatric nephrologist, Subankar? Are we already late for this one?
So, okay, actually, there's no clear recommendation for referring the pediatric nephrologist, because I think we can manage in your setup. But when you feel it's not able to manage like recurrent UTI, we need to find out the exact cause why this child is having recurrent UTI. It could be bladder dysfunction or anatomical anomaly. Specifically, the lower urinary tract symptoms is there, like obstructive symptoms is there. Right. And child is already developed some scar kidney. So these kind of kids need a regular follow-up to monitor the blood pressure, to control the GFR, so that the child is not drastically fall and enter into the end-stage renal disease. So as a pediatric nephrologist, they have some mechanism, they have some care actually, they can do the retard the progression of the CKD. So that's right. The most standard indication to send the pediatric nephrologist.
Right. So simple UTI, no need to refer. Pediatrician can jolly well treat that. Only when there is a complication or there is a background abnormality, then only you need to refer. As Dr. Rajiv says, Rajiv sir के पास भेज दीजिएगा. ठीक है? So the simple guideline was 10 years back, जहाँ पे referral का clean indication था. This guideline does not mention, as Dr. Subankar told, the referral, but seems to be similar type of indication. Correct? So now, the protocol-wise management can protect your child early, diagnose any problem much early, and a good management can give you a good kidney life for a long time. So now, after discussion with the, अब तो स्कूल के ज़माने में स्कूल में WhatsApp group भी हो गया है, mother are in this group. So मिष्टी को क्या क्या हुआ है पूरा स्कूल को पता है, all school knows. So one of his colleagues, classmate, Bstic, got similar episode of dysuria frequency. This mom is be smarter. वो Bstic की मम्मी जैसा उतना tough नहीं है. So prior holding behaviors was there. So this time mom ने सोचा कि ये पैनलिस्ट लोगों से तो शायद Bstic का ट्रीटमेंट होगा नहीं, ना ही इस moderator से होगा. So they directly approach Padi sir. So now clean catch urine was taken, no pus cell, started on cefixime syrup as a protocol, standard protocol. Day 3 culture came as Klebsiella, 50,000 colony count, sensitive to amikacin, resistance to cefixime, well on day 3. So now repeat questions so audience can also answer easily. So is this a first UTI, yes or no? Yes, अच्छा खुश हो गए. सर ये तो complicated UTI के बारे में सर ने बोले डिस्कस करने के लिए.
Nowadays we are actually getting a zoo. I know it's not a common organism, but you can get Klebsiella pneumonia giving rise to
right,
UTI,
sir.
even in the community.
But you are correct. Still, E. coli holds the first position.
Absolutely.
But first और second में difference धीरे-धीरे कम हो रहा है. शायद 10 साल के बाद this boss can become first one. I don't know. So next, so Bristy asymptomatic on day 10. Mom did the urine test again against the advice of Pahari sir. So now urine pustule was 15, bacteria was 2 plus, 2 plus, 3 plus ही था शायद, 2 plus लिख दिया हूँ. Culture came 10 to the 5, sensitive to ofloxacin, resistant to cefixime, and sample was taken from, बहुत favorite item है, potty seed. Potty seed से sample उठाओ, काम खत्म. Girl child, so mom started ofloxacin because previous doctor has written a diary of ofloxacin, mom को याद है कितना ml लेना है. So mom started that. I told sir, this is pretty smart mom. So is this a recurrent UTI, persistent UTI, or no UTI? UTI resolved. अरे बाप रे স্যার অডিয়েন্স সব বলে দিচ্ছে স্যার এক্সপার্ট তো যাচ্ছেই না স্যার কি করা যাবে যাকে পোস্ট লাঞ্চ দেওয়া এই স্যারের খাবারটা বোধহয় ঘুম পাচ্ছে না বৃষ্টি নাও 3 years old frequency for 3 days afebrile but there is increased frequency मॉम ने बोला क्या यूरिन टेस्ट करेंगे वही तो सेफिक्सिम देने वाले हैं तो दैट टाइम स्किप द यूरिन टेस्ट स्टार्टेड ofloxacin because last time ofloxacin पाने के बाद baby was well increase the water intake also and the baby become fine also is this a UTI then is this a recurrent UTI ये पहला UTI तो हो चुका है नहीं है
The house is saying no.
Sorry sir no afebrile UTI can also happen is this a afebrile UTI no culture no UTI अगर भेजे नहीं है तो treat करो but don't label as UTI right UTI means symptoms plus culture positive on a correctly collected sample so test has not been sent so why हम लोग झगड़ा कर रहे हैं UTI की नहीं no UTI accepted चलो fine so now 3.5 years old, frequency, dysuria, 3 days, still afebrile. So now clean cash sample was taken because पिछले बार मम्मी ने काफी डांट खाए पहाड़ी से. So अभी वो sample भेजे proper collection, not from the potty seat. 30 to 40 per cells, E. coli 50,000, sensitive to cefoxidim, well on day 3 with clavum because sensitivity report came late. Already started on amoxiclav that time. Ultrasound is fine. So now is this an recurrent UTI? Yes or no? Does हाँ जी सर फीवर है क्या
Not febrile UTI.
अच्छा we can give one more chance is this a recurrent UTI
Yeah, symptom is there.
this is a UTI is this a recurrent UTI so first one is a febrile UTI this one is a afebrile UTI so still not recurrent UTI भैया MC वाले को बोलना है और two febrile episodes in full के
2 episodes of febrile UTI.
चलो अभी भी चांस है बच्चा फिर से आएगा चिंता मत करो जिसका प्रायर बाउल डिफेक्ट्स है वो तो आएगा ही शायद डॉक्टर सब इनके बाद आएगा लेकिन स्मार्ट मॉम नॉट चेंजिंग द डॉक्टर एनीवे बृष्टि 3.5 years old सॉरी शायद नीचे वाला नहीं दिख रहा पीछे से तो 3.5 year girl fever dysuria 3 days clean catch urine sample 30 to 40 per cells again E. coli similar type of culture 50,000 क्योंकि सर बोल रहे थे क्लेप्सिया तो कॉमन नहीं है तो E. coli ला दिए रेजिस्टेंस टू यही हुआ प्रॉब्लम रेजिस्टेंस टू amoxiclav sensitive to meropenem still febrile on day 3 with amoxiclav ultrasound KUV is still fine दो बंदे ने कर दिए अल्ट्रासाउंड में कोई हाइड्रोफिसिस नहीं है अभी रिकरेंट है क्या इतने बार पूछ रहा है तो yes now Santanu sir is happy so now this is recurrent UTI so sir अभी दवाई देना क्या है amoxiclav cefixime nitrofurantoin meropenem colistin medicine meropenem so already we have a sensitive report use meropenem you can obviously send a repeat culture before starting meropenem and at that time you can also do a ultrasound कि कहीं भैया pyelonephrosis तो होके नहीं रखा है तो फिर तो पास्ट को शायद पूनम मैडम को बुला के डिटेन करना पड़ेगा मोस्ट लाइकली सो MCU करना है क्या
Now it's a
आज
recurrent
कल
UTI.
परसों आज कल परसों 1 महीने बाद 1 साल बाद 4 महीने के बाद after the infection settles so please complete your antibiotic properly and then you can ask our pediatric surgeon to please do that.
This is actually a very important point. Not everyone is going to have a luxury of having a pediatric surgeon or urologist to do the MCU. If a child is actually admitted after 5-7 days of treatment and if the child is actually well before discharge, please try to do the MCUG beforehand because previously we used to actually wait for 2 to 3 weeks and having a repeat urine culture negative, urinary showing no passages, and then we are doing MCUG under antibiotic cover. But the current guideline clearly says if your child is well and if you giving injection meropenem, so obviously this child is actually being treated as an inpatient. So as soon as your child is well and there is no features of any active inflammation going on, you can actually perform the MCUG under antibiotic coverage.
Right. So duration was 7 to 10 days for a standard UTI or a febrile UTI or a complicated UTI. For a lower tract infection, the duration can be little bit less, 3 to 5 days. Previously, it was 14 days longer. Yes, ma'am. Your
The comment I would make with this patient is
yes, ma'am.
that I don't care if this is termed as recurrent UTI or not recurrent
Right, ma'am.
UTI, whether you do a
Well
MCU
taken.
now or later,
Right, ma'am.
DMSA now or later, I don't think that all that is the issue.
Why
the issue
recurrent?
here is multiple episodes of urinary symptoms with other sort of bladder,
Right.
possible bowel holding and all, I think you
Right.
said somewhere.
Ah, so, ma'am, right.
So
Prior.
many episodes. Why are we waiting till the 4th, 5th episode before
Right.
the alarm bells are ringing? Long before we should be looking at a bladder diary,
Right, ma'am.
constipation.
No,
those
that-
are,
that-
those
right, ma'am.
should be the focus and
Right.
what is this recurrent or
Right,
not?
ma'am.
Where is the ultrasound?
Correct.
So I think these are the issues
Correct.
that we
Now,
need to
ultrasound
look
is done. Rest of the things are also done, not mentioned for the
Absolutely agree.
sequence.
Santanu?
So, yes, sir.
Actually, we are advising USG.
Yes, please.
But my radiologist will only write down that AP diameter of scarring
You are lucky,
and,
sir,
and,
they are
and the
mentioned.
bladder volume. So
Yes.
what actually pinpointing we have to write, whether the corticomedullary difference and AP diameter,
Right.
major calicial. So what should be our advice? That
So one solution is we can write the points in that picture that we need a kidney size, an AP diameter, a cortical thickness in the all the three parameters, upper pole, lower pole. How
I
is the
think-
hydroureter? How is the bladder total volume and what is the PVR?
I
You
think
can
for
have
a
stamp
practical
of-
point,
Yes, sir.
what is important, all of you should actually find out a radiologist who will be very happy to actually do the renal ultrasound as per your guidance and as per ISPN guidance. The minimum that you will need from a radiologist, not just simple the kidney size, you want to see whether there is any pelvic axial dilatation, whether there is any diameter, pelvic diameter in the transverse at the hilar lip has been mentioned, not just actually anywhere. It might be an extrarenal pelvic dilatation that might not be having any clinical significance. Second, they usually do mention whether there is any ureteric dilatation. They will mention whether there is any bladder wall thickness, and also please do ask whether there is any residual volume. Because these are the 4 points you would definitely like from an ultrasound examination other than renal ultrasound. So any pelvic axial dilatation, any ureteric dilatation, bladder wall thickness, and any residual volume. These are the 4 most important things that you need.
Plus one.
And if there is a possibility of that ultrasonologist doing very well from the bowel point of view, very few pediatric ultrasonologists are there who is going to really look into transverse rectal diameter. If they can, that is actually a bonus point for you.
Right.
Dr. Shumanto, can you
So-
show the...
Right.
Unless we know what was the pre-void.
Show
If
the
the
chart, the flow chart, please, the guideline.
If the pre-void was very low, then the post-void becomes almost meaningless. So we should also know what was the pre-void and not only the post-void.
Yeah.
This one?
Yes. Over here, as Madam was saying, the first part, even before ultrasound, the first assessment is assess for BBD.
Right.
That's the first part that has
Absolutely.
never to be
Absolutely.
forgotten. Even many a times we do not need a MCU, even if there is hydronephrosis, if there is significant BBD, we have to manage the BBD. And most of the cases, the UTIs do not happen again.
Right.
Even if there is hydronephrosis and there is bladder bowel dysfunction, the bladder bowel dysfunction will cause VUR or some pressure changes, and hydronephrosis would be there.
So, sorry to intervene. As I said in the morning, there has been a paradigm change in Alport, right? Now, they are saying that you diagnose Alport very early so that you can start. Similarly, in the last 10 years, 15 years, there has been a paradigm change in UTI also. For us, UTI, particularly for general pediatricians, UTI is BBD. This is something that has come out. So we have to focus, particularly for the general pediatricians, on the bladder bowel dysfunction. Constipation, if you ask mother, আমি যেটা বাংলায় বলি কি দ্যাট বাঙালিরা কনস্টিপেশনের জন্য আমরা ভয় পাই না, আমরা সবসময় ডায়রিয়াতে ভয় পাই। মাকে অনেকবার জিজ্ঞেস করা হয় কনস্টিপেশন না।
Now, I think there is a paradigm shift now. I think people are worried
So
about
better
constipation
treating the
nowadays a
UTI,
bit
have
more.
your co-prescription of something like either your bowel, water intake, potty seat habit, and maybe some medication like Laxopeg or Dufela. People are sitting just opposite the room. So please have their option rationally.
And
obviously.
often the family is also quite surprised that I came to a kidney doctor for UTI and he is treating me with for constipation. but that is something you have to
A
explain.
lot of Rajiv's patients come back to me, sir को दिखाया, ये stool chart देके हमारा treatment कैसे कर दिया sir? हम तो UTI लेके गए थे, Bristol stool chart.
So, that is a paradigm change that has happened.
So
You
thanks to
can
the
focus on
BSPN team
PPT.
once more, and thanks to the audience. Finally, audience is जीत गए. So I
All
again
the audience
welcome.
really learned to be an expert on managing UTI. Thanks to Sumantro for your brilliant presentation all
So
through
on the
it
same
and all the
occasion, for the
panelists.
next Pedicon in our national Pedicon in Kolkata, we have a brilliant such nephrology workshop will be there. Please do attend. So I thanks to my panelists and obviously Dr. Subankar who is going to present the algorithm he has created with the help of RD Sir's guidance. So over to chairpersons. Question hai?
Thank
sir?
you, thank
Sir,
you.
that
I
depends
think
on sir.
we will be very happy to
Depends on
take the
chairperson.
questions after Dr. Sarkar actually goes through the algorithm. This algorithm, I must say, I have minimum contribution as an expert. Dr. Subhankar Sarkar did it all by himself, going through the ISPN guideline regarding the recurrent UTI algorithm that he is going to present just now. Algorithm. Next.
So while we are waiting for the algorithm to be uploaded, if you have a question, then you can ask because we are running out of time. So.
Sir, if the child has been discharged from hospital and the child is not on a follow-up, the child comes after 2 weeks. Should we, before going to an MCUG, should we restart the antibiotics? Is there any guidelines?
Sumantro.
Does that, though there are few trials in a control setting कि antibiotic नहीं देके भी infection rate are similar, but they are done under a very good control setting where the catheterization is done by trained doctor. Many of the center doing MCU might not have the 10% to do the catheterization. So in our center we give 3 days of antibiotic prophylaxis, 1 day prior, on that day and after that day. So once your antibiotic is completed, the child comes after 3 or 4 weeks, then you can do that. If Pahadi sir was just suggesting that your child is already on a plan of day 10 or day 9 antibiotic, if your child is very well on day 8, you have a clean urine as per Dr. Poonam asked, you can do it on day 9, so that's why 1 day extra of antibiotic post procedure. So your job was done within the antibiotic coverage, okay? But again, this may vary from center to center.
Sumanto, recurrent UTI, febrile UTI.
Yes, sir.
You are excluding any organ specific or organic abnormalities. When at present, when at that situation you will go for to rule out some immunodeficiency underlying is there or not?
Right, sir. For recurrent UTI, you are asking, sir, or single?
That is only one infection that I can tell you. Recurrent UTI is not associated with immune deficiency. It's more defects of innate immunity, is more defects of barrier function, is more defect of your periurethral flora, is more dependent on adherence to the bladder wall by the pathogenic E. coli fimbriae. So it's actually not associated with any primary immune deficiency. So you don't need to do any immune deficiency workup for recurrent UTI.
I think, so you have got 5 minutes.
Okay, so I just try to summarize the 40 pages guideline in a 5 to 6 slides actually. So we already share with you as a printed version in your booklet. So UTI prevalence is about 2% in boys and 7% is girl. And symptom is most of the time is non-specific. So many a time you have a child with fever, definitely you think about the UTI. And it's very easy to do by doing the some few tests actually. The risk factor, those who have a constipation, neurogenic bladder, labial adhesion, and urinary tract obstruction. These are the key point to say UTI could be there or not. Key physical finding, you do the palpate the bladder. If the bladder is palpable, then pointing toward the obstructive uropathy. If the kidney is palpable, that is pointing toward the hydronephrosis or upper tract obstruction. And if there is a fecalith, then it's a pointing toward the constipation. Also do the neuro examination like lower limb power and tone and sensation, perineal sensation. And definitely do the genital examination. So diagnosis mainly initial base of the urine collection, analysis of the urine. So how to collect? We already discussed that toilet trained child, clean catch urine method, clean catch method, and if the non-toilet trained, then you attempt the clean catch. If fail, then you go for catheterization and suprapubic aspiration. In a sick child, you definitely prefer to the catheterization or suprapubic aspiration. So definitely you use the freshly voided sample to get the better result. And if it's not possible, then room temperature, do analysis within 1 to 2 hours, not more than that actually. And if you put in a refrigerator, you just use the urine within 4 hours of collection. So screening test before your culture is available, to start the antibiotic, you do the first line screening test, that is the dipstick. We have already discussed a lot about that actually. To do the just mainly the leukocyte esterase and nitrate. That is give a clue the UTI is there or not and start the antibiotic or not. If it is possible, then you do the bacteria like microscopy, bacteria and leukocyturia. That can give a good idea about that actually. So here is a sensitivity and specificity of both these things to decide about the which test is better or not. So now the confirmation of the diagnosis of UTI. That is already we discussed a lot actually. Symptoms must be there. Symptoms plus significant growth of the single uropathogen of the urine culture. So what are the significant growth of the bacteria? We already discussed. I'm not going to repeat that actually. So this algorithm says that if it is leukocyte esterase or nitrite is positive, then you start the empirical antibiotic and look for the culture positivity. If it is positive, then continue the antibiotic and finish the antibiotic. But if it is negative, if the risk is there, like recurrent UTI, child with a recurrent UTI, bladder bowel dysfunction, and age less than 6 months, then also you consider to start the empirical antibiotic and wait for the culture. If the culture is negative, then you change your mind and just stop the antibiotic. But if it is positive, you have to continue the antibiotic, the full course of the antibiotic. So once the urinary tract infection is proved, I mean you have a urine infection, and if you think it's a cystitis, like in older kids, like in adult, so cystitis, oral antibiotic is preferred. But in febrile UTI, suspecting pyelonephritis, less than 2 years of 2 months of age, sepsis, renal angle tenderness, poor oral intake, definitely use the IV antibiotic. But IV antibiotic, you just 3 to 4 days is enough. After that also you can change to the oral antibiotic. So now guideline says more pointing toward the oral antibiotic. Those who are stable, those who are adolescent, those who have cystitis, better you choose oral antibiotic. But those who are sick, young kids, complicated urinary tract infection, then you choose the IV antibiotic. But IV antibiotic after 2 to 3 days, 3 to 4 days, you can change to the oral sensitive antibiotic. And empirical antibiotic, third generation cephalosporin is a very good choice, or coamoxiclav is a option. And in adolescents, those who have a lower tract infection, that is also cephalosporin plus coamoxiclav can be chosen. And the duration of the antibiotic, febrile UTI, we have mentioned that 7 to 10 days is enough, not for 14 days to continue the antibiotic. But cystitis, 3 to 7 days also good enough to treat the antibiotic. Imaging following UTI, very simplified way, all kids ultrasound to be done after a 1 episode of UTI. If it is thinking about the MCU, the indication is abnormal USG finding, children with less than 2 years with non-E. coli UTI and recurrent UTI. If it is DMS scan, only the recurrent UTI need to merit for the DMS scan. Antibiotic prophylaxis is recommended in normal urinary tract, but no bladder bowel dysfunction, that is against actually. So normal, no BBD, no antibiotic prophylaxis needed. High grade viewer. So viewer 1 to 2 not need any antibiotic, but if it is 3 to 5, you need to start the antibiotic prophylaxis. And recurrent febrile UTI with bladder bowel dysfunction, you need to start the antibiotic. Infant with recurrent UTI, low grade viewer, like 1 or 2 grade, then also you can consider to give the antibiotic. Prevention of the recurrent UTI, so surgery like reimplantation. So recurrent febrile UTI, despite prophylaxis, antibiotic, and control of the bowel bladder dysfunction, but still the child is having throwing recurrent UTI, then you can send to the surgeon for the reimplantation. Canberry product, these are like soft treatment therapy. You can use in a recurrent UTI with normal urinary tract infection, urinary tract, urotherapy, all patients with bladder bowel dysfunction, circumcision in considering male children with risks of recurrent UTI. I think just summary is in the last slide. So if the child is having suspected UTI, do the dipstick, and you decide about the empirical antibiotic.
It is all given in the in your handout.
Yeah. So if it is leukocyte esterase or nitrite is positive, start empirical antibiotic and look for the culture.
Subhankar, we can
we can stop here also. We can go
all
for
in the handout.
Okay.
So if you have any questions now, you can ask while I think Niladri can put up the Mentimeter thing.
Yeah. Which one? USG you can done
ultrasound.
immediately as soon as you suspect. You don't need to wait. What is? Never.
We never write that.
Never.
So the question is the alkali mixture.
There is no evidence of alkali mixture ever going to make any difference in the management of UTI. It's not recommended at all. Not as a placebo as well.
No role. No role of folic acid by according to the guidelines.
Just a
In
minute.
complicated UTI, which antibiotic we should start before the culture coming up?
I think Dr. Shubhankar clearly mentioned in the algorithm, if it is a complicated UTI in a younger child, the child is getting admitted, we are still starting on third generation cephalosporins IV. If you are actually managing on outpatient basis, Kefixin oral is actually still going to be your drug of choice. Next.
Hello, is there any role of cranberry?
Yes, ma'am. Canberry product has a role.
Cranberry product, there is immense role in adult UTI. Is there any role in pediatric UTI?
Yes, current the new guideline says we can use actually, but Canberry has lot of product and the taste is very bad.
No, not the taste. The amount that you need to
Amount,
take
amount,
is actually quite huge, and that taste is bad. The commercially available real producing cranberry juice has got a very small percentage of it. Sumantro actually did the publication with Pankaj Hari. You can tell them about it. Cranberry
Sir,
juice.
actually-
What's the exact amount?
Only cranberry juice for the anthocyanidin part, not the total cranberry volume. That should be coming around something 1 to 1.5 liters for a 20-kilo child, which is difficult to take. And the cranberry is not from the Amazon, which contains huge amount of sugar. It's a pure cranberry, difficult to get.
So for all practical purposes, I don't find it having any rule.
No. I mean, there is a product is available. The adults use it. We don't, because I don't know why we don't. Cranberry capsule. That has a active component of this pro-antha, whatever.
Not
that
written
is.
how much of pro-anthocyanidin. They only write the milligram of cranberry.
They have that can be found out. And
I will really ask one of you to actually do a study on this, and then we can discuss about this further. We don't have enough evidence about it.
Prophylaxis. So should we continue prophylaxis until we do the ultrasound or MCUG? Because this is something you're saying, no BBD, no primary VR. So we have to continue prophylaxis after completing the antibiotics. I
I think often you are feeling doubt, and it fits into the criteria. While you are waiting for further evaluation of this child, you can continue on prophylaxis and take the decision once you have got more information.
And what about the age of the child? Say, any younger age, should we?
I think less than 2 years is the kind of cutoff that has been described in the ISPN guideline.
So should we give them prophylaxis until 2 years?
So regarding prophylaxis, just add on the point that if you start the prophylaxis, continue better 1 year. And you reassess if the child is having no febrile UTI, no blood bowel dysfunction, you can stop. Whatever the age, doesn't matter actually.
what is the question? Is there an indication for prophylaxis?
No, we didn't mention actually.
Sorry,
Cystic doesn't.
again, is there an indication for prophylaxis in recurrent cystitis?
There is no indication on prophylaxis on recurrent cystitis. Because
Bladder bowel dysfunction.
absolutely.
You just treat the blood bowel
So you have to
dysfunction.
treat the bladder bowel dysfunction, and if there is bladder bowel dysfunction, you can
You
give
should be
prophylaxis.
treating that rather than treating with any antibiotics. I think, basically, while you're going through the ISPN guideline as suggested by Dr. Sumantro Rao, it's very important you do not forget that each individual child is different. Each individual child is going to present to you with the symptoms of UTI, which might not be absolutely straightforward as per the textbook. It's very important you individualize treatment for the child based on the guideline, which has been done with a lot of evidences by various experts of Indian Society of Pediatric Nephrology to guide you in managing children with UTI, which is a common problem and which should be managed by pediatricians in a very effective way. I think that's all. If the chairperson permits, we should be closing this session.
Thank you all for a highly interactive session. Thank you.
Thanks to the mentor also.
So we are now ready with our fourth and the last session.
So
of
I'd
audience.
request the chairperson and the panelist and the expert to stay around for the 2 questions, and then move on to the সেলফি কর্নার।
এতক্ষণ অনেক কমপ্লিকেটেড কোয়েশ্চেনের আনসার অলরেডি আপনারা দিয়েছেন, and these two questions will be too easy for you, I think. Still more players are getting joined. I want to announce that for the audience quiz, for the first, second and third prize will be a gift hamper of rupees 2,000 rupees, 1,500 and 1,000 rupees respectively. Followed by we'll be having a PG quiz on electrolytes. For that, the first, second and third PG will get 2,500 rupees, 2,000 rupees and 1,500.
বাপরে অনেক তো টাকা।
So stay over there. So 62 players, অনেকেই হয়তো পালিয়ে গেছে অডিয়েন্সের মধ্যে।
So we'll start.
We'll start, huh?
Yeah.
So very easy question, so it's on your way. Ready? 6-month-old girl, first febrile UTI, urine culture E. coli 10 to the power 5, planned for day 10 of antibiotics. USG KUB okay when we are planning for MCUG. প্রচুর ডিটেলসে ডিসকাস হয়েছে এতক্ষণ। এখনো একটু কনফিউশন, হ্যাঁ, ইন্ডিকেশনস অফ এমসিইউজি আদৌ কি লাগবে? ফার্স্ট এপিসোড উইথ অ্যাবনর্মাল ইউএসজি or recurrent UTI or non-E. coli UTI in less than 2 years, কোনোটাও কি ম্যাচ হচ্ছে? This is actually, the answer is as per previous guidelines. So in the morning only we are going with the paradigm shifts. So this is another paradigm shift. So okay, chalo next question and last question for audience. এটা অলরেডি ডিসকাসড হয়ে গেছে, অনেকবার করেছে ডিসকাস। সো 3-year-old boy with PUV, second time turbid urine, dysuria, fever for 2 days on cefixime, well by day 3, but culture এলো resistant to cefixime and sensitive to mero. What is the next best step? অনেকবার ডিসকাস করেছে।
So in your mobile, the font will be larger than this.
Yes, thanks to Sumantroda and their panel, they did a great job.
So
almost majority is correct.
So
we'll
now
continue for cefixime only because of the difference between in vitro and in vivo susceptibility. And
Sir,
since the patient is doing well, so we'll continue with the same antibiotics, despite it is showing as a resistant one. Anyways, the result.
বন্ধ হয়ে যাচ্ছে স্যার, এখনো হচ্ছে, ক্যালকুলেটর ছেড়ে রেজাল্ট নয়,
Result.
কিন্তু ক্যান্ডিডেটরা জানতে পারবে নিজেরা, যে পেয়েছে 1 2 3 জানতে পারবে।
প্রাইজ দেওয়া হবে সবার লাস্টে, সেটাই তো মেন।
Okay, so that brings us to the next session, which is going to be an electrifying session on electrolytes. So for that session, I would request Dr. Tathagata Bose sir to be the judge. Sir is Professor Pediatric Nephrologist in Command Hospital, Alipur, Kolkata. And we have two very vibrant quiz masters with us. Dr. Rohit Bhomik, he is Assistant Professor in the Department of Pediatrics in AIMS Kalyani. And Dr. Niladri Bose, he is Consultant Pediatric Nephrologist in Manipal Hospital, Salt Lake, Kolkata. So over to you, Niladri and Rohit for the electrolyte quiz.
Give us some time to load it.
And the previous চলে যাচ্ছে, ঠিক আছে।
তুমি বলতে থাকো, আমি আগের রেজাল্টটা ডাউনলোড করছি, তুমি রুলসগুলো একবার বলে দাও।
So I would still urge those who are leaving not to leave, because who knows, maybe one of you are getting the cash prize.
দিচ্ছি, তুমি রুলসগুলো আবার একটু বলতে দাও হালকা করে, ওই নেটওয়ার্ক থাকবে।
Mainly for PGs, if you want to come out in the front seat. Because যদি নেটওয়ার্ক কারোর ইস্যু হয়, ওখানে কিন্তু লোডিং দেরিতে হবে। অ্যান্ড ফাস্টেস্ট ফিঙ্গার ফার্স্ট, যে সব থেকে ফার্স্ট সে মেবি হয়তো 5000 পয়েন্ট, যে সব থেকে লেট সে হয়তো মেবি 1000 পয়েন্ট। সো দ্যাট উইল ম্যাটার। আর উইল বি পুটিং দ্য লিঙ্ক টু দ্য গ্রুপ, ইয়োর ডেলিগেট গ্রুপ অনলি। Just give us some time to load. Anyone can participate, only PGTRই first prize, মানে second prize পাবে। Total 25 questions will be there. The
স্টার্ট করে দে নীলাদ্রি। না না at least ওই introduction and
There will
and
be
all
total
that.
25 questions. Some will be image based, some will be on pedigree, some will be some historical based, some genetics based. So I will just read out the quiz mainly, and the options will be in your screen as well as the quiz body, and you have to click.
So Dr. Deblina is sharing the link. So there will be 25 questions. Initial part will be a bit of history, 3-4 questions. Then will be electrolytes related to genetics, and the last part will be pure clinical. So 44 people are ready. So the first question. No, wait. Photo is there.
Okay.
So one photo is there. This famous character from Christmas Carol might be suffering from nephronophthisis, renal tubular acidosis, muscular dystrophy, diabetes insipidus. So the photo and things which is written, it will be shown full in your mobile. And we have given enough time for this. So the correct answer is renal tubular acidosis. Next question, explanation, no time. So all of you ready? Another history. Electrolyte panel, commonly used today, was influenced by the work of which physician who pioneered fluid and electrolyte therapy during World War II? Harvey Cushing, Thomas Edison, James L. Gamble, John Peters. Enough time. So answer is James Gamble, correct answer.
Nice gamble, huh?
So everybody thought Edison and Cushing, right? তোমার এই নেটওয়ার্ক এদের নীলাদ্রি সাম নেটওয়ার্ক ইস্যু হ্যাঁ এটাতে হচ্ছে আছে তো ঠিক Discovery of Liddle syndrome provide crucial insight into which of the following aspects of electrolyte homeostasis? Paracellular calcium reabsorption, inact channel overactivity, hypocalcemia induced tetany, aquaporin 2 regulated by ADH. Excellent. So majority correct, it is inact channel overactivity. Question 4. Who first described relationship between aldosterone and sodium retention, laying to the foundation of understanding aldosterone-related dyselectrolytemia? Bright, Gambles, Hanseli, Jerome Kohn. So majority correct, it is con. Great. So some reports will be there. Concentrate on the reports. Reports will be there in your box. So just minimize, go up and down. Time will be there enough. Next few questions will be like that. And your reports will be larger than in your screen. A term neonate brought with polyuria, vomiting and failure to thrive. Which additional finding is most consistent with this subtype of Bartter syndrome? The lab results will be displayed to you.
The lab results will be showing hypokalemia, metabolic alkalosis, elevated renin aldosterone levels.
Great. So majority corrected, hypercalciuria and normal blood pressure will give the again. A 3-month-old infant brought with recurrent seizure and muscle twitching. Which of the following mechanism best explain the underlying pathophysiology? Lab results are there inside your.
Genetic testing identifies a mutation in the TRPM6 gene. Which of the following mechanism best explains the underlying pathophysiology?
The correct answer, reduced active intestinal magnesium absorption.
Some will be a bit difficult.
Some will be very easy. Nine-year-old girl came with muscle cramps and fatigue. She has hypokalemia, hypomagnesemia, metabolic alkalosis and low urinary calcium. Defective ion channel is?
TRPM6 gene. Despite calcium and magnesium supplementation, hypocalcemia persists.
That is important clue in the question. It is there.
Still many of them are correct only.
Correct answer is SLC12. Two-weeks-old neonate has persistent hyponatremia, hyperkalemia, metabolic acidosis. Renin and aldosterone both elevated. Genetic mutation suggestive of SCNN1A gene defect. Diagnosis is? So it is autosomal recessive type of pseudohypoaldosteronism type 1. Which of the following findings best differentiate type 1 Bartter syndrome from type 4 Bartter syndrome? Presence of nephrocalcinosis, elevated prostaglandin E2 level, sensorineural deafness, hypokalemic metabolic alkalosis. So correct answer is sensorineural deafness. Again, some reports will be there which will be only displayed to you. Dr. Niladri will read that. A child has hypertension, hypokalemia, suppressed renin and aldosterone level. What drug would be most effective?
Genetic testing reveals a gain of function mutation in the SCNN1B gene. Which agent would be most effective?
So amiloride is the correct answer.
This was little.
Again, reports will be there to your screen. Go up and down to see the report. Dr. Niladri will read the report also. A 10-year-old boy with normal BP came with reports. Which finding would strongly support diagnosis of Bartter syndrome over surreptitious diuretic use?
Genetic testing is inconclusive.
High plasma renin, elevated urinary chloride, metabolic alkalosis. So elevated urinary chloride. Next. Which statement among the following is correct? SIDH is not common among hospitalized children. Diabetes insipidus causes hyponatremia. Hypernatremia causes cerebral edema, which can be fatal. Rate of change of sodium is very crucial while treating dysnatremia. So correct, SIDH is common. Diabetes insipidus causes hypernatremia. Hyponatremia causes cerebral edema. The last one majority corrected. So now you will get a bit of breathing space. Easy questions are coming. No history, no gene now. Which of the following is least likely etiology in a 3-year-old hypovolemic child with hyponatremia and urinary sodium concentration of 15 milliequivalent per liter? Pneumonia, cerebral salt wasting syndrome, peritonitis, profuse vomiting and diarrhea. Yes, so CSWS is very least likely because the urinary sodium will be very high in CSWS. Least likely. Sorry. Large doses of sodium salts should be avoided in distal renal tubular acidosis because this may cause increased urinary bicarbonate reabsorption, decreased GFR, reduced extracellular fluid volume, increased urinary calcium excretion. Easy. So, increased urinary calcium excretion. So now all next 10 questions will be very easy. Just concentrate, don't see here and there. All of the following are ECG changes in hypokalemia except ST depression, flattening of T wave, short QT interval, appearance of U wave. These are fast, you have to answer fast to get more marks.
This is kind of a slog over.
Yes. Good. Short QT interval is not seen in hypokalemia. Which of the following is false? DNS contains 154 milliequivalent per liter of sodium. RL contains approximately 4 milliequivalent per liter of potassium. 10% dextrose contains 10 gram of dextrose per 100 ml. 3% NaCl contains 214 milliequivalent per liter of sodium. Fast. Yes, correct is, it is almost 514. Which one of the following causes hyperkalemia? Diarrhea, salbutamol nebulization, Bartter syndrome, vasculotoxic snake bite. So vasculotoxic snake bite causes hyperkalemia. Other all causes hypokalemia.
Especially salbutamol.
Salbutamol causes hypokalemia. So easy questions are coming, slog over. Management of SAIDH include all except 5% albumin infusion, Vaptans, fluid restriction, loop diuretics. Good. Majority, others are all correct answer. 5% albumin is not the answer.
So 5 more questions to go
6.
of 19.
A 3-year-old child present with tetany. Calcium is low, phosphorus 4.3, potassium 3.4, magnesium 1.4, pH 7.3. How to treat? Time is there. IV calcium gluconate, IV bicarb, IV calcium gluconate, IV KCl, IV calcium gluconate, oral phosphorus supplementation, IV calcium gluconate and IV magnesium. You have time. So you have to correct both hypocalcemia and hypomagnesemia because both can cause, you don't know what is causing what. In presence of hypocalcemia and hypomagnesemia, both to be corrected. An intern gave 2 extra doses of injection Maxalab to a child. The patient may develop all of the following except hypertension, hypotonia, sleepiness, hyporeflexia. बहुत easy question है. So correct. Very easy question. He is enjoying.
Good.
बोल रहा है ये क्या question है? Regarding Gordon syndrome, which of the following is false? अभी ठीक है question? The genetic defect causes volume expansion and hypertension, causes hypokalemic renal tubular acidosis. It is an autosomal dominant condition, also known as pseudo-hypoaldosteronism type 2. अभी मजा आया, ठीक है अभी. पहले वाला क्वेश्चन बोले ये क्या है मैक्सल वाला? So it causes hyperkalemic renal tubular acidosis. Almost all electrolyte cover हो गया. Incorrect statement regarding refeeding syndrome occurs frequently during treatment of anorexia nervosa. Dyselectrolytemia usually occurs within the first 5 days of refeeding. Associated with severe hyperphosphatemia can occur during treatment of a child with malnutrition. So good. So it causes hypophosphatemia. बहुत easy था question. Medication that can cause renal losses of magnesium, including all except amphotericin, cisplatin, PPI, lithium. So lithium causes hypermagnesemia. ठीक है अभी ठीक आ रहा है बीच बीच में तो एक दो सही रहेगा ना इजी रहेगा. Chloride. Regarding hyperchloremia, which of the following is false? High volume NS infusion may cause hyperchloremia. Plasma light contains less chloride than normal saline. It causes high anion gap metabolic acidosis. Hyperchloremia is associated with bad prognosis in septic shock patient. Time है आपके पास सोचने के लिए. Great. It causes normal anion gap acidosis. Last question. Phosphate. Which of the following condition causes hyperphosphatemia? Hungry bone syndrome, tumor lysis syndrome, rhabdomyolysis, acute hemolysis. Fast. It will disappear. So correct answer is hungry bone syndrome. It is high. Which of the following condition causes? Chalo, ठीक है. Last is disappeared. So result is.
So So we all have played very well. A big round of applause for everyone.
So you people can get your result, but we won't publicly disclose. We'll disclose after some time.
Thank you, Niladri, Rohitda, and Tathagata sir. So I would request them to calculate the scores and decide the like standings of the various participants in the quiz. And in the meantime, we would like to announce who the winners are for the oral paper as well as the poster presentation. So to hand over the prize to the winners of the oral paper, I would request Dr. Karhui ma'am and Dr. Sushmita Banerjee ma'am to please come on the stage.
So I would like to first, like if Dr. Karhi wants to say anything about like the oral presentations and any comment on the conference also.
Yeah, it has been a long day. I must say, when I attend conferences like this, actually I do learn a lot, not just the scientific aspects, but also the resilience of the people in the region, how you made an exciting and vibrant program with the minimal resources that you have. And often I take back more than I give in every of these trips. So thank you for having me here. And I think the discussions, or rather the presentations this morning was really great. And I think it was hard to, I'm not sure if it's hard to get a winner, but yeah, I think it illustrates the vibrancy of the scientific community that you have. Yeah, so thank you.
So the first, we'll start off with the first prize. So the first prize for the oral. The third. So the third prize for the oral paper presentation goes to Dr. Orijit Nando from Apollo Multispeciality Hospitals. Please come over the stage and accept your certificate as well as prize.
So what was the topic? If you can again say, what was the topic, Devlina?
An observational study regarding the prevalence of joint hypermobility syndrome and constipation in patient admitted with UTI.
So definitely a bit of a, I would say, esoteric topic, and credit goes to the mentor. Who was the mentor?
My mentor was Dr. Amitabo Pahadi sir and Dr. Olgananda Das Datta madam.
Good.
So the second prize goes to Dr. Anindita Nondi for the oral paper presentation. I would request Dr. Anindita if she's around. She is not around. So her topic was initial presentation of children enrolled in the multicentric SLE nephritis prospective registry. She's, yeah, so on her behalf, I would request the mentor, Dr. Shanjukta, to come and collect the prize.
And now
the first prize for the oral paper presentation goes to Dr. Rifa Khan. And her topic was next generation sequencing in the diagnosis of cystic kidney disease in Indian children. Thank you, Karui ma'am.
Do you want to thank anyone for this?
I would like to thank Devlina ma'am and sir also because they guided me through this. So I don't. Yes.
Okay. So now I would request Dr. Jayati Sengupta ma'am and Dr. Swarni to please come over and hand over the prizes for the poster presentation. So the first prize for the poster presentation in the case series case report category goes to Dr. Pallavi Agarwal. Her topic was, I think, persistent hypertension in a child with cystic fibrosis. Right, Pallavi? And the first prize in the poster presentation in the original article category goes again to Dr. Rifa Khan. So just tell everybody what you had presented, Rifa.
My poster was on clinical pathological profile in the HSP nephritis.
And whom would you like to thank also?
Dr. Sanjukta.
So I would request Dr. Sumantra because he really, like the abstract whole headache, screening, most of the thing was done by him. So, but team, he was like the leading sort of it. So would you like to make some comment on it and like, and no, particularly because like people might say that how come all is ICH. So you can say that whether there was any bias on it or not.
থ্যাঙ্কস বন্ধুটা আমার কাঁধে রাখার জন্য ইংলিশটা আমি জানি না সো ফার্স্ট টাইম in the name of Bspncon, the conference is happening and 42 abstracts is a huge number for us for pediatric nephrology subtopic. We didn't expect actually, and the credit goes to all the delegates who have sent that. And obviously in the background they are mentors. Many of the mentors have struggled and pushed a lot to the delegates. But delegates, please do. Pediatric nephrology is not at all a bad topic. You can understand some bit. I know you are in immense pressure of other topics also. Carry on your good works. And maybe original articles are more invited. Take help of your mentors who are more aggressive on this line, and we expect further subsequent year we will have more such topics. All are during the screening judge can better tell that all the competition was tough, very tough during the screening point. 17, 17.5, 18. This was the screening board scorer who are on the top list. So whoever not in the prize list, don't get disheartened. They are also in a good up to the mark majority. Okay, thank you.
So like
and ICH for the thing. Most of the pediatric nephrology works have been done there, so don't get that this is a biased thing because judges are from other centers. None of the judges are from ICS this time. So I know, so because...
yeah, judges. And no, I mean from my side, but I will be frank with you. When we first started, I didn't have the idea of keeping the oral or the scientific presentation. It was later on Paharida, Sumantra, everyone said that there should be some a slot for the scientific presentation. I was a bit worried that how many abstract we will get. And particularly there was a rheumatology conference, I think a month before, there was so much of competition for the postgraduate trainees and all that. But I was quite surprised with the number of abstract, the number of enthusiasm. And particularly even for the original paper, I was thinking that Kolkata our original paper pediatric nephrology the kotai ba asbe, but there was quite a good number of original paper, and as Sumanta said that the competition was very tough, and I on behalf of as a chairperson of the scientific committee, I do apologize that most probably we should have put up at least 6 original papers. So it was my fault that we could only accommodate 3 original papers.
I think from next year onwards we will possibly rectify that. But I really like to offer my sincere thanks to all the faculties from all over Eastern Zone, all the pediatric nephrologists who actually helped Dr. Sumantro in selecting those abstracts for different categories of presentations on oral, pitch poster, as well as poster presentation. So thanks goes to, from Dr. Sarnim to Dr. Mridu, Dr. Himesh, Dr. Subal, Dr. Amit, all those busy pediatric nephrologists who really took time off and go through all those abstracts in a meticulous manner to do a proper kind of evaluation on them. And it's really actually, a lot of moral boosting for all of us that there is so many enthusiasm on actually, publication and doing research work on pediatric nephrology. So hats off to the delegates. Please keep it up. And we will expect more and more abstract and research work in pediatric nephrology in future.
So next we go to another session that we were eagerly waiting for. The quiz session, no? Yeah.
Before
Quiz
we
session,
declare the winners, we need to identify people because their usernames are different. And I also need to know who is a PG and non-PG as well.
We are calling not on rank or anything. We are just calling few random
Will be
names.
just random some names. We need to identify your original name and also PG and non-PG. Magical Rhino. Kese.
বোধহয় লজ্জায় হাত ওঠাচ্ছেন না
Magical Rhino.
No.
You can put. Then you can change it, but Magical Rhino is K.
So if you can show also, because if you show that it is magical rhino yourself, then also
Yes.
we will.
Yes.
So
Otherwise
nobody is
it's difficult to
claiming.
identify who is
আমি
Magical
তো
Rhino.
রাইনোর মতনই দেখতে অনেক
হ্যাঁ ঠিক আছে কিন্তু পাবেন না স্নেহা দাস
আমরা স্যার র্যান্ডম ডাকছি না rank
না
নেহা দাস কে
we are just identifying তুমি পিজি না নন পিজি yes sir ঠিক আছে we are just identifying people, we are not declaring the results চিনতে হবে তো আগে তারপর তো তাহলে ম্যাজিক্যাল রাইনোকে চিনতে পারিনি ওকে ডক্টর রাঘব গোলচা
কি তুমি কি
পিজি
পিজি তো I don't know
হাততালি এখন না বাজাতে
হাততালি এখন না
be winner, we are just
আমরা এখন টিআই প্যারেড করছি চলো আস্থা আস্থা
sir, if they are not present, we won't give, sir, in case if they are only present, they are
তাহলে আস্থা অ্যাবসেন্ট কাটা গেল বাদ গেল আচ্ছা কোথায় গেল ঋতদীপ नॉट टू आनंद गुप्ता
तो चले गए वे तो फैकल्टी हैं आनंद गुप्ता फैकल्टी हैं
त्रिजीत दास he is a PG or non PG PG okay fine বাট না ওর ফ্রেন্ডসরা তো আছে নিশ্চয়ই
আচ্ছা ওটা পরে আগে তুই এটাকে সর্ট আউট কর তাড়াতাড়ি বাড়ি যাব
এক সেকেন্ড কি
or the other thing we can do is we can do the ethics and then
আচ্ছা দাঁড়াও দেখছি ভুল হয়ে যাবে আচ্ছা এম গুপ্তা
is there.
হ্যাঁ আছে পূর্ণা ঘোষ
PG
ঠিক আছে উৎকর্ষ
কি PG তে কি
পিজি ওকে আস্থা নেই আস্থা শ্রীনিধি পিজি আস্থা তো নেই
Asta was there just
জে স্নেহিল না হয়নি এক সেকেন্ড হয়নি এখন হয়নি জেনারেল আরো নাম্বার
অনিমেষ অনিমেষ
অনিমেষ?
কি তুমি
Done? Because before you announce the result, I have got some something to say. So the space. I would
Sir,
like
एक
to-
second, sir, एक second, sir. Croc. CROC croc. Huh? Shreo. Shreo. শ্রেয়টা কোথায় গেল?
you are not here now can you show your first second third your third come up evidence with evidence
Before you announce the result,
announce it sir cost checking
third means? Anyway, while he's cross-checking, I would like to thank the whole quiz team. So there was two part of it. The audience quiz, it was helped a lot by Niladri, along with all the faculties. And for the overall for the quiz, I'd like to thank Dr. Tathagata Bose. He supervised all of this along, and then there is Dr. Rohit. Rohit, I am sure many of you will be knowing him. Like he is becoming a national quiz master. So Dr. Rohit and Dr. Niladri Bose again. So a special thanks to all three of them. Niladri, too much of suspense.
आप लोग बहुत जो क्लिक किए ना वो है अपलोड जब अपलोड हो रहा था तो बहुत लोगों ने वो क्लिक किए जो दिखा रहे हैं जैसे you finish first you finish second it is coming as they are the real person many of you clicked that time it is uploaded it was going here and there so the person who is coming with first and second is the real person you can many a time you just clicked when it was calculating so that snipping shot is not the result the result will be like you finish first.
Anyway, for the result, Quizmaster is the final. So whatever, yeah. So let us go ahead, please.
PG says.
So I would request all of you not to leave because they are calculating the result and who knows, one of you might be the winner. And there is a huge prize waiting for you. But till they are calculating, we will go to the last session of today. And I have, because we are all running late, we will be doing it for 15 minutes on ethics. So, Deblina, if you can do that.
So this last session, I decided that it better be a open discussion rather than a didactic lecture. So here I'll be presenting 4 case scenarios and I'll be asking the experts in the audience about what to do.
So I would request Dr. Karvi, because I just learned that she is in the NUH ethics board. So if you can have a chair here.
So our first case is a 10-year-old male child. He is a case of quadriplegic cerebral palsy and he is non-ambulatory. He was diagnosed with nephrotic syndrome with initial steroid resistance and this will be CNI resistance as well. And when we did a whole exome sequencing, we found that there were no pathogenic variants related to the phenotype and the child eventually landed up in ESKD. The family background was that this was a single child of his parents. Father works at a private firm with an earning of 20 to 30,000 INR per month. Mother is a homemaker and mother takes care of the child at home, and so far they have been very nicely compliant to treatment. Problem is the child now has to be started on dialysis. The parents are not affording for peritoneal dialysis, so this was at a time when this PD bags were not being given free of cost in the government hospitals in West Bengal. So they could not afford PD because they could not afford to buy the bags. And they were not willing for hemodialysis also, and they opted for palliative care knowing the consequences. The child at that point of time was already under a government scheme. So why they did not want to go for HD? Because as per the mother, the child was around 10-year-old. It was a fully grown-up child who was non-ambulatory. Father, being in the private firm, cannot miss his job, and he has to undergo hemodialysis three times in a week. So the mother has to carry the child all the way from her home to the hospital, and she decided that it was not something possible for her. So they decided against HD and they opted for palliative care, knowing the consequences fully well that the child probably will not survive if the child is not subjected to renal replacement therapy. So in this case, what should we do, ma'am?
If I can take over. So basically, what is the problem here? We have a child who is a quadriplegic cerebral palsy and now has gone into the end-stage kidney disease. If we should we start dialysis in this child? If we start a dialysis, as we all know, that this child, the dialysis is not the end game. You have to go for a kidney transplant. So will this child be eligible for a kidney transplant? And in our society, what should be done? How it should be done? So I would like to have a comment from the audience first, and then maybe Dr. Karvi, because her socioeconomic situation might be a bit different from ours. So the audience, anyone, including the experts? Sakil?
So considering the neurologically impaired child, this child with such a low socioeconomic status, so renal transplant should not be the something that should be considered. And that's what I have learned. Even in AIMS, if you have children like that, they would go against planning for renal transplant. And palliative care, maybe after consulting the family and continued therapy as what they are giving, should be continued. But very unfortunate, but for a country like us and with the kind of patient selection, this patient is not fit for renal transplant.
So I would like to have a comment from our seniors like Susmita Di Paharida, whether they agree with it, that Parida, would you give, what would you do in this child? Would you offer this child? Would you offer this child peritoneal dialysis?
I think, in a child like this, of the renal replacement therapy that is actually, going to be available. And nowadays, with the situation where which way things might head in the form of transplantation very soon, I will definitely counsel the family regarding starting on peritoneal dialysis if they're not keen to actually go for preemptive renal transplant.
So, so we have got two scenarios. One scenario is that the child doesn't have any money, there is no state support. Then what would you do? Child has money or there is state
Even
support?
if there is no state support, it's very important for all of us to know here. Even if there is no state support, there is a lot of NGO bodies that are working and often coming up to help a family like this kind of dilemma, at least with financial support. So as pediatric nephrologists, what we need to do is actually counsel them about the various options that might be having, and we might need to be doing crowdfunding for them to go for actually the best possible treatment option for them.
Any
It's
comment
actually
by-
at the end of the day, it's actually going to come on us, and how we counsel them. The most of my parents at least are actually going to take the decision how we counsel them.
Any comment by Susmita ji?
What is the cognitive status of the child?
Ma'am, if the child
What
is
is the
like,
understanding?
ma'am,
Can
the
we
child
get
is severely
accent?
developmentally,
Severely
yes,
developmental,
yes, ma'am. Microcephalic, completely non-ambulatory.
So I would not, I would not force anything on this family.
No. Question is not forcing. Would you offer or not?
Definitely you have to offer because
Because
the
Sakil
option
will,
is there.
Sakil will not offer.
The option is there. You have to tell the family the options. You have to tell them the pros and cons that are involved with dialysis. And then it is a decision that you have to take jointly with the parents.
One comment here. One hospital being nearly burned down and closed because they didn't offer proper service to a child with Down syndrome. One cardiac doctor was actually brought into the court because he didn't do the cardiac surgery because the child had Down syndrome. So, the neurodisability and disability affecting the other symptoms and ultimately affecting the quality of life, we can only judge. But at the end of the day, it's parents' child. We can only counsel them and giving all the best possible option for them to consider what is going to be the best. As clinician, we have to offer what is best for the child's renal condition.
Dr. Karhil?
Okay, this is exciting.
Unfortunately, we don't have that much time.
Okay, so just like how we approach a case as a physician, we have history, physical exam, investigations, then management. So we have a certain structure of approaching a case as a doctor. So similarly, when we want to approach an ethics case, there's also a certain structure. So the first thing you need to do is to identify what is the medical indication for this case. Medical indication for dialysis, transplant, or not doing anything, right? So these are the three options that you have right now. If you just take away all social context and everything and just look at the child's medical condition, and that is your first part here, just like history, that's your first step. What is the indication for dialysis, for transplant? How does it integrate with the fact that there is neuro disorders? Is there anesthesia risk? So you consider the indications and the risk of the three options that you have for each kid, just medically only first. So that's first step. Second step would be the preference and the autonomy of this patient. So in this case, this is a child who apparently is not mentally competent, right? From what I understand. So we need to decide who has the autonomy to decide. It's probably the parents. So the autonomy of consent goes to the parents because they are the legal guardian. So we will have to respect the preferences and the values and the perspectives of these parents because they have the autonomy of deciding, as Doctor said, right? So that is autonomy and preference. So that's step number 2. Step number 3 would be the quality of life of this child. So what is the underlying quality of life right now? If you give dialysis, what would be the quality of life? If you give transplant, what's the quality of life? So you do need to consider that with the parents, because it could be that even though the child is having cerebral palsy, but maybe he's having good quality of life because he could still interact with the parent by eye contact or whatever, and the parents is still deriving pleasure with having the child around, right? So even if you can't do transplant, but if you do dialysis and you could extend the life by a couple more months or years, and there could still be good quality of life between the parent and the child, is it worth it? Maybe yes, from the perspective of the parents and their values, it is something that they still want to go ahead, right? So that is the values, the quality of life of the patient. So that's step number 3. Step number 4 would be the contextual factors relating to this case. And that's where we talk about money, we talk about justifications, because, justice, because you may be taking resources away from other patients and stuff like that. So if you analyze each case according to each of this structure, then it becomes a bit easier to approach the case and give the options and talk to the parents. It's just my 2 cents worth. Thank you.
So very difficult thing, no? So as you can see, Sakil might be feeling that maybe he was wrong. But then in India, money is also important. We have seen children whom we have supported for kidney transplantation, supported for dialysis, but then we could not find money for the support of post-kidney transplantation complications. And in front of us, the family spent everything. There was a post-kidney transplantation complication and the family spent everything, and ultimately the family became like much poorer. Child also couldn't survive, and I remember Deblina saying that why are we doing kidney transplantation?
No, I did not say that.
Yeah, almost like that.
Like that. I said that if we are doing kidney transplant with the help of NGOs who are able to provide them the financial support only in the peri-transplant period, but they cannot support in the post-transplant period.
So when any of the NGOs, that's why cardiac NGOs like cardiac surgery, they get so much of support. Why? Because they support the surgical part. Nobody will support you a long term. Dialysis long term. Every month, if you are on a peritoneal dialysis, 20 to 30,000 rupees at least. Hemodialysis maybe a bit less. How long? Then we have. I think we will stop here only. But like on this case only, because I mean ethics itself is a very exciting topic if done, and we will do it maybe next year on the ethics on pediatric nephrology. But if we have a child who is ESRD, and we said that we will do your dialysis free of cost. Family says that you are going to do the dialysis, hemodialysis free of cost, but for doing the dialysis, I'll have to come 3 days a week. For that, the father will be losing that day's earning. What will happen to that? Then I said that, okay, we will try for a Sastro Sathi, which is our like a government scheme for maybe peritoneal dialysis, and then go for kidney transplantation. Then mother asked me that after kidney transplantation, would I have to do regular follow-up? I said yes. And how frequently? I said like initially almost alternate day, then weekly, then monthly. How can I come? Who will be supporting my family? Government will not be supporting all that. No, NGOs will also be supporting all that. So for pediatric nephrologists, these sort of cases are really very frustrating and difficult.
But I think in this particular case, I don't think it is very complicated, because you have already stated you looked at everything, and the parents, after hearing everything, have come
okay,
to a
I will make this case a bit complicated.
No, don't make it complicated.
Now the families, now we have decided we want to go for a dialysis, transplant. Suppose I said we'll go for a dialysis, transplant. Who will give the kidney? Mother is saying no. Father is saying no. How far am I justified to get a kidney from the cadaveric system for a person who may not have that good quality of life? We don't have that many kidneys. Lot of ethical questions. So this was a very, sorry Deblina, I have to stop her. This was, I again apologize that we could not keep it in a long, prolonged discussion, but this is very important and hopefully sometime in the future we will cover it. But this is very important, the ethics of doing a dialysis in this sort of children or even normal children who are not having a financial support, the ethics of doing kidney transplantations and all that. Thanks.
Only we close it.
These are unsolvable.
There will be, continuous ethical dilemma in children who are actually having this kind of problem. And it will be actually really needing individualized decision, as Dr. Karhui mentioned, taking consideration of all the facts and discussing with the family. And still there will be ethical dilemmas which are often not solvable.
Yeah. And I don't want you all to go sad feeling from pediatric nephrology. So now we will have the cash prize.
Cash prize for the winners. Rohit.
Thank you, Dr. Karhi.
Before we announce, we need to identify a few, like who is SS? 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 একদম না পিঙ্গু পিঙ্গু মানে that is why it is making us very difficult. পিঙ্গু আছে পিঙ্গু পূজা
পূজা আছে পূজা
পূজা
কি আপনি ম্যাডাম
ম্যাডাম প্র্যাকটিশনার তো এই মরেছে
এইবার স্যার কিছু বলার নেই
পি ডাবল ও জে
নেম আর রিপিট করুন
ওনার হবে অভিষেক মাঝি কে আছে আচ্ছা দাঁড়াও এক সেকেন্ড হয়ে গেছে
So for practitioner, third is Purna Ghosh. Dr. Punya Ghosh, third for practitioners. Non-PG group. No, ma'am, in that also, PG is also answered. So that is why we found, it took so much time. Rank is there in system. So many congratulations. Second though. No. Then second is Abhishek Maji. Your SR. Second in practitioner, that non-PG group. General quiz, though 8 questions. Those 8 questions. No. First, okay? First is Pooja. Dr. Pooja. But issue is, ma'am, in this, the rank is all the clinicians only majority participated in that. PG is not part. We told once. Yes, ma'am. That is why this rank is like this only. Next is in P. So PG, third is Shreya. You only showed now that third rank. In that is name written as a. You are. Okay. Second is Ritodip.
Guys.
First is M. Gupta. M. Gupta.
Requesting all the 6 winners to come on the dais, please. Along with that, our one and only Dr. Rohit. And Bose sir, please.
Can I ask all the prize winners to just introduce themselves?
I'm Dr. Pooja Nandi Anand. I'm a practitioner in Barashat area of Kolkata.
I am Dr. Abhishek Maji. I practice in Purulia.
I am Dr. Shreyoshi Ishen. I am third year PGT of MD Pediatrics in Calcutta National Medical College and Hospital.
I am Dr. Hitodip Nandi, second year MD Pediatrics, ICH.
I am Dr. Manthan Gupta, DNB PGT, second year, Amri Mukundapur.
I request all the faculties as well as the delegates who have been here till now, sab aa jaiye. All come around here.
I would request Tathagato sir, Niladri and Rohitda to collect the memento from the memento corner after this given. Tathagato sir? রোহিতদাকে দিতে হবে এখানেই দিয়ে দিন না স্যার এখানেই দিয়ে দিন স্যার ওখানে যেতে যেতে লোকে চলে যাবে এখানে দিয়ে দিন
You can come this side. ডক্টর রোহিত এখন যাবেন না মেমেন্টো নিয়ে যাবেন মেমেন্টো হ্যাঁ